Hello, good morning everybody. We are going to start our session right at 9:30. So I'll request the moderator and the panelist be here. Welcome to 18th Howrah Pedicon. So we'll be starting our session with a panel discussion of vaccine. It will be moderated by Professor Kripasindhu Chatterjee. And I request moderator Dr. Kripasindhu Chatterjee to come over the dais. Expert opinion will be given by none other than Dr. S.G. Kasi. Kasi sir, please. Panelists are Dr. Kaushik Chakraborty, Dr. Joshi Anand Karketta, Dr. Shomik Hajda, and Dr. Shoma Mitra. And for it, the chairpersons are Dr. Prosenjit Ghosh and Dr. Shanti Gate. So Dr. Prosenjit Ghosh and Shanti Gate, please come here. Kasi sir, please take your chair, sir. Either. Sir. Dr. Prosenjit Ghosh, are you there? So I will request all the panelists to come over the dais. So, Dr. Shomik, Dr. Karketta, Dr. Shoma Mitra, and Dr. Kaushik Chakraborty. Torun, please stop the breakfast right now. So let everybody enter into the hall. Dr. Chatterjee, please come here and start your session right now. Your time starts now.
Your TV is not ready.
It will be visible from there. Please start.
প্রসেনজিৎ দা স্যার বকবে, তাড়াতাড়ি চলে এসো। প্রসেনজিৎ দা তাড়াতাড়ি চলে এসো, নাম ডেকে দিয়েছে, রোল কল হয়ে গেছে, অ্যাবসেন্ট হয়ে গেছে, বসে পড়ো। Can I start? Hey, do you have slide changer or through keys only? Slide changer আছে? এক মিনিট স্বপনদা বলে দিচ্ছি। অফ আছে।
Hello. Dr. Ghosh, please start the session.
Okay. Thank you, everybody. Now again, we meet regularly, annually, all Howrah people as well as Sir Professor Kasi as well as our fellow pediatrician of all over India and West Bengal. Now, these are sessions of vaccines, and we all know vaccinology has come a long way since Edward Jenner's pioneering work on May 14, 1796, when he conducted the first experiment with invention of smallpox vaccination. And its continued advancement has saved countless lives and protected public health. Now, in this inaugural scientific session of vaccines, I invite Professor Kipashendu Chatterjee as a moderator of this session. Dr. Chatterjee has needs no introduction. He's known to all. But still, it's customary to say something. He's now the professor and HOD of Gauridevi Institute of Medical Science, Durgapur, and he's the author of 8 textbooks of pediatrics, as well as he has published 34 international and national journals as well. So now we get Kipashendu Chatterjee, and as well as our sir, Dr. Kasi. Now, Dr. Kipashendu, start the session, please.
Thank you, Chairperson, sir, for your introduction, and thank you, Howrah Academy of Pediatrics, for inviting me. I'll just take 1 minute to introduce my favorite, my teacher, my guru, Dr. Kasi sir over here. So, I was going to attend, just 1 minute I take from the organizers. I was going to attend the Vaccinology TOT in Nagpur, Pedicon. There I found one person who is having a handbag like a Santiniketan bag over West Bengal, and a very simple dress. The shirts are not well maintained anywhere, but is speaking so boldly and so confidence and so clarity. It really touched me. I went to sir, amongst everybody, sir, I want to talk to you later on. Can I get your phone number? I'm one of the participants over here. So sir said, yes, you take my phone number. I took it. And in the next 1 or 2 months, Atanu Bhadro sir asked me, in Coalfield branch, you want to make a vaccinology CME, a vaccinology panel discussion. Who would be the moderator? I mean, you can invite Kasi sir. He's the best person. So he told me, you invite. And sir was having cataract operation at that time. So after much discussion, he agreed. And that was the beginning of a long story. And sir has become part and parcel of our any of the vaccination, not in West Bengal, not in Howrah, not in Kolkata, throughout India, and also he is the now international expert in vaccinology. We are really blessed to have him here, and for everybody's acquaintance, I tell you, we all know his Dr. S.G. Kasi, he is a Srinivas Gopinath Kasi. That is a full name. So I am blessed with a good bunch of young panelists who are very much enthusiastic and very much interested in vaccinology. Kaushik Chakraborty is come from Makura Medical College, and Joshi is the head of the Mission Hospital in charge of Pediatric Department. Somik Hajra is a very, very good academician, ever agile, good practitioner. He's completed MRCP also recently. And Soma is in Sarchandra Medical College, very young guy, and I think it will make a very good panel discussion. I'll request everybody to be very crisp and short, because otherwise we have to stop, because you see the organizer's mood. They'll stop me any moment when 40 minutes will be over. So going straight away into the questions, first panelist, Dr. Kaushik. So vaccines are integral part of the pediatric practice. You know, without vaccinology, without vaccine practice, it's very difficult to practice pediatrics in your office practice. We'll be concerned with the office practice, obviously. And here the difference is that those patients who are coming to you, they are having some sort of problem. For that they have come and they want the solution. Here for vaccination they are coming without any problem to prevent some problem that may occur in future. So any problem developing to this, healthy child would be more traumatic for the parents and would create more problems. That's why vaccinology knowledge is very, very important, very, very pertinent over and above our knowledge of medicine. So, Dr. Kaushik, this is your case. First one is a full-term baby of 3.2 kg was developing normally till they came at 6 weeks of age for your first vaccination, and you gave the pentavalent vaccine or hexavalent. Here is the pentavalent. Developed fever for 1 day and recovered well, and in the next 4 weeks down the line he came for second dose at 10 weeks and developed high fever for 8 hours, followed by single seizure that lasted for 1 minute with complete recovery for 10 to 15 minutes. There is no family history of epilepsy. So what do you think about this?
So before going to the mainframe, Hare Krishna, good morning to everyone. I am very much fortunate that I am sharing the dais with Kripa sir, Kashi sir, and with all of you. And this is quite funny and childish that I am seeing my name in the front of the academic itinerary. So this is a case. So simply, this is scary. Anything, if it happens in a healthy child, this is scary. So this is very difficult to counsel the parents. In this situation, this is simple febrile convulsions. So we have to consider what will be the next dose. Whether that will contain the whole cell or acellular or will delete the P component. So my choice, first choice will go for the acellular component.
Kaushik. Then you just discussed something about what the incidence of febrile seizure in WP, whole cell pertussis or acellular pertussis.
Okay, sir. So this is some numericals, little bit clumsy, but very important and interesting slides. If you look it very carefully, I'm dividing into two parts, acellular component and whole cell component. There are different mild, moderate, severe fever gradations. If you go downward, you can see that in the acellular component, the severity, the incidence rate is decreasing. And in the subsequent vaccines, the incidence rate of the fever is also increasing in acellular components. This is also same for the whole cell vaccines, but the numericals are quite larger in comparison to the acellular components. So by and large, the fever and the complications by the seizure, encephalopathy is little bit in the lower side for the acellular component, but this is quite in the higher side for the whole cell vaccines.
So Kaushik, what will give? Whole cell or acellular
so
or,
for this,
or DT only?
In this scenario, for my first preference will be on the acellular component. Then I can opt for the whole cell, but the first preference is for acellular.
Why not whole cell?
If you look at the slides, all the fever, the incidence of the fever is more, incidence of the seizures are more, encephalopathy, there is no such documentation for the cellular component, but still there is some incidences of the encephalopathy in case of whole cell.
First dose of whole cell makes a good priming. That's what Kashi sir tells every time.
Sir, definitely, sir. That
and then if you give acellular, it makes a good impact. So that's why you can give acellular also, but you can give WP also here. Exactly. Because usually these complications do not recur in the subsequent dosage. So you can give the whole cell pertussis also, depending after your discussion with the parents, then only you decide what to do. According to their mood, you can give both. So this is another one, again for Kaushik. So this child, again in the same scenario, now in the second dose, patient developed at 10 weeks, developed high-grade fever, followed by multiple seizures. Was very difficult to control. Patient required multiple anti-epileptics. Now the parents are still very, very worried. This is a second scenario, obviously not the same patient. Now you want to investigate, how will you investigate and how you will reassure the parents and what will be the next course of action?
Definitely, this is a scary situation. Patient has to be admitted in PICU, very difficult to control and counsel the parents. Always look for the other alternatives, septic screening, neuroimaging, metabolic screening, because there are numerous rare metabolic causes that may lead to that kind of repeated seizure episode. But if that kind of neuroimaging EEG will not get anything, always we have to look for some rare causes. And on follow-up, we have to look for some rare causes like Dravet syndrome. So this is very rare. It happens actually.
So you feel it's a case of Dravet syndrome?
Straight away I cannot. After ruling out all those things, we can, after going through the genetic counseling, genetic mutation test, if it's coming like this SCN1A, that is very much specific for the Dravet syndrome. This is rare
What is
epilepsy.
Dravet syndrome? It looks very complex.
In few lines, just I am describing. This is very complex and rare epilepsy. So here the exciting point is fever. What happens over here, there is some abnormalities in the sodium channels, and here the nerve cells are very much sensitive to the fever. So fever is the most common offender to produce the Dravet syndrome. So any situation which will produce the fever may lead to this kind of Dravet syndrome. And here the seizure, this is very difficult to control. After giving multiple anti-epileptic drugs, that will not come in control. So what happens over here, cytokine surge used to take place. And here they are more inflammatory than the anti-inflammatories. So very briefly, these are the Dravet syndrome, though rare but scary situations.
Basically, it is a sodium channel disorder with cytokine propensity to cytokine surge. It is genetically predisposed. Vaccine has got nothing to do except for the initiating the first event. Otherwise also patient would have developed this, but maybe the vaccine has led to the earlier initiation of the syndrome. So that's it. Yes, you want to tell something? Please.
Actually, I want to ask something. First of all, let me introduce myself. I'm the youngest person sitting here, I think, and I thank all of my senior faculties for this opportunity. And as I know that from the text that Dravet syndrome was previously known as a vaccine encephalopathy. So first, in the 12 months of infancy, it presents like a complex febrile seizure, and after 12 months, it changes its course to like myoclonic seizures and all. Now, once I want to know that once we are diagnosing a case as Dravet syndrome, the child will again have its vaccination next so is it prudent to since the trigger is
I will
only
come later. We'll come later.
Okay.
You'll get your answer. So what is your advice regarding further vaccination of the child? That is what Soma was asking.
Again, counseling is needed. Pertussis vaccination definitely may trigger the onset of the Dravet syndrome. But vaccine is not only the offender to produce the Dravet syndrome, there are numerous causes. So we should not stop the vaccinations. Always we have to take some cautions. We have to take some in-house vaccinations also. Always take extra cautions for the live vaccines, but continue the vaccinations as a routine. Even the MMR or varicella may lead to that kind of symptoms also. So by and large, vaccination has to be continued with caution.
So parents are asking your choice. Now they are now confident, yes, you can continue the vaccine, but whether they will give DT, DT-AP or DT-WP.
So definitely the risk of subsequent vaccination associated seizures was significantly lower for the acellular component in comparison to the others. So always we should opt for the acellular component and non-P component in comparison to the whole cell.
Excellent. So any question, can I move to the next part? Sir, please.
I think in a situation where you have a choice of WP and AP, AP is considered as a safer, more modern vaccine. If you offer the WP to that patient, you have to be very sure that you have explained all the pros and cons of taking WP vaccines. Now in this first situation, if you are given WP without explaining, he develops a seizure, and then you say, no, we'll go for AP because it's a safer vaccine. They are going to hold your scruff of your neck and say, no, why didn't you give this vaccine as the first dose? Why did you choose a vaccine which is more reactogenic? So I think it is communication. First dose of WP, explain everything. Better long-term protection, whatever adverse effects, it's the minor adverse effects which are more. Serious adverse effects are almost the same with both AP and WP. I think you have to be very clear in explanation when you give it to the patients. Thank you.
Thank you, sir. Sir, this point we will touch upon in next part. And you are very, very pertinent, and sir, as you guide us every time, it's really a need of the moment is communication. Yes, whenever you call me, I will stop. Yes. So, Dr. Joshi, what about the consent? I mean, is it consent required for giving vaccination? you need to sign the consent, you need to document something, or it is not needed? What is your view on consent when the patients are coming for vaccination? Parents are bringing their children for vaccination.
Good morning, everybody. Right at the onset, I would like to thank Howrah Academy of Pediatrics, Dr. Abhijit and all, for inviting me over here. So, coming to the question of consent, I think in our practice now, we all know that communication, like what sir said, communication is the most important. Whether it is vaccine or anything, any other treatment, it is communication. And communication of what is information. So how much you inform the parents and how much there will be always a class of patients or parents, caregivers who will have their own views and ideas. So how much you can convince them about the best evidence-based vaccine which is available for that particular child will be a little tough. But you need to spend time. Otherwise, there will be maybe like the cases we have seen 1 in 1 lakh cases, or maybe even half. It will be less. So I think I'll follow Dr. Jog's abbreviation. I think it's easy to remember Nescafe. Everybody has a cafe or coffee in the morning. So remember the Nescafe. N is for you explain to the parents or caregivers about the need for the vaccine. E is for efficacy, how efficacy is, and for that child, how good it will be and what are the other options. S is for safety and side effects. Other S is schedule, what schedule you're going to follow. C is for the cost, which is going to play a big role, especially for private practitioners. A is for any, you have to explain their doubts or whatever they want to ask. And E is any ethical considerations like was being discussed earlier. So if you remember these, if you cover all the topics of this Nescafe, I think you will have everything. Coming to the point whether you want to document out this, I don't think there is any need for actual documentation of in a written way, but there are many practitioners who do follow written consent forms, but informed consent or a verbal consent is more than enough. I think best is to have small leaflets on each vaccine separately available, so that before they enter your chamber, they have an idea about meningococcal vaccine or pneumococcal HPV vaccine. Other vaccines, so anyway, most of them are being covered in the government sector.
Thank you. Actually, this is a very controversial topic right now. I will ask opinion from Kasi sir after I finish regarding this. So I was attending on medical legal webinar a few days back, where the medical legal experts were there. As per their view, yes, you do not follow this not required. Not required is not there. At least you should have printed sheet of adverse effects and efficacy to some extent that should be handed over to them. And while giving vaccine, you should at least mention that vaccine was given after informed consent, and what is the route and what is the brand of the vaccine. That should be written on your prescription, and that should be signed by you. So, and if the adverse effects are written and you can hand over that, or it is printed on your vaccination card, it is some sort of safety. Otherwise, court will ask, yes, verbal consent, but you have not explained. You cannot prove that you have not explained clearly, because there is no audio clip in each and every patient for you. So that's why it should be written there. That's what their opinion is. Sir, your opinion, please.
Thank you, Dr. Prabha. See, as far as consent is concerned, a normal healthy child being brought to your consultation for a vaccination with your vaccination card is an implied consent. So for routine vaccination, we follow the CDC criteria. There is no need for a written consent. It is an implied consent. But that implied consent also implies certain obligation on your part, a proper information about the vaccine, efficacy and adverse effects. Now, what about adverse effects? Now, before giving rotavirus vaccine, are you going to tell them that interception is a side effect? No one is going to take it. So, you are obligated to tell them the very common and less common side effects. where any side effect whose incidence is less than 1 in 100, you are not obligated to give information. However, before giving rotavirus, it would be nice to tell them that in case excessive crying, blood in the mucus, come back to me again. You don't have to tell them about the interception. So I think this way you have to be sure that the patient is aware when they should come to you immediately. Only if you are giving vaccines off-label for some extent. Say, for example, a 30-year-old woman comes to you and tells you, I want to take the Gardasil 9. It's not licensed for 30 years in our country, but all over the world it is licensed till 45 years. In this case, you have to take a written consent and then you can give the vaccine. Okay, so only in certain situations, even in immunocompromised children, see, there are indications for giving live vaccines in a child with leukemia, especially the varicella vaccine. In such a situation, it is better to take an informed consent. Otherwise, in routine day-to-day practice, no written consent.
Subrata, you wanted to tell something.
See, I totally agree with Dr. Kashi, what he said. Actually, it is important to know, it is very important where you are practicing, the perceptions of the people, the cultural status of the people. So, asking a consent to everybody, it's not at all necessary. What is not at all necessary? That could be counterproductive. See, now our priority is to vaccinate the children. So vaccinate the children. I have seen even erudite parents say they are not interested in what vaccine they're giving and what are you doing. They're not interested. Even, see, I practice in a Salt Lake area where, say, the majority of the parents are erudite. For one single state, whenever give HPV vaccine, even the students, the girls who are students, 11 or 12, I ask them, what is the vaccine? Why are you taking? They say, because the parents are asking. So it is the status there to go by implied, I mean, see, rightly you said, sir, implied consent. By consent is not at all necessary. So, so you were talking, Krish, about the legalities. So, say, it is the legality. See, even today, as we stand today, our practice is practice of trust. You cannot compare it with the developed nations where, say, for each and everything they go by consent, they explain. Rightly you said, sir, we must say what vaccine we are giving and why we are giving. And if there are significant, adverse effect, we should say that. Otherwise, it should be the practice of trust. It should be practice of trust. Of course, it is very important that you write down the vaccine in clear words. The majority of the immunization guides see just it is messing up. They will say they writing down the vaccine, then sticking the sticker there only. It is not like that. You take a separate sheet, clearly write down what you are giving, put the date, put the signature, and in a separate sheet, you put the stickers. And say a few words, that is enough. So I think that should go. So the discussion on all this is very important because we need to improve everything, but otherwise it is better. Thank you.
Thank you, sir. So thank you, Subrata, for your comments, and it's really need of the hour anyway. So continuing with our discussion, I'll request everybody to be a bit short, otherwise only 15 minutes left. So this is a case scenario for Dr. Joshi. So mother has got cervical cancer, and the father has brought her 14-year-old daughter for HPV vaccination. I recognize the presence of our National President-elect Neela Madam. You are welcome, Madam. So 14-year-old daughter for HPV vaccination, and she refused. That happened twice again. He was brought and she refused. No, I won't take vaccine. I won't take vaccine. Third time now father brought with two uncles or two similar people and said, doctor, you give the vaccine, we will catch hold of my daughter. I have to save my daughter. She will tell anything, but you have to give vaccine. We are ready. gave the vaccine. And the girl started shouting, sitting on the floor. Now, this is the situation. What you will do? You will force vaccination, you will restrain parents, you will restrain the girl, or what you will do? It's a very practical scenario.
First of all, you should remember that she's a 14-year-old girl, so definitely she's a minor. We'll definitely need consent from the parents, but her consent is definitely will be this one. But I don't think we can directly force her to take a vaccine. We have to try to convince her to the best of our knowledge and abilities. Legally, we may be correct, but ethically, we may be.
Actually, this question originated by my vaccine guru, Dr. Kasi sir, and I'll request him to answer it very
Thank
clearly.
you. Actually, this happened in my clinic. That's how I made this case scenario, and it has been discussed on quite a few occasions. A 14-year-old girl legally in our country cannot give consent, but ethically assent from her is necessary.
Yes.
Okay? Assent is not legally valid in our country. It's valid in many other countries, Western countries, but not in our country. So in an ethical dilemma like this, let us go back to the principles of medical ethics. The first is beneficence. Is this act going to benefit the child? The answer is yes. Non-malfeasance, that is, do no harm. Is not giving the vaccine going to harm the child? Here is a question mark. If you don't give the vaccine, yes, she may develop cervical cancer and succumb to it. The third is autonomy. It is essential that the vaccinee, if old enough to give assent, should be given the choice of taking a decision. And the fourth important concept is the concept of justice. Justice is, if I don't give the vaccine to her, will it harm the community? For example, say there's a measles outbreak, and a teacher in that particular school says, I don't want to take the measles vaccine. Here, her not taking the vaccine, if she gets it, can communicate to the child and constitute a risk to the community. So there she can be forced to take the vaccine. So there are certain overriding principles. So in this case, is not giving the vaccine life-threatening? No. You can always give it a little age after you have convinced her. Now, if you think of it in another way, suppose this was...
Sir, give your concept of mature minor over here.
Yes. Now, coming to mature minor is now a concept legally accepted in many of the Western countries, where, though not legally mature, that is still not 21 years, but mentally they are mature enough to understand and take decisions. Now, the age of this mature minor varies. In US, it is 12 years. In UK, it is 14 years. So, 12-year-old girl in US can go to the doctor and take vaccines, and she can even take advice regarding reproductive health without the consent of the parents.
Without consent of
So, this is the concept of mature minor, which is legally not valid in our country.
And in different states, it is not universal now.
And the second thing, as I said, is you have to look at the situation. Suppose this was category 3 exposure and the
Sir,
girl
that is the
refuses
next
to take.
part. So
Yes.
this is one, and
Oh,
next
yes.
part is this.
Right.
If it is rabies, what to do?
So, if it is rabies, then you have the right to give it to her forcibly. HPV, you can always wait, talk to her, and finally convince her. And this girl of mine in the clinic, really stubborn kid. I think after the 5th or 6th attempt, she agreed to take the vaccine. Thank you.
Thank you, sir. Thank you, sir. This is a very, very important lesson we should learn about consent and again, vaccinology. I think we will complete the first round only. And next part, Somik, your take on asepsis during vaccination.
Yeah, good morning everybody. Asepsis is important because it is an invasive procedure at the end of the day. So there the standard hand hygiene practice needs to be followed each and every time I am going to vaccinate a child. That includes 2 minutes of hand wash at the beginning as per the WHO protocol, alcoholic hand rubs for all subsequent vaccinations, and if I even find that my hands are dirty in between, I need to again go back and wash the hands for 2 minutes as per the WHO protocols. Gloves are not needed if neither me or the caregiver or the patient is actually suffering from a communicable disease. Otherwise, gloves, there is a problem with the gloves because it makes maneuver and movement a little difficult. So ideally, gloves are not required.
What is the difference between alcohol rub and soap water wash?
If the hands are visibly dirty, soap water wash is needed. Once there is a soap water wash which removes all the dirt and all the larger particles, subsequent to that, because I am in a set of chamber or a clinic which is reasonably not unsterile, subsequently I need to take care of the germs again and again and again. So for the subsequent...
Actually, alcohol is more effective against spores and
Yes.
enveloped viruses.
Yeah.
Because they are not taken care of by the
soap wash.
Soap doesn't kill any virus or any organism.
They will remove.
It only washes away. But the alcohol kills. That's a major difference between the two. Well, now, Sumik, another question. Now we, many times we put this spirit swab and then we allow it to dry. Unless it dries out, we stop and then we give vaccine. And that increases anxiety time of the patient, of the subject. Whether it is essential to increase anxiety and dry the alcohol on the skin or not. That is your take.
It is always ideal if the alcohol evaporates and it is dry. But waiting for that is not prudent. Because so long you are going to keep it, there is even chances of contamination after you have put in the alcohol swab. The alcohol has dried, but somebody has touched the vaccination site, maybe your assistant or somebody else. So it is not prudent to allow, and the little bit of alcohol that might be there on the skin is not going to interfere with the immunization process or the immunogenicity of the vaccine. So therefore...
so whatever remnant alcohol might be there possibly on the skin will not cause any change in efficacy of the vaccine. That is a summary message. So it is not necessary to wait because waiting time increases anxiety of the baby also. Yes. You have to remember that.
Sir, one point, say additional vaccine or MMR vaccine, we do not use alcohol swab.
You can. Actually, the process and the understanding of a safe vaccination practices changes over time. So now, there is universal guidelines that you can actually give an alcohol swab because the little bit of alcohol that is available even on the prick site is unlikely to interfere, be it a killed vaccine or a live vaccine.
Sir, remember just only one vaccine where you don't need any such swab, sterile swab, HBCG.
Message vaccine.
HBCG. Rest all we need. So next, another similar situation oh, sorry. I went back. Another situation, when I use a single dose vaccine, we remove the protective cover, then we wipe on the cap, then allow it to dry again on the similar procedure, and then we do a prick. So it is when the protective cover is there, the rubber is supposed to be sterile. Do you need to put alcohol there? First question. Second, whether again we need to wait for drying of the cap. So what is your take on that?
See, again, if it is a pre-filled company provided or the manufacturer provided cover, it is considered to be sterile. My hands are sterile, so I do not need to put additional alcohol after removing the stopper when it is manufacturer provided. It is not guaranteed. There could be chances of contamination. So if somebody wishes to put a bit of alcohol, again, that is fine. Especially when we are drawing in a standard vaccination practice, like we are taking up a vial, we are removing, then we are taking up a syringe which is not provided, then we need to actually apply the alcohol. And again, the time by which I am going to take the syringe and put it, the alcohol is likely to evaporate. There is no need to wait for extra hours, extra minutes or extra seconds just for allowing the alcohol to dry.
It's not mandatory for waiting for...
In case of multi-dose vial, yes sir, the standard vaccination practice or standard injection technique, you need to wipe in the second time and then you just draw it. There is no need to wait for 1 minute or 2 minutes to allow it to completely dry.
Thank you, Sumit. Now our youngest guy. So pain relief. What is your take on pain relief during children? Is it really necessary? Children do not feel pain, so we can give any vaccine straight away. You can catch hold of the baby, give the vaccine, and ask the mother to go. I have given the vaccine.
We pediatricians are not known for like that kind of. It always should start with sympathy and empathy, and moreover, we are not treating the child per se. We're treating the whole family. The parents are there. We should not do anything which increases the anxiety in the parents. Now, having said that, that should be taught to the parents as well as from our side as well. We should not panic first, and we also should teach the parents how to calm the child before we are doing the procedure, because the procedure is only going to take 5 to 6 seconds, but the story that is going to said before and after is going to make an effect.
Why I ask this question is that one patient came to me twice. I have given vaccine, child was crying incessantly, and third time he went to Soma. So that doctor, if the child cries so much, I don't give vaccine. If you can do something, do, otherwise I won't vaccinate. So now, what's the role of this? Obviously, fathers have got some role, parents' role. You have got medications, you have got physician's role. Would you elaborate on that?
Sir, first, that is so humble on your part. Having said that, parents, what they can do is, first of all, they can distract the child. The most important, I want to say, breastfeeding the child, and always try to calm the child first. Put the child to breastfeeding, then never make the child lie down. That is going to make the anxiety more.
That's
never
very
going to let the child lie down while you're vaccinating. Then if the child is not able to breastfeed or cannot, we can arrange for sweet sucrose solutions, and we can arrange, parents also can ask for some distraction, telling stories, mimicries and everything. And we should be very expert, we should have expertise on our procedure as well, because we will need to our part would be to distract the child, to have a very strong hold on giving a rapid plunge on the needle, and then rubbing, or that is what we say in physiology, gating of the pain. We can rub and do that to relieve the pain that is happening. This all we can do. After that, after vaccination, yes, we can definitely ask for this pharmacological therapies, like before the vaccine we can apply the lignocaine, the imla creams, but these are not very famous because they take long time to act. But it has also been seen that the ethyl chloride swabs that we are using just 15 seconds before the procedure also, they have been proven to relieve some pain on their part. And after that also, if the child is having multiple vaccinations, which I have seen mainly during the newborns or the infants during their 6, 10 and 14 weeks, we can ask the parents to have paracetamols after the if they are having pain sensations. I think.
Any point on positional comfort?
Yes, sir.
Positional,
yes, and
position?
When we are vaccinating.
What is the best position for vaccination of a small kid?
In the child,
on
mother's
the
lap.
mother's lap. On the mother's
And
lap.
Where we are putting the vaccine, we should try to flex and relax the muscle while we are giving it. For like deltoid, we should flex the elbow. For the vastus lateralis, we should right internal
Basic
rotation
thing is
should
that
be
we
there.
should remember, whenever we are putting any needle into a muscle, we should try to relax the muscle as much as possible. That will reduce pain. Is it?
Yes.
Yes, it gives a lot of psychological boost to the parents, not to the child or not to the physician, not medically. So I won't go for the next round. It's 1 minute left. So it depends. So there are only questions that are so much relevant in day-to-day practice. We are skipping those. I am requesting the organizers to give time for 4 questions only, one for each of the panelists. That will take 2 or 3 minutes. This is the first question. Obviously, it will go to Kaushik. Baby Samit, 2 months baby, was given first dose of DPT on 20th April. Earliest when you can give the second dose?
So for the inactivated vaccines, minimum interval should be 4 weeks. I am converting it into the days, that is 28 days. So we can reduce the interval 4 days, that is 24. But if we give it on the 23rd day after the first dose, that will not be accepted. But if we give it on 24th day, that will be accepted. So minimum gap is 28 days. 4 days, the permissions that is granted, but if we cross that limit, that is not acceptable. That vaccine will not be effective. So as per that rule, so that day will be next schedule will be 14th May most probably. Yeah.
Yes. Thank you. And this is a background knowledge for that. Less than 4 days makes the vaccine valid. If the gap is more than 4 days, it becomes invalid. So this is another question. 18-month Master Preetham received MMR on 15 June and varicella on 29 June. What is your comment? Are both the doses valid? Joshi? Both the doses valid? Which vaccine is invalid and when to repeat the dose? This is your question.
Here you should remember the gap between the two both of them are live vaccines. So the gap has to be at least 4 weeks apart. So the second dose, second vaccine should be considered as the invalid vaccine, and you have to repeat the varicella.
So varicella is invalid.
Varicella is invalid, and you have to repeat the varicella after 4 weeks of the invalid dose.
So 4 weeks after the invalid dose.
Yes.
Okay. This is the third question. 16-year Master Arindam's record shows 2 doses of TD separated by 1 month and 1 dose of Tdap given 4 months after the second dose. That is 014. So is it up to date? It is optimal?
Here, some of the components are optimum, some of the components are not. As per guidelines, the Tdap should be at least 6 months from the first dose. Here it is from 4 months apart. Therefore, the Tdap, the TD component of the Tdap is considered invalid, but the pertussis component can be considered as valid.
Why?
Because pertussis does not require the 6 months gap.
You have given a single dose of AP, that's why.
Yes. Yeah. And therefore, this child needs another dose of either TD or Tdap upon completion of 6 months from the TD dose.
Right.
At least.
Is it okay? And this is the last question. 18-month-old Somi's father is seeking your advice for vaccination. This is regarding card and record keeping. One card shows that she was given 1 dose of PCV13 6 months back, and father states that he had another card, but he's lost the card, where pickpockets and where influenza vaccine was given. Father states that another card lost due to pickpocket has records of 4th dose of PCV13 and influenza vaccine. So would you accept that? Suma?
Influenza can be accepted, but PCV, I think we should consider giving the 4th dose.
Why?
Because it is as per our guideline that if without undocumented history can only be accepted for influenza and the pneumococcal polysaccharide vaccines.
That's a CDC guideline.
CDC guideline.
Yes. Only influenza and PCV13, we can accept the parent's deposition even though it is not documented. Otherwise, what is not documented is not given. That is dictum as per Vaccinology. Kasi sir, any comments, sir? It's okay. Okay. Amita, you want to tell something? Please come here. And that would be the last question. I think Sapanda would be very angry after that. Because influenza is given every year and parents usually remember that, right? And PCV13, I don't know the exact reason why CDC had done that. Reason is not
it is
given.
not
Sir can tell
PCV13, it is PPSV23.
PPSV23.
PPSV23 because it's only given once. So patient will not forget. You can rely on the patient's information. That's
So
the
it
only
is not PCV13, it is PPSV.
PPSV, the 23.
So hereon I wrap the session. I really am thankful to the panelists and Kasi sir in particular for explaining these things so detailed. Because of dearth of time, I could not complete everything, but thank you, and thank you the audience and Howrah Academy once again for inviting me, and hoping that my performance is not very bad. I'll get chance here, in future also. Thank you.
Thank you so much for the session. I would request all the panelists, the moderator, chairpersons to be on the dais for the mementos. And I would request our chairperson, Dr. Proshanjit Ghosh, sir, to kindly give the memento to the moderator. Sir, একটা তুলে দিয়ে দিন, হাতে দিয়ে দিন, sir. I would also request Dr. Ghosh to please give away the mementos to Dr. Kashi, Dr. Kaushik. Okay. I would request Dr. Shantigir. Shantida, please give the memento to Kaushik, Dr. Shamik Hajra, Dr. Joshi, and Dr. Shoma. And I would request Dr. Kripa Sindhu to please give the memento to Dr. Gair, Dr. Shanti Gair. So, thank you so much. And with this, we move on to our next session, which is a panel discussion on. সবাইকে তো প্রসেনজিৎ Thank you so much.
One group photo of the whole
Thank you so much. Now we move on to our next panel discussion, which is on tuberculosis. And for this, I would request the esteemed chairpersons of this session, Dr. Shubroto Chakraborty, the past president of West Bengal Academy of Pediatrics, and Dr. Prashanjit Banerjee, who is a senior pediatrician and the past president of Howrah Academy of Pediatrics, to please grace the dais as the chairpersons. I would request the moderator of this panel discussion, Dr. Shopon Roy. I would request the panelists, Dr. Atanu Bhadro. Atanu da needs no introduction, and in fact, Shopon da is there to introduce. Dr. Atanu Bhadro, Dr. Vinay Asava, Dr. Choitali Patro, and Dr. Torun Shamanto.
Welcome everybody. Now we have got a very interesting topics, the tuberculosis. The days are gone when the tuberculosis was rampant. In our student days, we saw lots of cases of tuberculosis, meningitis, lots of patients with complications of tuberculosis. But after the advent of BCG, the number is definitely diminishing, but still new problems have been coming, and drug-resistant tuberculosis and so on and so forth. We have not still overcome tuberculosis, and so it's still an interesting and difficult subject. And here we have, it's almost a total Howrah affair, and we have got Shopon, Dr. Shopon Rai, our mentor, and there are Athanu, Binoy, Torun, and Choitali is there. So I think this will be a very interesting topic. So I ask Dr. Shopon Rai to start the program.
Thank you, Dr. Prashanjit Banerjee, our very senior and past president of Howrah Academy of Pediatrics, for his lucid introductions. So good morning all. So next 40 minutes, I will go through three cases of tuberculosis. So my panelists are Dr. Atanu Bhadro, the National Treasurer of Indian Academy of Pediatrics for the first time outside Mumbai. Dr. Vinay Aswa, the Treasurer of Howrah Academy of Pediatrics for long, and Treasurer of the West Bengal Academy of Pediatrics, and Vinay is the source of money to Howrah Academy of Pediatrics. Dr. Torun Shamanto, our dynamic would-be secretary of Howrah Academy of Pediatrics, and very organized person. Next is Choitali. So today Choitali is the host of the whole event, okay? And we are all guests. So, and she's the medical officer in railway, so we got this opportunity to hold this occasion over here. So with this, I'll just proceed. So I'm happy to be here in the Howrah Pedicon 18th. So our theme is Let the Child Fly, Draw a Rainbow on the Sky. So let's see how we can make a rainbow over the next 40 minutes. My first case is the case of non-healing ulcer. This is the girl, can you see? So, a 8-year-old girl is the resident of Malda, attended in our hospital in Bihar, Kishanganj, with a swelling 8 centimeter into 8 centimeter over the right preauricular area for the last 1 year. And there was central ulcerative lesion that we have already seen for 3 into 3 centimeter with a sloping edge filled with granulation tissue for the last 4 months. So, no history of trauma, no history of pain, no history of any herbal product use, and no family history of tuberculosis. We have inquired repeatedly whether there is a history of tuberculosis or not. So, what is the possibility, Dr. Bhadra?
So, with the history that you have shared and the pictorial depiction, I think we have a wide range of possibilities. It can be, even if there is no history of tuberculosis in the family, it can be mycobacterial. In fact, Burulli's ulcer is one we studied in the UG days. It can be that mycobacterium, parasitic, fungal, a whole lot of things. In fact, even if there is no trauma, we can think of other things like vasculitis, occlusion of the vascular vessels around that. That can also cause this. And in fact, it's a broad spectrum. We need some more inputs from the history.
Okay, I'm giving you that. So the child was started on comoxiclub as usual. We have to give some antibiotic. The biopsy specimen was taken because Dr. Atunu has already told that there might be a case of Burulli's ulcer or an scaphoidoma or something like that. So the biopsy specimen was sent for AFB culture and the culture sensitivity. Pus sample was also taken for the AFB and the culture sensitivity. So reports came, all reports to be negative. Now, after 2 weeks of antibiotic, we have noticed that there was no clinical improvement. The ulcer didn't heal at all, and the child was presumed of having a non-healing tubercular ulcer. At the right cheek, we have started the anti-tubercular drug. On day 6 of starting ATD, the child is having itching over the upper limbs, trunk, face, lower limbs, and multiple erythematous macule and papules all over the body. And there was swelling of lip. That is very alarming. So we thought of some problem, was the angioedema or severe anaphylaxis or not. So lab investigations were done, which showed deranged LFT and the increased IG level. I am very sorry that I cannot share that lab investigation of the LFT at that time because my PGTs are very, very meticulous to just forget this. So I cannot find this. I am very sorry for that. But you can well appreciate the IG level was more than 4,000. So there must be some allergic component over there. So Vinay, how will you proceed further with these investigation reports and all?
So we'll do a battery of other tests. We'll do CBC with complete blood count and peripheral blood smear. We'll do a retic count. We'll do a kidney function test, liver function test, and we'll also do a viral panel and chest X-ray, USG of the abdomen, and MRI if possible.
So this is the pediatric TB management guideline. That is the latest guideline we have. So here it is written. If you look carefully, if AST and ALT more than 5 times of the upper normal limit with the normal bilirubin, or AST and ALT more than 3 times the upper normal limit, accompanied by bilirubin more than 2 times the upper normal limit, or any symptomatic treatment, you have to withhold the rifampicin and pyrazinamide and monitor clinical symptoms. If there is improvement, you can even start those with a 3 to 5 days of interval. But as it is a very high one, so another module is there, the clinical module. So here it is written, stop all anti-tubercular drug and So we followed this one because the child has got an angioedema. You don't know whether it might be the hepatitis part can be taken care of, but we are really afraid of that angioedema. So we stopped all the medications, ATD, and we wait for.
But Dr. Thapun, can I come in?
Yeah, sure.
This is a atypical presentation. It looks like a very atypical presentation because if...
So my case will be always atypical, no?
Now with liver derangement, I think vomiting, nausea, it be initially at least that should be there with all the other symptoms also.
Yeah. Yeah. Yeah, we have performed CBNAT. We have performed. Yes.
Clinically presumed
look,
TB.
Look, Dr. Patro, I'm telling you. Let me speak. In this scenario of the rural Bihar, where TB is rampant, and after treating the child with a antibiotic, IV antibiotic 2 weeks, we have to consider the presumptive tuberculosis. And I will show you at last what happened.
And if you see the lesion, I think it's very typical like scrofulloderma.
Yeah, the ATD was stopped immediately because we couldn't take that risk, whether it is the angioedema part or the hepatitis. In hepatitis, we could easily continue that. I'm coming. Please have patience, please. Tab Atarax lotions, the mometasone and the moisturizing lotions are advised, and after 5 days, the remission of the symptom, the child improved very fast. We have started tab isoniazide and no fresh complaint after 5 days. So we thought, no. Neither there was hepatitis, neither there was any signs of any allergy. So the child was started rifampicins and ethambutol. And no face complaint for 7 days, we have started the pyrazinamide. When you started rifampicin, after 7 days, we started the pyrazinamide. Child progressions were wrong. Okay. But Dr. Torun Shamanto, what wrong have we done here? Because Dr. Basudev Path was pointing repeatedly, you have done the wrong thing in treating the child.
No, because there are the category of tuberculosis in new cases. One is Mycobacter positive pulmonary tuberculosis. One is clinically diagnosed Mycobacter negative pulmonary tuberculosis. One is extrapulmonary clinically diagnosed pulmonary tuberculosis. So here the case is clinically diagnosed extrapulmonary tuberculosis, and the regime is 2 HRJD plus 4 HRD. Here the patient got the hepatotoxicity, the enzyme, the liver function test says. So here the protocol is that when the hepatotoxicity occurs, we should use non-hepatotoxic drugs like ethambutol, quinolones, streptomycin or cycloserine. Here it has been stopped, and again we reintroduced one by one, and there is no toxicity, but that could be, it was preferable with using the non-hepatotoxic drugs.
Actually, the rifampicin pyrazinamide is a very known hepatotoxic drug, but this is I have taken from that particular module. Here you can see the INH has got also some hepatotoxicity. So we stopped. Only ethambutol we could give. But the child was no toxic, not very moribund, so we have stopped all the drugs according to the recent module we have. So I think you are not very vigilant, and you are not very attentive. Sir, in the first instance, I have told you that the biopsy was taken. So you should be very attentive, sir. Yes, yes. No, granulation tissue, it is visible, but we cannot pinpoint it was a case of tuberculosis.
There is a percentage where even after all your efforts, we cannot get a microbiological diagnosis. What you are referring to is that without a microbiological diagnosis, why ATD was started. And that's why the last category is that even after all efforts of getting a microbiological confirmation, if it is not available, but clinically it's still tuberculosis, then the ATD drugs has to be started. That is the officially, according to the NTEP, National Tuberculosis Elimination Program module, it's there. But only after all efforts have been done to make a microbiological diagnosis, then only we can give that in this situation. And apparently this patient had all the investigations done, and it wasn't, no microbiological diagnosis was coming.
So I request all the delegates over here to keep your question in your mind. When I will finish the session, you just bombard with your questions, okay? Otherwise, what happened to Dr. Kripa Sindhu Charaji, he couldn't finish everything. But I want to finish, okay? So I'll give you the chance, don't worry. So pre-discharge LFT was within normal limit. You can see the bilirubin has come down to normal. The AST and the ALT also become normal. So this ENT consultation was taken and planned for the superficial parotidiectomy with the skin grafting, and you can see this is the OT that they have done, and this is the right. Can you see it? So can you see how is the scar? Is it visible? The scar was perfect. So what regimen would you follow, Choitali?
First of all, good morning and thank you as being the part of the panel. Our case, there is ultimate on the days 5 of starting of ethambutol. The patient is no LFT is normal in the normal range, so we can go for the normal regime. In the normal regime, already said by the Dr. Torun sir, if there is 4 main part: the newly microbiologically confirmed pulmonary TB, and newly clinically diagnosed pulmonary TB, and newly microbiologically confirmed extrapulmonary TB, and newly clinically diagnosed extrapulmonary TB. In our case, it's the 4th one. So regime is HRZT for 2 months and HRE for 4 months. It is as per protocol.
Excellent, Chaitali. So, Atanu, would you comment on the 4 months treatment of the TB, because the WHO has advocated giving 4 months therapy?
Only in cases of uncomplicated tuberculosis, and when we do not suspect MD, multi-drug resistant tuberculosis, or it is rifampicin sensitive, there we can think of this short regime, and this is important in the cases because it this is important only because it ensures compliance. So 4 months is a short duration of time, and in some countries World Health Organization has come up with this tube, and India is one of the countries where it's TB endemic. It's where the compliance is a factor, and in areas like, particularly in certain states like Bihar, I think the compliance is a major issue. There we can have this 4-month regime, but it should be, is not suitable for all types of tuberculosis. Remember that we have a very high proportion of HIV sensitive, where the overlaps, there is overlapping of HIV and pulmonary TB. So in those cases also we have to avoid giving this 4-month regime.
Thank you. The point is well taken. So Vinay, what is the current ATD doses? Because now we are just deviating from our previous dose of the low dose INH and rifampicin. What is the current anti-tubercular therapy doses?
Yeah, it is, I would remember it in this way: 10, 15, 20 and 35. So 10 is for INH. We can have a range of 7 to 15, highest dose is 300. Rifampicin, we can give 10 to 20, average dose is 15, highest dose is 600. Pyrazinamide, 35 at the most, range is 30 to 40 and maximum is 2000 milligram. Ethambutol is 20 and streptomycin is 20. Highest dose ethambutol 1500 and streptomycin is 1000 milligram.
So we are giving
Professor Rai,
yeah,
I think we are all very bad at remembering this table. Either we have to, either we can refer to a chart on our table, or better we have the fixed drug combinations. It's very easy to remember on these tablets. 1 tablet, 2 tablets, 2.5. It's according to the weight band range.
Very
I
difficult.
think we should follow.
In pediatrician's brain, I think the gray matters are very much high than all the fraternities. So I beg to differ, sir. Anyway, can we add pyridoxines, and why? Because we are using the higher dose of INH. So
Definitely.
over to Dr. Torun Sharma.
Definitely we should use pyridoxine whenever we use the antitubercular drugs containing the INH. INH has the potency to produce peripheral neuropathy. The child or man, when a person will have the tingling, numbness or paresthesia in the limbs. So to prevent this peripheral neuropathy, we should add the pyridoxine 10 mg per kg per day.
And it is very cheap also.
Definitely.
So the Benadryl
and if
tablet,
we do
10
not
milligram
use it,
tablet
the child cannot recognize the numbness tingling, that will be unmasked. So we should give the...
Also because of the high dose of INH.
Yes, that I have already mentioned. The prophylaxis dose is 10 milligram per kg, but in drug-resistant tuberculosis we can go higher. So in vitamin B6 deficiency, if there is, we can go to the tune of 50 to 100 milligram daily. So Choitali,
Swapon, that is one thing I'm interrupting. Most of the drugs are not available in the stores. By your prescription, yeah. No, these antituberculous drugs are not sold in stores.
No, actually
What is the
this
problem?
is because the government supply is there, and there was rampant use of these ATD, so government has stopped this, and it is very much available in all the government hospitals, and we can refer it to the district hospital always.
Right.
So Choitali, what are the other adverse reaction of the ATD? Just like what we have in our child.
Most common in our child there is a allergic reaction, but most common is the hepatitis. It is occurs mostly all ATD drugs, the more common jo ATD drugs. And next maybe QT prolongation in case of fluoroquinolone or in case of ceftazidime, clofazimine, and there may be the hearing loss also occur in case of the aminoglycoside.
So there is a list of the drug, and it is a huge one, so I'm skipping that because to interact with you. So my second case is a baby A, I'm not telling her name. So 1-year-old girl of the Bihar presented with a fever, abnormal body movements, means seizure, vomiting, and decreased appetite for 25 days. Just keep it in your mind. Decreased appetite for 25 days, the parents told us. So what are the possibilities, Atanu?
From Muzaffarpur? Is the child from nearby place?
No, this is from Bihar, not Malda.
So because otherwise I would have put encephalitis on the top, and if it is Muzaffarpur or nearby areas, pyogenic meningitis, viral meningitis, and of course TB meningitis also would be one of the possibilities.
So yes, viral meningitis and acute encephalitis syndrome because of the Muzaffarpur and the lychee season, you were aptly told that. So we thought in the same line, this might be a case of this meningitis or encephalitis. So this is, you can jolly well see the general physical appearance. The BP was slightly on the higher side according to the 1-year-old child. Temperature was mildly raised. The respiratory pattern was normal. Pulse was slightly high. And there was no icterus, pallor, clubbing, and no lymphadenopathy. And the other parameters are almost normal, but the child was semi-conscious. And the birth history was uneventful. Family history also, there was no significant family history of the tuberculosis and all that. Only feeding history is that the child was on breast milk along with cow milk started since birth, because the mother thinks it is an inadequate secretions of the milk, so they have started the cow milk also. So this is the catch. The respiratory system, there was bilateral diffuse crepes all over both the lung fields. The heart was normal, no murmur was heard, abdomen was soft, no palpable spleen or enlarged liver. CNS examination, the child was very much drowsy after the seizure has been taken care of. What next investigation will want to do, Dr. Vinay?
Yeah, we'll do a complete blood count with retic count and peripheral blood smear. We'll do a renal panel, we do a liver function test. We'll do a CRP, ABO and RH grouping, viral serology, bacterial culture, chest X-ray, USG abdomen, and then MRI brain.
So we have done the total CBC. The WBC count was 9,360 with a neutrophil of 59.6%. This is the report, original report I have shown you. I have forgotten to mask the name, sorry. And ESR was 20, just borderline. CRP was 96. The RFT, LFT electrolytes were almost normal. This is the X-ray. This is the X-ray USG abdomen. So it was insignificant. The chest X-ray, nothing of tuberculosis was there. So Dr. Torun Samanto, would you go for neuroimaging?
Yes, because the child is 1 year, there is febrile history for the last 25 days. The child is having decreased appetite, abnormal movements like convulsion. So any febrile child with convulsion, we will keep in mind the meningitis, and it may be go to
not febrile convulsion, not febrile, simple febrile
but
convulsion.
the child is having fever, so I will keep in mind the chronic meningitis like tubercular meningitis. And since more or less 1 month history, there may be the sequelae or the manifestations of effect on brain, so I will go for MRI.
So
As the MRI has more sensitivity.
The MRI. Now, can you please tell the salient feature of the MRI?
Ventricular dilatation causing hydrocephalus and multiple infarct.
Here, this is a bilateral enlargement of the lateral ventricles, and this is also the third ventricles is also enlarged. You can well appreciate this. Can you see from the behind? Okay. So I'm giving you another better view. So this one. And this was done on the 11th of November of 2024. But this is the report of the MRI. Overall features are suggestive of meningitis with multiple areas focal infarct. But surprisingly, the person treating the child, he went for a CT. So how you can judge this? Is it a judicial or the rational approach?
No, after MRI, there is no role of CT.
So it was done on 14th, you can see. And the report was given that there was some white matter edema and the meningoencephalitis and some effacement of the cortical sulci. So it was in the line of the meningitis. And this was the report I am giving you with the enlarged view, and they say the line about the tuberculoma. So it struck the mind of the father that this might be a case of tuberculosis. So what we did, we just perform another MRI here because it is done free of cost in our institute. Yes, whenever it is required for any academic case, the administration, they give us the permission to do it. And you can see, I'm giving you the better view. So there are multiple hyperintense signal throughout the brain, and the lateral ventricle and the third ventricles are also very enlarged. And there was rapid progressions also. So we thought, we have started antibiotic. The child is not improving, there must be something else. So we have, this is the, can you appreciate this better view? This is the hyperintense signal and the periventricular region and all throughout the brain. So just like this one, the hyperintense signal. So, yeah. So any other investigation you want to do, Chaitali?
In the present scenario, we have to do for CSF study and the CSF cell count, cell type, and if possible, gum stain and culture.
So we have done this. The CSF had showed no pus cells or anything, and the CSF culture sensitivity required. There was no flagging of any organism even after 48 hours. So we are really in dilemma. So it was not a case of pyogenic meningitis. So
I think CSF could have been done in the first instance only before going to MRI and...
No, we never do it, because if there is any chance of herniation with so much of these ventricular dilatations, if you just take the CSF, there is every chance of tentorial herniation. So as a policy, even in Institute of Child Health, we never do. Subinita is here. We used to do MRI first, then we used to see whether the CSF can be drawn or not. And in this area of the litigation, I will also request if you used to do it, always do the MRI first, then go for the lumbar puncture.
Okay, point well taken.
Okay, and again, the count was 100 and mostly lymphocytes. So our antenna rose. So we have started ATD. And would you like to start steroid, Chaitali?
Yes, as it is a case of diagnosed as TB meningitis, so we have to add the steroid.
So these are the indication of the steroid, because all of you are aware of that. And because it was a case of TB meningitis, we have started steroid, and there was dramatic improvement. And how do you use steroid in the pediatric TB?
In case of TB meningitis, in case of Addison's disease, in case of miliary TB with alveocapillary block, in TB pericarditis, mainly we use the steroid. And in case of TB uveitis, in IDs during treatment, also in endobronchial TB, we can also use the steroid. But in case of tuberculoma, we should not use the steroid.
Yes, that was the thing. They were written tuberculoma. Only seeing the tuberculoma, we won't start the steroid because it is not going to improve. So whenever you get a tuberculoma, either in the brain or in the choroid, so never give this.
Can
steroid.
we have a picture of the chest X-ray?
Yeah.
Chest X-ray was normal.
Yeah, this is the chest X-ray. Any comment?
Expand कर सकते हैं इसको? Can we enlarge this thing?
No.
Because the parenchymal में कुछ there is not there are.
Atanu, I am practicing radiology for last 35 years. Not bold. Anyway, so we have made the things a bit lighter. He is one of my best friend. Don't take it personally. So progress during our hospital stay, the child started improving. That is the thing. The child started improving, and we have continued this. And so the IV fluid was given, and we have wind up from the bubble CPAP. The child improved like thing. So how will you treat this child, Atanu?
If you are thinking as a TB meningitis, of course, the 12 months regime should be followed. The 2 months of intensive phase and 10 months of the continuation phase. There is now another regime that has come up of 6 months with high dose of and ethionomide in the first intensive phase.
So do anybody use this regime of the 6 month? So almost 6 drugs for 6 months. Do you use it? I don't think, because we use what you have already said, 2 HRZE and 10 HRE. So we have adopted 2 HRZE and 2 HRE. What is PUR? Vinay?
Yeah, it's a paradoxical upgrading reaction. Paradoxical means whatever the things we are supposed to encounter, or the opposite thing happens. So there is an increase in size of the mediastinal lymph nodes or area of pulmonary infiltrate in pediatric patient with pulmonary tuberculosis. In extrapulmonary cases, there are new lung infiltrates in the patient. There is development of TB pleural effusion, and in some cases increase in the effusion size. There are appearances of new lymph nodes or enlargement of the original nodes, and increase in the size of number of tuberculoma, infarction, hydrocephalus in the treatment of intracranial TB.
So this is very important for the PGTs who are attending. PUR will come in your short note.
The definition of PUR should be clear. Definition of PUR is patient is symptomatically better, but evidence showing.
Yes, new infiltrates. He has already mentioned that there is a definite paratracheal lymphadenopathy. There are a new development of the lung infiltrate. So you were seeing. You were treating the child, but paradoxically it looks by investigations that it has exaggerated. I'll come. I have promised I'll come, definitely. Let me finish. So case 3, because I want to share all the cases. These are very interesting cases. A 10-year-old girl presented to the casualty with complaint of recurrent cough and cold for 4 to 5 years, not 4 to 5 days and months, 4 to 5 years. Increase in cough and the breathing difficulty for last 15 days, and swelling of the lower limbs for the last 2 days. So when I saw the girl was panting on the bed. So we made her in the proper position, and we thought it might be a case of congestive cardiac failure. This is the proband, and the height was less than 10 percentile, weight was also low, less than third percentile, head circumference was normal. So the father, with details in history taking, it revealed the father has history of tuberculosis diagnosed 2 years back and treated for the same. So history of contact is positive. And the child was presented with the tachypnea, tachycardia, right hypochondriac pain, and palpable very tender liver. So we thought it is a case of CCF. We started with IV diuretics and the ACE inhibitors, and naturally Gangajal, that is the coamoxiclav. And after the resolution of the CSF, the investigations are sent because we want to first make the child hemodynamically stable. And what is the further step ahead, Torun?
The child is having, after stabilizing the child, we have to search for the exact illness in that child. There is often all last 4 or 5 years cough and cold. So, and the father is having the tuberculosis. So the contact history is positive and child is having cough and cold. We have to search for the tuberculosis in this child also. So the microbacteria.
Can you comment on the X-ray? And audience, I am giving you the chance. Audience, comment on the X-ray. So who said? Okay, Dr. Guchait. So, Vasudevda? What?
Right side. Right middle lobe.
Yeah. So, right border of the heart at the lower part is not well delineated. So, there must be a right middle lobes consolidation. Not collapse, consolidation. And we can see the air bronchogram. And hats off to Guchait sir, because you have said miliary modeling. Now, as Otonu said, can you make it larger? So I am giving you the larger one. So this is the larger, and you can see, well appreciate, this is the miliary modeling. And believe me, the miliary modeling may be from 2 millimeter to 20 millimeter. It was written in the Crofton what we used to read. But nowadays they have written 4 to 6 mm. For the PGTs, remember the miliary tubercle shadows are 4 to 6 mm. Yeah. No, this is the magnified view. I have magnified. So investigations, we have seen the hemoglobin was 6.6. So we thought, has it precipitated it on the tubercular, miliary tuberculosis with 6.6 of the hemoglobin? There are multifactorial things that may present for this CCF. And the CRP was also raised. ESR was 56. So see, the previous child, if you remember, that was 20. Here it is 56. So tubercular you have to think of. So, but the card test of the HIV become positive. So we are really in the soup. Why did it occur? So we inquired the family. Initially they didn't agree to divulge anything. But after repeated request, they have revealed the father and the mother was diagnosed to have HIV positive, and they are on retroviral therapy for last 1.5 years. And this is the report of this. I have sent the report for the HPLC, and see the child, unfortunate child. The child was also beta thalassemia trait. I'm giving you. So this is a beta thalassemia trait. So the child with the beta thalassemia trait, with tuberculosis, with HIV. This is possible in the Make in India. This is our India. And this is how we proceed. I'm not going into the clumsy thing. The USG thorax we have done. The sputum was sent for 3 consecutive days because we don't believe on the TrueNat what we have. And the CBNAT was sent outside, it also became negative. The child was presumed to having the tuberculosis and put on the anti-tubercular drug. The child started improving very fast, and with the oxygen support and all that, we have gradually removed, and the child has improved. So I was thinking about, this was our paper with Joydeep. I think Joydeep has already come. Joydeep and me, we have done a trial, the clinical profile of the HIV and the TB co-infection. So in India, it is still rampant. So what is IDs, Chaitali?
It is a very important topic, especially for the PGTs. IDs is the after ART, when it is a reconstitution inflammatory syndrome. After starting of ART, there is decrease the viral load and increase the CD4 count. And in that case, immune response also increased and TB symptom may flare up. It is maybe two types, the paradoxical IDs and unmasking IDs. In paradoxical IDs, there is first the TB symptom present and start of ATD symptom disappears. But after start of ART, the symptom of the TB again recurred. And in case of unmasking IRDs, in that case TB symptoms are not present, but after starting of ART, it is obvious.
So what was not there, we can now see it. So it is the review in reconstructions. So this is a very important short note for PGTs, the IRIs. And for the audience, I said that I will give you some food, okay? So this is the X-ray. Now Basudevda and anybody can definitely say this is the X-ray. What is your finding? Bolo bhayo. So what is that? Can you see the heart? So what has masked the heart? So there was collapse consolidations on the left side and there was compensatory hyperemphysema on the right side. So what is your diagnosis? In children, usually the fibrosis doesn't occur. It is in the adolescence or the adult. So it is after treatment of a long. So it didn't improve after a course of antibiotic. This is the child. Can you guess anything? Look carefully at the face of the child. So rashes over there. So skin rash with lung involvement, what can be? Yeah, that's why she is the president. That's why she is the president, LCH. Thank you so much. So if you have got any questions, we have got just 1.3 minutes left.
In addition, the child has huge constipation, the colon is going up to stomach.
This is the bubble. This is the bubble. Yeah. Yeah. No. PUR IDs are totally different. I'll come because it will not be finished within 1 minute. Any other question from the audience? So I think you don't have any questions. We'll discuss outside. Okay. Okay. No.
There was a lesion, you did a surgery in the end, you get treatment, so he has a point.
Bolo.
Actually, we have in tuberculosis diagnosis, the central causation with granulation is it not there in the first case, and the whole microbiological
There was
assessment.
past. That's why I said there were past. Everything cannot be written in the slide. If you just look carefully, there were past points and a lot of granulation tissue. So it just looked like the scopuloderma in the neck or some in the neck and any other place. So we are thinking about why so much of the granulations tissue, and that's why you have sent the biopsy and it came negative. We cannot detect, possibly of the HIV part or that. So I think a big round of applause for my learned audience, and thanks to my chairpersons, Prasenjit da and Subroto da, who are the really our inspiration in our student days.
Hello.
And thank you very much for the audience for interacting, because it is an interactive session.
Excellent interactive session. Thanks, Atonu, Binay Aswa, Torun Samanto, Choitali, and of course moderator Sopon.
Can we add gradually the INH or rifampicin in the same dose or from
Same dose. Same
lower
dose.
dose to have?
No, same dose. We will not titrate the doses, same dose.
There are two options. In some, you're right. If both has been suggested that you start 50% and then increase.
No, actually, that was the old concept. In the recent guideline of the tuberculosis, they have stated you can straightaway go to the higher dose. No need of titrating the dose.
Full dose.
Yes, if you want, I will share in the Howrah group that that I have shown the TB book that I will show you. Thank you so much. Thank you so much, Mr. Subrata.
Thank you, sir, for finishing that off in time. And we go for the felicitation, the mementos. I would request Dr. Shopan Roy to please give away the mementos to our chairpersons first. And the panelists. I would request Dr. Atanu Bhadro to please give the memento to Dr. Shopan Roy. So with this we move on to the next very important session, for which we have our President-elect today here with us. It's really a privilege for Howrah Academy of Pediatrics, for West Bengal Academy of Pediatrics to have Dr. Neelam Mohan with us today. And the next oration, the Malavika Biswas Memorial Oration, will be delivered by her.
Our next program is the prestigious oration, and this will be kind of presented by our Honorable President-elect of CIP, Dr. Neelam Mohan. Ma'am, please take your chair. And she'll be talking about the Indian pediatric hepatology, the journey of excellence and innovation. And this session will be chaired by our Honorable Dr. Rana Chatterjee, who's just entering in the right time. Dr. Rana Chatterjee, could you please take your chair? And Dr. Sujay Chakraborty. Sujay, are you there? Okay, then Sujay had to leave for some urgent work. Dr. Atanu Bhadro, our very beloved treasurer of CIP, will be chairing at this session as well. Atanu, could you please chair this session as well? Sure. So before we start the session, we'll be garlanding. A round of applause, please.
I'll request Dr. Rana Chatterjee and Dr. Atanu Bhadro to come here. And give the medallion, Oration medallion, to our very energetic President-elect of 2025, Dr. Neelam Mohan. Dr. Rana Chatterjee, please introduce Dr. Neelam Mohan.
Good morning. Now we'll move on the next session. the memorial oration of our very own Dr. Malavika Vishwas, who will be delivered by the eminent pediatrician, the energetic organizer, and entrepreneur, Dr. Neelam Mohan. President-elect, Just a moment. Dr. Malavika Vishwas, a brilliant academician, graduated from famous medical college, Kolkata. Then she did her MD in PGI Chandigarh. She joined Institute of Child Health, Kolkata. She was active member in Howrah Academy of Pediatrics and was a real gem not only in academics but also as great human being with motherly touch. But unfortunately, we lost her in a car accident during Holi. But her presence we can feel always. Atunada, move on.
It's my honor and privilege to introduce the President-elect, Medical Director of Medanta City, one of the pioneers in liver transplantation. Though I know many of you, almost all of you have voted for her, but probably we should know that she is also one of the leading pioneers of liver transplantation in children in the country. So is a speaker in all international forum, has put gastroenterology, Indian pediatric gastroenterology on the map of the world. And of course, she is something that we all of us should aspire to, that academics. So it was our proud privilege to have her as a President-elect, and thank you for coming to IIP Howrah in spite of over busy schedule, not a busy schedule, it's an over busy schedule. And thank you, Dr. Neelam. We are proud that you are delivering the oration today.
Thank you. And at the moment, first at the onset, I would want to start my gratitude to all people from Howrah. Thank you very much for voting and supporting me, because I met a lot of people from Howrah and they all were absolutely, genuinely in appreciation and wanted to support me. So I think it is a reflection of the academic bend you have. And the previous two panelists with Kashi ji around and Kripa Sindhu and Swapan Ray, except for his bossing, but I really enjoyed the two, and it was very interesting to see the cases, and it just teaches us in the basic fact that knowledge is so fast, we all can't have the same draw, and we need to keep updating and sharing our knowledge because there's so much. So with that, my gratitude towards the Howrah, for this opportunity to me. And the title of the oration is Pediatric Hepatology in India, a Journey of Innovation and Excellence. So to start with that, I would just give you with the key breakthroughs and what were the game changers and how things happened and where we are today. So going back to, 80s, I just wanted to show that gastroenterology pediatric sort of got separated from pediatrics by late 60s, 70s. So European came out with pediatric gastroenterology, the North America pediatric gastroenterology, that was also in 1970s. In 80s, they decided to have nutrition added to it, 75 gastroenterology. So this is all, I'm just suggesting you how they started with gastroenterology in 70s, and then they added nutrition in 80s. That's how it was going on. And you can see nowhere hepatology was not mentioned in 1780s, and I bore towards these stalwarts in USA, Dr. Allen, William Ballistry. These people started with hepatology, And we all have read books of Fred Suchi, and I've been I mean, I had the privilege to be with Harlan Winter in that they in USA started in 80s understanding that they didn't want to be called as gastroenterology and they wanted to work for hepatology. And I think a major change came from Europe where Alex Mowat, we've all of Sheila Sherlock in adults, and then Alex Mowat and Professor Georgina Melli, these two in King's in 80s started doing great work. And then came Dr. Deirdre Kelly in Birmingham, and she had a childhood in Calcutta, so she loves coming to Calcutta. So with this, it was in mid-90s that a new specialty emerged as the field of pediatric hepatology. They wanted separate. I mean, the pediatric hepatologists didn't want to work gastroenterology too. So this was the first time that research started flourishing. People wanted to understand what is the pathophysiology, why do these liver diseases occur. Metabolic was very less understood. Then the molecular biology and genetics, this were all happening in mid-90s. So in mid-90s, and then first in USA when I said they wanted to do transplants, so Professor Stahls in 1967, he did the first successful transplant, and that was fortunately in a child with HCC in University of Colorado. But that time the results used to be less than 25% because we didn't have great immunosuppression where we could tell it. So then came cyclosporin. When it came in late 1980s, the cyclosporin, wow, the results went from 25 to 60% of the liver transplant. And then 90s, 89, 90 came the tacrolimus, what we use now. And in that 90s, then the success rate went up to 80%. So this was the story that was happening in USA at that time, and that is the team there. And now come back, so you are now seeing that all this major association which were having G, now they started adding H to their, now 1990 was the first Europe who added H, is Pagan, hepatology. Then the North America added H. The Latin America added H, the Asia Pacific added H. So now came the major four, North America, Latin America, Europe, Asia Pacific, who wanted to have H along with them. But in the Commonwealth, still though 1984 they came with CAPGAN, they didn't have the H part into them. Now come back to India. So I just gave you a glimpse. So now in India, Saroj Mehta ma'am was in PGI Chandigarh, and she wanted to have pediatrics separated from the adult gastroenterology. So now we are still struggling in gastroenterology. So she wanted, but it was not possible, but at least she, with Professor Thapa, they started and they were wanting to work more in pediatric gastroenterology rather than adults, though they were trained with the adults. And Dr. Yacha was one of the first who again was a pediatrician who did DM adult gastroenterology but wanted to practice pediatric. Now in AIMS there was only Professor N.K. Arora. Now N.K. Arora was a sort of a self-trained hepatologist who did predominantly epidemiology. He went to Australia and he wanted to do epidemiology. So I worked under him, so his was not so much research into liver, but at least he wanted to understand that. And Professor Pandit in KM, he had his association, great association with Europe, and Europe started supporting him for Wilson's disease and ICC. So he started doing a lot of work in hepatology. Then what was the scenario? So I've given you a scenario, 90s, late 90s, everybody is split, and transplant in 90s was going up to 70-80% results and all that. So Sri Rajiv Gandhi ji went to USA, and then, you know, in one of those meetings in USA, he heard about heart transplants, liver transplants, etc. He came back to India and I saw his interview on TV. And in that interview, I saw that he asked this question, why India doesn't do liver and heart transplant? And Professor Nandi was called from AIIMS to ask for it. And then came the Transplantation of Human Donation Act in India 1994 by Nandi. And those, I still know a couple of people who in late 90s went to USA and had their liver transplant done. So those who could afford 10 million rupees at that time, not today's 10 million, you know, it was a huge amount of money. And I know one of the person who still, you know, he donates a lot of money every year, annually 2 CRs for transplants. And he had it in late 90s in USA. So they used to plant themselves there for a few months and learn. Otherwise, 2 lakh people were dying in India. So when I saw that interview, something in me happened, and my dad always wanted me to do something different for the country. And that Chulbali, Neelam, I thought, what can I do? Okay, I decided I wanted to do transplants. And I was doing MD pediatrics. I got married pretty young in my MBBS itself, and my husband was a non-doctor in Delhi. And I realized that if I do MD and then go for my training abroad, it would be a straightforward divorce, 6 years, you can't be away from him. So I left MD from Hyderabad, and I came to AIIMS, and I could not get pediatrics. I got ophthalmology. I did 3 months ophthalmology. I was just not happy because I was enjoying pediatrics and not enjoying ophthalmology. And Hyderabad, Andhra was a state which did not give all India entrance. We were not eligible. We could only join AIIMS. So I joined with Professor S.C. Arya as a TNB student, leaving MS Opthal and MD Pediatrics in Hyderabad. I joined with him as DNB, and I was fortunate. Professor Guy was my examiner, and he called up S.C. Arya to say, what a bright girl you've got, and I topped in the DNB despite the MD. So the training, what they did, and I went to Dr. Datta in Kalavati for my pediatric training. And then they sort of handheld me, and Dr. Arya made me introduced to Dr. Bhan, and Dr. Bhan was in AIIMS and Dr. N.K. Arora. So they wanted me to do my senior residency. I started. Then I went to Meherban Singh and I said, sir, I don't want rotation. I just want to work with them. He said, are you kidding me? How can there be no rotation? I said, sir, very simple, don't pay me. Really? I said, yeah, you don't pay me, but I'm a senior resident, I'll give it to you. So then they said, okay, we have a WHO fellowship where you pay us 500 rupees for 6 months. I said, done. So I paid them 500 rupees for 6 months, and I did the first fellowship in India in pediatric gastroenterology in 1996-97 with them. So I'm very grateful for people who came to. And then Dr. Bhan sent me to Deirdre Kelly, and 2 years I spent with her. My son was almost like 4 years, 5 years at that time, leaving him. I went up, and that's me in the center with the other nurses and Professor Ian Booth, and then I got that certificate from the Birmingham University. I came back with my fellowship to India, and that was my first photograph, which was put in the bulletin of Gangaram when I joined Gangaram, and I wanted to start. And Apollo Hospital, Anupam joined, and oops, I think there is a picture missing. Okay, so there is one picture which got missed. So I joined here, and Anupam joined in Apollo Hospital, and both of us wanted to do transplants. And the work that I was ending up doing was more in gastroenterology. Let me be very honest. And the first time in the world, then a congress was formed called Fishpagan. This was formed in 2000. I showed you all the societies. So they wanted to join and do once in 4 years. So the first World Congress was done in 2000, and I was very lucky. I got the Young Investigators Award for presenting in chronic pancreatitis, etiology, and clinical profile. And I was fortunate I was working with Dr. Randhir Sood, who's an adult, but he was doing huge gastroenterology. So within no time, I mean from 98 November I joined to 2000, I saw almost like 50 patients of pancreatitis, which was referred to me less than 18 by him. So that's how my story started with that. But then transplants, I was not able to do great work. There was no resources, no trained specialist except me. There was no infrastructure. I wanted them to have state-of-art theaters and state-of-art rooms, and there should be no infection and all that stuff, and there was nothing like an organ transplant also. So yeah, so there was a lot of struggle. Professor Nandi was in Gangaram, so that's why I joined in Gangaram, because I knew he was there. Dr. Gupta, I got him from Leeds. I said, you've got to join Gangaram. So he was sweet enough, he came along. Dr. Soin had initially joined in Apollo, and fortunately he moved to Gangaram. So I was very fortunate. I had Nandi, I had Gupta, I had Soin, and myself. So we were all struggling, and after 98, there was a lull, no transplants in India. Then 2003 was the first, you can see that photograph of that girl and me with the thing. This was my independence. 15th August 2003 was when I got an independence, and we did the first cadaver liver transplant. Then, of course, I became the media girl. Every week, I used to be in the newspapers for a lot of things like, transplants, setting up. Now the hurdles. There was no confidence. UN would never refer a patient to me. So you all don't trust that somebody can do. Wo to ek ho gaya, by chance ho gaya. No awareness, no referrals, no money, no support from the government, no NGOs, no cadaver donation. How do I do? So literally 48 weeks I used to travel. I mean, my chakra on the feet, I used to just travel to tell people, hi, I'm Dr. Neelaman, I do gastroenterology, hepatology, all the time trying to tell myself. And I was I had to make the protocols, ICU protocols, and I was trained in cadaver donation, but here I had to do living related because nobody was supporting. And the surgeons and all were happily, they were doing more GI surgery work. So it became a little issue, but then every programs and all, and I'm so grateful to these three people who are there. Dr. Bhan continuously supported me in every meeting I did, and every year I used to do a meeting. And with Dr. Mahajan, Dr. Sama, these people I salute because they also had this dream of doing it. And the first, another milestone we did, where the first liver failure in India in 2004, and then in 2005, another bloodless transplant. It was a big thing because we got a QSA, which prevents the bleeding. So that was a big thing that it came. And I'm happy, I kept on doing the workshops on pediatric hepatology, gastroenterology. Every year I used to do. And obviously I had to invite the adults like Dr. Sareen, Dr. Bhan, Dr. Sama, and these people. So the spreading of knowledge was extremely important so that people started giving. And I'm very proud to say that the first conference of transplant in India was done by yours truly as the organizing secretary. So I was so dynamic. I brought ahead a couple of international people, and we did the first transplantation and pediatric. So I took bone marrow people like Anupam standing there. So he could talk about bone marrow and all. So that was the first transplant awareness conference in India. So it was not organized by a surgeon, but by me in there. Then came the next milestone. We did the first combined liver kidney. And by that time, since both the surgeons had joined Gangaram, so Apollo did not do anything after the first 98. There was a lull, and we kept on moving for the next till 2007. The transplants were happening, fortunately, in this. So this was also there, and this was another milestone that we achieved, was a swap transplant wherein that husband gave to this the child of that mother, and the mother gave this. And this also was me trying to take permission in Nirman Bhavan, and that was the first time now swab donation was allowed in India, because that husband, they did not have children and she did not have a matching donor, so that's how we did. And this milestone made me literally global. I'm very grateful. I mean, I spent lakhs of rupees. There was this child called Shaurya. The parents had lost previous child. He had MSUD, maple syrup urine disease. So they can't eat proteins. The only way you can cure them is with a transplant. Though the father was working in Seaman and he had almost up to 1 crore of insurance, but they had lost 2 kids, and this kid was from Great Ormond Street. They gave them the protocol how to make the child survive. So I met them and I went to Pittsburgh to learn about MSUD, transplant. I spent a fortune from my pocket to understand what it is. And in that, what happens is, auntie gave a liver to this, but this liver was good, so we could give another child who had cancer. So that's called domino. You don't throw the liver because the liver just didn't have the enzyme which is there in the normal this. And that's how I became sort of global in 2010, January. And it was a big thing to be a first, and these 2 children are doing so well. She's just gone to London for her studies, and he got 2 days back, I got a message, he joined law. So both of them are doing pretty well. So then we completed 100 transplants, but not 100 children, total 100 in this thing, and that was a child. So we completed around this. So the journey was from 2003 to 10. I was very instrumental in developing, and by that time I started a lot of gastroenterology work, which I'm not showing. I used to do endoscopy in 2 kgs and therapeutic pegs, but I used to be planted in the hospital from 8 a.m. to 8 p.m. Lot of work, because that I would sleep in the room of patient for week 10 days, each transplant, each for the first, and we had 0 mortality for the first 45 because I would just plant in the patient's room. But yes, selection criteria, I never took any baby which was less than 1 year because I wanted to get that confidence. So it was a very successful thing by 2010, a lot of achievements and doing that. But then we need more transplant hepatologists. It was not me. It is time to understand, to give back, cost barriers, awareness, vaccination, nutrition, biliary atresia diagnosis, metabolic. So these things intrigued me, and I thought it is time for me now to get into all this, how I can be working on vaccination with the government. So Dr. Sareen was very instrumental because we really used to appreciate my work. So we were approaching the government. It was not pediatricians, let me tell you. It was Dr. Sareen and me who were with the government for vaccinations, and then biliary diagnosing. All this, they helped me a lot. And then I wanted to dream big. I thought it is time to have a department of gastroenterology. Department means I didn't have to be reporting to a pediatrician or under a pediatric. So separate department, 2 secretaries, 4 residents, 2 consultants with a separate ICU for the first time in India was offered by Medanta, Dr. Trihan, who really had a vision, because when I went for an interview, I said, sir, I'm not looking for a promotion of money because I'm really earning huge money. By that time in Gangaram, I used to be in a double digits already numbers. So I wanted something else that he could understand what I was talking about. And it was a big thing that the whole team, that's Dr. Trihan next to me with the mask on, and that's me. So we moved on to Medanta in 2010, and it was really very good decision because nowhere in the world there was such a big team, and I wanted to have a separate pediatric hepatology team and not be just a part of the adult. So that is the first. In either I am under the adult gastroenterology, neither I was under the transplant. I was separate as a department in this thing, but we got state-of-the-art ICUs separate, liver ICUs. We were not a part of the pediatric. So that became very interesting. We started taking more challenging cases, and this again was a second global thing that we did a factor 7, which globally people were not thinking of doing. We had, and we moved in, and they used to feel jealous about us because in India you had 1:1 nursing in ICU and both ward, because we could afford 1:1 nursing, and the doctor-patient ratio used to be like literally the same where you are. So this was another global credit. But the small babies I mentioned to you, I was not taking much less than 6-8 kgs till in the first. Now came the chance to move and accept these challenges. The purpose of explaining to you is you always need to have a roadmap when you start. Just can't jump into it. So first gain the confidence. Zero mortality in the first 45, nobody would believe it. Because I did not take the lesser than 1 kg, 10 kgs, because I knew they are going to be complicated. Nobody would believe in me. So now I started taking these babies, that this baby was so small that you can't even close the tummy with the liver. So we started doing work like meshes, and these girls are growing so big and such complicated cases. We started accepting them, and they used to have a lot of, so having dedicated liver ICU, liver critical care team. So I was heading the critical care at that time, and so I would do a lot of critical care work along with this at Medanta. And then small babies were no more a challenge. We did almost like 37% of our babies are less than 10, and I think I'm probably less than 6 kgs in India. Quarter of the patients are done by our team. We're very famous for small babies, transplants that we do into them. And we made on a third world record, which was the lightest baby in the world with 2.13 kgs. This was the third a global record that we created. And I was writing at the same time all that I was saying. And then the surgeons started moving with robotic surgery. Now we've done 500, but this was again a national record we started for the first time. But my endeavor to continue to teach was always there. I remember there was a nephrologist, I won't take name, who was with me at that time, but he said, I don't want to teach because then there'll be many I'll produce and I won't be what I'm getting that. I think that's not the vision of a good teacher. There is so much to give back. So I started with the postgraduate course and doing the work continued annually, how to do. Then we did first ABO incompatible transplant, which was not done in Asia probably at that time. And God was kind, it was successful. We kept on taking very big challenges. Again, another global citrullinemia, because to manage these patients intraoperatively, purpose of telling you all is it's really a big challenge. It's not the surgeon who's going to look into your complications of hyperammonemia, not the anesthetist. I used to be in the OT. People used to think, is she an anesthetist, is she a surgeon? But the whole day I used to be in the theater. So trying to understand everything and then parking yourself for a week post in that. So it made a difference in these papers. And then new centers from 2010 to 15, Hyderabad and Chennai Global Hospital, Narayan Hridayalaya, Max Hospital, because by that time, Medanta and the SGRH. So the whole team moved from SGRH, and SGRH was not doing any great because the entire team, I showed you the pictures, had moved. Now my role was to mentor youngsters because I wanted to give back to the society and do it. So the first fellowship that was started in the country was 2008 by me. I wrote an entire thing, and I'm very grateful to the IAP to have accepted Dr. R.K. Agarwal. He was so good. He said, fellowship karna hai, and there was nothing, and EB passed it because there was nobody else, and I was the only young one who wanted to do. So the EB passed, and I could start a fellowship, IAP fellowship in 28. Then I went to national boards, and national boards allowed me to start my first FNB in 2011. And of course, now an advisor to national boards and an accreditation for a lot of new centers. And these are so many people I trained in India. So that's how almost any transplant center that you would see developing, or hepatology, God was very kind. These youngsters were disseminated everywhere across by me to go and start their new work, and they all moved around in different places and increased the work of hepatology in India. And the first publication which came from India was for the first 200 transplant was written by us, and we showed that the results were 93%. Then this came a very big challenge. This child, look at the clubbing she had. She was blue. She was a biliary atresia with a saturation of 48% in room air. And what happens is, this is called hepatopulmonary. You develop bypass in the lungs, just like you develop in the skin, those spider nevaes, you can develop bypass in your lungs. So you don't get oxygenated blood, it just bypasses you. And that was a big challenge I took, and she was 33 days with me and in nitric oxide, and fortunately we survived her. So that was the first hepatopulmonary transplant also in India that was done, and that's my family. And in 2016, I received the BC Roy for the work in hepatology and liver transplant training that I was doing. That's my elder son, who just got married. He's married, and that's my younger one. And it's an old picture taken in Gangaram because it was a pleasure from where you did it. They called me to do an oration, and my first oration was in Gangaram at that time where they did. So what was happening now, the other branches were developing. Without them, I don't think we could have done anything without the radiology and technology developing. So the technology was so high, you could just get a road map. And I'm showing you black and white. We see three, I could not find it in my computer, the main image. They are so beautifully colored images that the advances that happened in imaging is beyond your imagination. It's like you can see everything virtually everywhere. And then the interventional radiologists, without them we can't do. So we had to be sending them abroad, and if such a small stricture, imagine on a 4 kg baby. So in that 4 kg baby, I want somebody to go from the skin and dilate that stricture. So I need the interventional radiologist. And Dr. Bejel is Asia's #1. He moved on to our team, and he was doing such great work. Such small baby, imagine I'm doing tips in a Bacciari, tips in that baby. So we started doing such cases because you need the other team members, the tumors, the way you're able to handle by doing surgeries, the liver. So the results in liver tumors came up to 90% with resections, chemotherapy, transplants. So we became a popular center for international referrals for tumors. What were the other breakthrough that was happening? Now the next breakthrough came where instead of doing a liver biopsy, can I know without doing a biopsy by biomarkers how the liver is? So the biomarkers, that's not biochemical, sorry, that's biomarkers started developing in the liver disease. Genetics became very popular, fibroscan and elastography. With that, we started telling you, so look at that elastography. We can tell you what is the liver fat percentage in that. So that way, and then fortunately newer drugs were coming over, not only trimethine, but the enzyme therapy for Gauchers and NTBC, tyrosinemia. All this I'm talking about India. They started coming to India, though globally they were there before. So we started getting this. We started doing genetics initially at 40,000 or 50, and now it is available anywhere between 11 to 25. So that's how the specialty was developing through different things. And we had started training a lot of youngsters, and as an accreditation examiner, 3 or 4 centers I was accrediting to develop, and then how to increase it, working with the government on the hepatitis B. Dr. Sareen did this. I should not take that credit, except that in the pediatric he would take my name. So then 2000 initially the hepatitis B came, and then by 2011 it became the national IAP. If I'm right, it used it in 2001 as an optional, because that was the time when the vaccine came available in India. But then in 2014 they said for all, and still it is not there in UIP. What was the research happening? Research was still pretty low. So Dr. Yacha moved to SGPGI, and these people were doing more in gastroenterology rather than in liver. In liver, their work was in EHPVO and cholestasis. Then in ILBS came in 2011 by Dr. Sareen. Then last 4-5 years, they started doing work in cholestasis, PFIC, and ALF. And as you can see, Ispagan. So I was instrumental in getting the H in the Indian Society, and 2013 I was the founder secretary of the Indian Society of Pediatric Gastroenterology, and wrote a lot of national guidelines and teaching. So I was instrumental in going to the ministry, and the products that you are using for the formulas for metabolic diseases, milk protein allergy. It was at that time, as the secretary approached, the health minister was Naddaji at that time too. So we approached him and he agreed. He put it to the FD, what is that? Food for FSSI. So he put me to FSSI. We had meeting including dieting. So I kept on my responsibility and my work, not only into clinical, into training and being with them and writing all the protocols and these things for that time, but education. So I just wanted to highlight, not only we're doing this, but I also moved on. I realized that, with the companies also, it's very important. Cipla and all used to do so I used to be a good speaker so that you can reach more people and more pediatricians about teaching, and the whole thing happened, and that's me dancing with all the children who had the transplants and promoting transplant works pan-India. Then I moved on globally and internationally. So because of my work, I got recognition and I became the secretary of all that is blue is Commonwealth. So I became the secretary of Commonwealth in 2015, and 2018 I took as the president, and that was, taking in that as a president of the Commonwealth, and Bill Gates sponsors through microbiota and all came a lot. So we were doing a lot of work in Africa and all in this, and I was fortunate with meeting the Prince Charles at that time, because he used to support a lot of work in Commonwealth, and I wanted to started developing. In fact, the government of Pakistan felicitated me with their award, because by that time I went to Pakistan 6-8 times and set up their liver team, and they have huge setup now. So set their team as much as I could do in Bangladesh. Sri Lanka was a big no, they did not want, and Africa was instrumental. So this was the time where I was working in India, but not much in the IAP, either in the gastroenterology and writing the guidelines, because I thought this would give. And I did, that made me get into the fish pagan, which I showed you as the Young Investigator Award in 2000, my first, and now I'm a council member of Fish Pagan, and of course the first lady from Asia and the first lady from Commonwealth and India. So we write the global guidelines. We wrote for B twice, then C, then the fatty liver. I'm talking only of liver right now. GI is like, magnets and foreign bodies, whatever. So that was putting me into the global scenario, and continued getting Commonwealth meetings in India and being with the ministry and talking with them. So what was my role in research? Only in liver I'm talking about, because pancreas is something I did a lot of work in neonatal cholestasis and about this fatty liver icon study and liver failure transplant. So my publications have been in this part with a lot of this thing, and I've been into media and teaching, and I think celebrating life with children post-transplant is a lot of achievements. So to sum up, the early years, we had limited resources. Then actually we started ulta. We started with liver transplant, then we worked on the other hepatology part, imaging part and all, and the evolution and supportive and targeted therapy. But still, there was a lot of issues of accessibility, affordability, training, research, better awareness. So I think in the future, I'm extending my hands to you all. We need collaboration among clinicians, researchers, and policy makers. We need to promote organ donation in our country, development of advanced services and transplant in a limited public sector. Everybody thinks it's a big fashion icon to do transplants. It's not. They just do it, whatever the results is. That's not exactly. We need to identify different centers in different parts of the India, rather than saying me, time to say we, because team is the key. It's not me, everybody is rowing together. So whatever I could achieve was a good that I can talk about the success, but all that I can say is with my new role on as the President-elect IAP, I have miles to go before I sleep, and together we are shaping the future where no child is with liver disease left behind. And as we say, every child anywhere, as an IPN, I would say, has the right to get the best of health facility and survive. So success is to bring meaningful changes, and I'm so grateful to my residents who work round the clock. They all helped me in getting this meaningful changes, and I truly enjoyed my journey. As Kelly Kim says, it is about benefiting others and enjoying the journey. So invite you all to Pedicon 2026 in Calcutta.
Fantastic. That was a fantastic oration. Could you please stand and have a great round of applause for ma'am? It was one of the best oration we have heard of a long time. And can we have a chair on the dais, please? Any staff from the... Now we'll be felicitating. Dr. Madam Neelam Mohan. Our chairpersons will be felicitating her.
Now our President of Howrah Academy of Pediatrics, Dr. Obhijit Sarkar, will felicitate Madam with the shawl. And I will request the MLA of Bali and our own member of the HAP, Dr. Rana Chatterjee, to felicitate with the plaque. Felicitate with the plaque. I'll request Dr. Torun Samanto, the newly elected Secretary of Howrah Academy of Pediatrics, and Dr. Indu Surana, please come to present a sari. Neelam ma'am, present the sari on behalf of us. So please show. So this is by Indu. No, that is something different. So Neelam ma'am, I will just request you to hand over the memento to our Dr. Rana Chatterjee, the chairperson of the session, and Atanu Bhadra. Oh, Atanu has got it. Got it previously.
No coin, it's just a pen drive.
No, no. There is a gold coin.
Someone Roy has told me that the gold coin is for me and don't tell others.
Thank you, ma'am. Thank you.
We'll take a group photograph. With Sopan also, then he'll say.
Dr. Kasi, please. Deepa Sindhu. Tejaswini, the tutor of dancing of Dr. Neelam ma'am. Tejaswini is there. Yeah. She is there. Mihir, please. The Secretary of West Bengal Academy of Pediatrics. So our right hand.
There could have been no place better than Calcutta for me to have been crowned as president. I'm so happy that I'm going to be in the city of joy.
Thank you. Thank you. Has got her flight at 3 p.m. So we have to just make a change from our schedule. So we will be doing the inauguration right now. Okay. So just a simple twist.
Hey, Rana.
So I'll request also the pharma person to be present here. All the pharma company representative to be present over here. My friends and dear guests, welcome to the 18th Howrah Pedicon in this beautiful venue. Hope you are enjoying the academic feast because there was a lovely oration by none other than Dr. Neelam Mohan ma'am. We assure you that you would be touched by our warm and hearty hospitality. Next. To start.
So now we start the inauguration, and today it is our proud privilege to get Dr. Neelam Mohan here in Howrah. So I would like a big round of applause for her after the excellent oration we had. Thank you, ma'am, for accepting our invitation and being here. And we also have our privilege to have Dr. Srinivas Kasi, sir, our special guest. And I would request both Dr. Neelam and Dr. Kasi to please grace the dais.
I'll request all the persons standing at the back, please be seated. So please be seated. All the persons sitting at the back, please don't gossip. We will take a very little time for the inauguration. Prasenjit, Rana and Prohitro, please be seated, please.
Then I would request our chief guest, Dr. Vijay Kejriwal, to please come to the dais, sir. He is the person whom Shapunda would like to introduce.
Yeah. Actually, Howrah Academy of Pediatrics was born in Alpha Children's Center. So it was his magnanimity that he has allowed a room and the floor to use for our daily these seminars and all that. But he never agreed to be the president of the Howrah. So we are really thankful that he ultimately agreed to be our chief guest today. So we are just paying our respect to you, sir.
Dr. Sujoy Chakraborty, the president, but I think he is not able to attend it. He'll be here in a short time. I would request Dr. Rana Chatterjee to be on the dais, please.
Good. Now I request Dr. Abhijit Sarkar, the newly elected president of Howrah Academy of Pediatrics 2025, to come over the dais, and want a big round of applause for the most energetic and organized person. So Abhijit was the first secretary of HAP in 2023 and 2024, and Howrah Academy of Pediatrics has gained a tremendous momentum during his tenure as the secretary.
Then I would request Dr. Torun Shamanto, who is the newly elected secretary of Howrah Academy of Pediatrics, a very hard-working person and a very down-to-earth person. Torunda, please come to the dais.
Dr. Subhashish Sarkar. He is the senior member of the Howrah Academy of Pediatrics. I'll request Dr. Subhashish Sarkar to come over the dais. Subhashish, please. Dr. Anup Mongol, our past president of Howrah Academy of Pediatrics. Anup, please come over the dais.
Now I would request the person on the podium, Dr. Shopan Roy, the president of WBAP, to come to the dais, please. I would request Dr. Mihir Sarkar, the very energetic, the very academic person of West Bengal Academy of Pediatrics, to please come to the dais. The national treasurer, Dr. Atanu Bhadro, to be on the dais. Dr. Atanu Bhadro, I think he will join, I think. And I would request Tejashwini and Chaitali to please felicitate them with the flower bouquet each. We'll move ahead with the inauguration. Can you please play the inauguration song? There is a lamp lighting and we have some floating candles today. So please start the inauguration song. And I would request all the dignitaries to please come.
Sarara, Kota, May I request Dr. Shukanta sir to kindly come up on stage?
Prosenjit da, Shukanta da, if I am missing, Shubroto da, please come. Kikadi. Dr. Prosenjit Banerjee, Dr. Prosenjit Ghosh, Dr. Kripa Sindhu Chatterjee, Amita, please come. Vinaya Swa, Vinaya, please come. And Tejashini Choitali, please. So I'll request everybody to take their seats. So please, we will want to proceed further. Please take your seats. Please come. Now I will call Dr. Sujay Chakraborty, but he is not here. So I'll request Dr. Indu Surana, our past president, to hand over the presidential medallion to our newly elected president, Dr. Abhijit Sarkar. A big round of applause for him. Madam, please be there. Now our revered member, Dr. Subhashish Sarkar and Dr. Onum Mangal have been serving the children of Howrah for years, and they are very active members of Howrah Academy of Pediatrics. We feel our pleasure to felicitate them with the Lifetime Achievement Awards for this year. Sir, so I request Dr. Abhijit Sarkar to felicitate Dr. Onum Mangal and Dr. Subhashish Sarkar. ঠিক আছে okay. So it's a Lifetime Achievement Award. Dr. Obi Sarkar has served the children of Howrah for long, decades. Yeah. So I'll request Neelam madam to please give the medallion. Obi, please accept it. Subhashis. So Onum Mongolda, please. So I'll request Neelam Mohan ma'am and Dr. Kasi sir, please come forward. Dr. Kasi sir, please. So Onubda is the institution. In fact, I remember when Tapunda was there, we have arranged a meeting of vaccination in Onubda's clinic itself. There was participation of more than 50 people. So he has got a chamber of 3-room flat and behind the cinema hall. The name is Ajanta, na? The name is Ajanta. Sujata. And he does century every day. He is the only doctor in Howrah to do the century every day. Am I right, Onubda? So please be seated. Now I'll request our first secretary, Dr. Obi Sarkar, be please here. So please change the medallion to our new secretary, Dr. Torun Samanto. So we have got our chief guest, Dr. Bijay Kejriwal. So I'll request Dr. Neelam Mohan ma'am to felicitate Dr. Kejriwal. And please make him agree to become the president of Howrah Academy of Pediatrics. He will not be able to say no to you. Sir, this is our humble request, sir.
Wish you all the best and do a lot of work for children of Howrah. Plan something. This is a responsible job. Take it only when दिल से आवाज आए.
मेरी आवाज़ दिल से ही आएगी.
देखा? जब ये मान नहीं रहा तो इसको जिगर और दिल का याद दिलाया तो फिर ये अब जिगर से ले रहा है, दिल से ही नहीं.
I am really feeling honored and express my heartfelt gratitude to all the members of Howrah Academy of Pediatrics, particularly Sapanda, always energetic, always dynamic. I have no words to express my feelings. The way we started Howrah Academy of Pediatrics initially in Alpha Children's Center on a daily basis or weekly basis, we used to sit together, laugh, chat, and now the day Pedicon 18, I am here as a chief guest by courtesy of you all in front of President-elect Dr. Neelam Mohan. I have God blessings with me. I have nothing more to say.
Thank you.
I heard Dr. Neelam Mohan in Hyderabad. I was so fascinating talk, so innovative. How a person, human being, in his or her life can achieve so much. I have no words to express. And then after listening to her talk, I requested her, ma'am, I want a selfie with you. And she readily agreed, despite so busy people surrounding her, and she gave me a selfie.
No, she loves it. She loves this request. No.
Out of fear, मैंने भेजा नहीं. मैंने बोला, madam. So thank you so much. Thank you, Sapanda, for giving me the opportunity. And you are the one person who keeps me motivated. And the whole young new team you have brought to Howrah Pedicon. And we see the Pedicon 26 Kolkata will be a face to remember with Dr. Neelam Mohan and West Bengal Pediatric Association organizing the event. Thank you so much.
Thank you, sir. Thank you, sir. Now I'll request Dr. Subhashish Sarkar, who has achieved the lifetime achievement, to say a few words, sir. Very short.
আজকে তো আমার কিছু বলার নেই,
আমি আপ্লুত, শুধু আমি একটা কবিতা লিখেছি, সেইটা একটু পড়ে শোনাই, খুব ছোট্ট। মনে পড়ে আজ কবেকার সেই কথা, কবি সুকান্ত লিখেছিলেন এক মনে, যেন মনে হয় আমারই হৃদয় গান, ছড়িয়ে আছে লেখাটির আকুলতা। চলে যাব তবু আজ যতক্ষণ দেহে আছে প্রাণ, প্রাণপণে পৃথিবীর সরাব জঞ্জাল। এ বিশ্বকে এ শিশুর বাসযোগ্য করে যাব আমি, নবজাতকের কাছে এ আমার দৃঢ় অঙ্গীকার। সেই কাজ নিয়ে জীবন গেছে, সময় চলেছে সময়ের সাম্পানে, কত শত শিশু ছুঁয়েছে আমার হাত, তাদের মুখের হাসিটুকু বেঁচে আছে। হাসি কান্নার এই যে জগতে চলা, সে চলার মাঝে সত্যকে ধরা চাই, ভবিষ্যতের শিশুদের পথে যেন পড়ে না থাকুক মল জঞ্জাল ছাই। সূচি সুন্দর শিশুরা আসবে আলো, অন্ধকারের হয়ে যাবে যবনিকা, আমাদের কাজ ওদেরকে ভালো রাখা, কেটে যাবে কালো ধোঁয়া হয়ে যাবে ফিকা। আমার কাজ তো করে গেছি নিষ্ঠায়, ফাঁক ও ফাঁকির দরজায় দিয়ে তালা, যে কদিন পৃথিবীতে আছি আরও, সাঙ্গ হবে না শিশু ট্রিটমেন্ট সারা। আপনারা আজ যে আমাকে সম্মাননা দিলেন, আমার হৃদয় কানায় কানায় পূর্ণ হলো, মাথা নত হলো চরণ ধুরার তলে। কাজের সঙ্গী আপনারাই তো ছিলেন, ভালো থাকবেন, ভালো রাখবেন সব। আমাদের দেশ ক্রমশ ডাকছে কালোয়, শিশুদের হাতে বই তুলে দিন, প্রিয় মোবাইল ছেড়ে ওদের ফেরান আলোয়। বেরিয়ে আসুন শিশুর হাতটি ধরে, হয় কাছাকাছি কিংবা একটু দূরে, সত্য শেখান মিথ্যেকে ঠেলে ফেলে, গল্প অথবা গান হোক সুরে সুরে। সবাইকে আমার প্রণাম, সবাই ভালো থাকুন। আমি যতদিন পৃথিবীতে থাকব সবাইকেই আমি প্রণাম জানাচ্ছি। নমস্কার।
I would request Dr. Anup Mangal to say a few words.
Good morning, everybody. I am very much grateful to the present Academy of Pediatrics Howrah branch to inviting me and felicitate me in these prizes. I will try to keep the prestige of this prize for a long, whenever I will be available, and I will also help the 26 Pedicon in my organizing capacity, whichever I've done in many occasions. I thanks to Howrah Academy of Pediatrics again and again to felicitate me in this regard. Thank you, everybody.
I would request the President of WBAP, Dr. Shopon Rai, to say a few words, please.
Thank you, Indu, for giving me the opportunity. I am not only the president, in fact, I am of Howrah. So we have tried our level best to showcase our energy and the academics Howrah. It is the 18th year, and it is our proud privilege to have Dr. Neelam Mohan ma'am, the President-elect 2025 in this occasion, and she has already delivered the Malavik Vishwas Memorial Oration. And we have the vaccine guru, Dr. Kasi. I am still a student of him. Every Thursday evening, I just wait for him. And we have got our friends, Obhijit, Rana, Mihir, Otonu, and Torun, Onubda, and Shubhashishda, and always Sukanta Chatterjee sir. So I think you will enjoy the academic feast, and also the enjoy the gustatory delights also. Thank you so much. Please enjoy.
I would request our incoming president and outgoing secretary, the very dynamic Abhijit Da, to please say a few words. And we hope that you still be as dynamic as you were when you were the secretary.
Well, thank you so much, Indu, for giving me the chance to speak. It is my honor, actually, and a privilege to stand before you today as the newly entitled president of the Howrah branch of IIP, Howrah Academy of Pediatrics. I'm deeply grateful to the trust and confidence you have placed in me, and I accept the responsibility with humility, dedication, and a strong commitment to our shared mission. First and foremost, I'd like to express my heartfelt gratitude to my predecessors whose leadership and vision have actually made this organization as to what it is today. Howrah Academy, with under 1,000 members, is one of the leading district branches of IIP in the whole of India, being recognized for its active participation and enthusiasm in various activities, events, and those of the CIIP activities as well throughout the years. I'd like to take this opportunity to name the members of my team this year. My vice president is Dr. Moshe Mukherjee. My secretary, Dr. Tarun Kumar Shamanto. Joint secretaries, Dr. Choitali Patro and Tejashwani Mitra. Treasurer, Dr. Sharanendu Sarkar. My EB members being Dr. Nibit Chakraborty, Dr. Sanjay De, Dr. Shanti Gir, Dr. Saurabh Manna, Dr. Jayadipta Chatterjee, Dr. Molay Mondol, Dr. Shobhashachi De, Dr. Alok Ranjan Singh, and Dr. Sachin Thakur. I must name those whose absence may result in an existential crisis for organization, actually, because the pillars of Howrah Academy of Pediatrics rest on these people, and they are the great and beloved Dr. Shapan Kumar Rai, he's always there behind us, Dr. Indu Surana, Dr. Vinay Asova, very, very active, obviously Dr. Shuja Chakraborty and Dr. Rana Chatterjee. Senior advisors like Dr. Prasenjit Banerjee and Dr. Anup Mongol continues to guide us with their experience and advice. And during my tenure as president, my focus will be on to strengthen professional development by providing CMEs, mentorships, and CIIP kind of activities throughout the year for all our members. I want to make sure we can bring in young and enthusiastic members to the forefront of our branch activities so that they can come and speak and can become more active. We need to induct more new members in the IIP ambit as well and into our branches. I'd request all those PGTs who are present here, please, if you are not IIP members, get yourself registered with the IIP as associate members at least. And all new pediatricians who are there present, who have not become IIP members, become IIP members. Mr. Shomnath Mukherjee is there today. He'd be able to help you to get your membership done if required. He's there in a bright yellow shirt. Please contact him. Along with that, our branch should get involved into more of social and voluntary activities, helping to kind of integrate with the community at large, the IIP ke baad with the community ke saath concept, and obviously expanding on the idea of IIP for all. However, we all know leadership is not about one individual, it's about the teamwork and collective effort. I urge each of you to actively participate and share your insights and work together to achieve our goal. Thank you. Let's embark on the journey with passion, purpose, and commitment to excellence. Jai Hind, Jai IIP.
Thank you, Abhijit Da. And I would request now the new secretary with Howrah Academy of Pediatrics, Dr. Tarun Shamanto, to say a few words and give his vote of thanks.
Respected guest of honor, Dr. Nilam Mohan, Central President IIP, respected special guest, Dr. Kashi, one of the pillars of Indian vaccination, respected Dr. Vijay Kejriwal, eminent pediatrician of Howrah, and all the distinguished dignitaries on and off the dais. Good afternoon to all of you. I am privileged to have been asked to say a vote of thanks to you. On behalf of Howrah Academy of Pediatrics, I say a big, hearty, warm thanks to especially Dr. Nilam, Dr. Kashim, sir, for giving us time and coming here from your busy schedule. I also thanks all the delegates from different parts of the West Bengal and PGTs for coming here and attending our program. Thanks to them. I must take the opportunity to thank Dr. Atanu Bhadra, National Treasurer, for his continuous support and help in smiling face always. I say thanks to all the pharmaceutical companies who have extended their hands and support our program, and without their support it cannot possible to arrange this sort of program. I hope everyone is enjoying this program. And last but not the least, our event management, Mr. Robit Mukherjee and Mr. Somnath Mukherjee, for their excellent event management. To conclude, I am really honored to have been chosen as Secretary Howrah Academy of Pediatrics, and I am hopeful I will be able to perform my duties and responsibilities under guidance of Dr. Shapon Rai, Dr. Binay Ashwa, Dr. Indu Surana, Dr. Rana Chatterjee, Dr. Abhijit Sarkar, and Dr. Sujay Chakraborty, and all the members of Howrah Academy of Pediatrics. And hope in coming year also we will arrange same sort of program, and hope you will be present there, and with your help and presence we will continue this sort of program. Thank you.
So here we conclude our inauguration session. We will start the academic session right now. So, Atanu, you want to say anything?
Thank you, and what can I say? In Howrah Academy of Pediatrics, I have been part of the journey of many of the branches of West Bengal, but Howrah is very special, and it shows in it the president of WBAP, the vice president of WBAP, and the treasurer of WBAP are all from this branch. So it's a very special, and I hope that the continuity goes on, and we will have much more, many more of the luminaries coming up from this branch. And please, on 15th of this month at Hotel Stadel, post lunch, we'll have an informal organizing team meeting, and Dr. Neelam ji will send her wishes on that program also, and I'll be requesting all of you, you are invited just now, this moment, officially to be present at that and be part of the organizing team, because Pedicon 2026 is a huge thing. It's a matter of prestige for West Bengal, for East, and a matter of prestige for our President 2026, Dr. Neelam ji. So let us all rise to the occasion and be present. Before that, we'll have many more options to meet together. But the first meeting will be on 15th of this month, 1 p.m. at Hotel Stadel. Thank you.
We are a bit unfortunate that Dr. Neelam Mohan ma'am have to leave for her flight. So possibly we will miss in the next sessions and the cultural event in the night. So madam, say just bye to all these delegates over here.
Respected seniors on the dais, if I start taking names, because I know he's very bossy, if he said bye, I cannot start with a hi. And Atanu said a lot about him, but सबसे important बात तो भूल ही गया कि वेस्ट बंगाल के ये से बोलता रहा, बिग बी पेडिकॉन भी यहीं से है. So Big B is also responsible for a very important post in the Pedicon, and that's what I have to say. And I think just before I can say bye, all that I wanted to say is that the warmth on your faces, in your eyes, in your heart, mean a lot to me. And I want to say a sincere thank for all the love, affection, and felicitation, not only from my heart, but from my liver. Because when you love somebody in Hindi, you will never say mere dil ka tukda. You will say mere jigar ka tukda. So when everybody tells you atanu बढ़िया है या स्वप्न है, बोलो दोनों दिल है, जिगर तो नीलम ही है. तो वो खुश हो गया, मैं और खुश हो गई. So with that, thank you all for having, and we really need to make it rock. We've got to work, and make it one of the most memorable Pedicons that we can ever have. And I'm going to say to Swapan, क्योंकि मैं dinner miss करूँगी, which is going to be Bridge Usaid is going to send me a ticket to have a dinner at the. And the next meeting, whenever you all do Howrah, I will not come in the day. I'll come for the evening so that I can enjoy the dinner too. Thank you so much.
Thank you, ma'am. Now we conclude our session of this inauguration. So please.
Next session for the day, questions that matter, hexavalent vaccine. I would like to request Dr. Abhijit Sarkar sir to kindly come up on stage. Also, I would like to request the chairpersons for this session, Dr. Keka Dotto ma'am and Dr. Noni Gopal Chakraborty sir, to kindly come and grace our dais. Dr. Keka Dotto ma'am, Dr. Noni Gopal Chakraborty sir.
Hello, check. Hello, check.
Our next session is on different aspects of hexavalent vaccines. Speaker will be Dr. Abhijit Sarkar. I don't think he needs any introduction. He himself is his introduction. But it is a protocol to say something. Dr. Sarkar is senior pediatric consultant at Narayana Hospital and Bhagirathi Neutia Child Hospital and Park Clinic, ex-HOD Pediatric Medicine Narayana Hospital, ex-Senior Pediatric Registrar, Surrey and Sussex NHS Trust UK, Chairperson Immunization Committee, West Bengal Academy of Pediatrics, Executive Body Member, West Bengal Academy 2022 to 2024, Secretary, Howrah Academy of Pediatrics, and currently he is the President. I am requesting him to start the session.
Thank you, Nonida. Thank you. With the kind of permission of the chair, I am starting the session. Now, this is a sponsored session. This is sponsored by GSK, and the slide deck is GSK's. I am just presenting the slide deck. Now, today, basically, this is to choose the right hexavalent vaccine. There are a few hexavalent vaccines. How to choose the right hexavalent vaccine, the questions that would matter in doing so. Because choosing the right vaccine for the little one is the right thing to do. This is a sponsored session. Now, how to choose, why do we choose combination vaccine? What are the available data on the immunogenicity of the three-component acellular hexavalent vaccine, that is the GSK's vaccine, Infanrix Hexa? The data available on Infanrix Hexa's
effect on the disease burden and how safe is it as compared to wholesale vaccine and the other acellular hexavalent vaccine, which is a 2-component hexavalent vaccine from Sanofi, the Hexaxim. So we'll basically talk about why choose a combination vaccine. We all know that because it's just one jab and it protects so many diseases, either 6 or 5 diseases at one go. It's a convenience for the patient, for the parents, for the doctors. The compliance increases, the pain decreases, the cost factor is also kind of beneficial. And throughout the globe, that is what's recommended. Use combination vaccine if it's feasible. Again, comparing between the pentavalent and the hexavalent, the same principle applies. Why should we do that? Because again, it increases the coverage with a single prick. Now, what are the data available on the immunogenicity of Infanteris hexa? That is the 3-component acellular hexavalent vaccine from GSK, immunogenicity-wise. Now, there are some questions regarding acellular vaccine. There's a concept. There is that wholesale vaccines are better protection than acellular vaccines. When we'll have to look into the details of it to find out what is the basis of this discussion. Now, if you look at the hexavalent vaccine seroprotectivity, now different countries throughout the world uses different kind of schedule, like 2, 3, 4 month schedule, 2, 4, 6 month schedule, 3, 4, 5 month schedule, 6, 10, 14 weeks schedule of India. And throughout the world, in all the schedules, it shows that the seropositivity rates for all the antigens in the hexavalent vaccine after the primary and the booster vaccination series are pretty high. It's almost all of them shows over 95%. It's 96 to 98% protection rate. So the vaccine is definitely effective. Otherwise, this data wouldn't have been available. Now, from an Indian perspective, this study between either 6 and 14 weeks or 2, 4, 6 months schedule, Infanteris hexa, if you look at the antigens, over 98% protective rates against all the antigens. On the top band, all the antigens except the hepatitis shows that it's almost 100% of the babies will reach seroprotective levels. And the lower band gives the 3 components against the pertussis antigens. Again, very good protection after the 3 primary doses. It's almost 98 to 100% protective rates, and all the infants, in the infants were vaccinated with this Infanteris hexa. Now, this is a study which was basically published by Dr. A.J. Chitkara in 2019 in the current status vaccines in India, hexavalent vaccines in India. There was a comparison with Hexaxim, Infanteris hexa, along with the 2-component hexa and the wholesale hexa vaccine. Now, if you look at the antigenic kind of immunogenicity and the kids kind of reaching the seroprotective level, the levels are either at par with the other 2 vaccines or better than that, better than other 2 for the Infanteris hexa. The Infanteris hexa is the lower band, basically. Talking about the wholesale vaccines' protective efficacy against pertussis as compared to acellular pertussis. Different studies have been done. On the left side, there are various studies throughout the world in different countries using different vaccine schedules show that the efficacy against pertussis using the wholesale vaccine, studies can report an efficacy from anywhere between 30 to 96% protection efficacy. Whereas when people looked at the protective efficacy of acellular vaccine, it's more consistent. The protection is around 70 to 90% in most of the studies. Infanteris hexa is the only hexavalent vaccine with 89% efficacy included in its label against pertussis, whereas the acellular one, the 2-component one of Sanofi gives around 74%, and there is no data available for the wholesale vaccine. So what is the data available on long-term impact of Infanteris hexa? Because when we talk about acellular vaccine, we are talking about the long-term protection against pertussis. But there is the question, does it give enough protection against pertussis if we use an acellular vaccine as compared to wholesale vaccine? Now, there is a discussion that wholesale vaccine provides long-term protection. Now, long-term protection, yes, no doubt about that. But does it give lifelong protection? We'll have to look into that. All vaccines, in fact, even natural infection will show waning of immunity. So we'll have to take this quote into proper context. Let's look at that. Now, initially it was thought natural infection, which is thought to be the most robust immunity which will give after an infection, Initially, it was thought it will give almost lifelong immunity. But then, as more and more data started coming in, we know that it's not giving long-term immunity. Even natural infection does not give long-term, lifelong immunity. So this study from Italy, they used Infanteris hexa for 3+1 schedule. That is, they used in the 3 primary schedule plus 1 dose in the second year of life. And then they basically measured the seroprotective levels at around 7 to 9 years of age in children. These children did not have the school entry booster at 5 years. What did they find? They find that after the 4th dose of Infanteris hexa, in the subjects who had not received the additional booster dose at school entry, the seroprotective antibody levels persisted up to 9 years of age in over 90% of subjects for diphtheria, Hib, and polio. It's 77% for hepatitis B, and some 64% of the subjects for tetanus. So basically for hepatitis B, by 9 years, the seroprotective level drops in significant amount of children, and more significant in tetanus. Now we all know hepatitis B has a long incubation period. So because of the immune memory and anamnestic response, if an infection happens, there'll be sharp increase in the antibody, and the kind of infection would be protected. Tetanus needs booster, so we continue to give booster. Now if you look at the the pertussis component, that's the third one from the left, it's pretty low. The anti-pertussis toxins, by that time, actually remains detectable in no more than 38% of the subjects. So that decreases quite a lot. Now, low anti-pertussis antibody concentration actually attests to the fact that there was an absence of pertussis infection during that period. The last one booster was given at second year of life, and now this test is done is around 7 to 9 years of age. So between 5 to 7 years in between, probably there was no natural infection to boost immunity again, so it remained low. So basically, it's a roundabout way of showing that the vaccine was effective in preventing infection in the population. This slide I'll skip. This basically comments on the hepatitis B protection, which we all know because of the long-term immunity, it'll give protection. Long-term incubation period, it'll give protection if there's an infection. Infanteris hexa has the longest follow-up of immune response for all antigens, including pertussis. If you look at it, pertussis efficacy follow-up for Infanteris hexa is up to 5 years, whereas the hexaxim has no available data. For all antigens, 7-year follow-up Infanteris hexa, but for hexaxim, it's about 4.5 years. And there is no data on the whole cell vaccine, which are available. A study from Madrid in Spain showed how the vaccine effectiveness with an acellular component vaccine in the 3+1 scheduling in the national health immunization. Over some 12 years, the vaccine efficacy drops slight marginally from initially 98.8% to around 85%. It's a slight drop. And this country started using the Infanteris hexa since around 2007 onwards. So there is no significant drop in the vaccine efficacy. So 3+1 schedule was associated with a high vaccine effectiveness, which gradually kind of waned from around 98 to 85%. Not significant waning at all. So this vaccine proves, in this country at least, to be pretty effective. In Italy, this is a study from Italy. In Italy, they started with a national immunization DTaP program from 1961 with the whole cell vaccine. You can see how the pertussis incidence has dropped after 1961. And since 2006, they converted from the whole cell to the acellular vaccine, Infanteris hexa. In spite of that, the incidence of pertussis continues to decrease at the last part of the graph. So it means that there is no resurgence of pertussis infection even after changeover to an acellular vaccine that is Infanteris hexa. This again proves that the vaccine is effective in protecting against pertussis. How safe is this vaccine? The Infanteris hexa, the 3-component acellular vaccine, as compared to whole cell, or even compared with the 2-component acellular from Sanofi. So let's look at it. More than 17 years of worldwide post-marketing safety surveillance has been done. Over 150 million doses of this vaccine has been given since 2017. There has been no reported interruptions to vaccination program due to any safety errors anywhere. And the 10 most frequently spontaneously reported events occurred at a less than 8 per lakh in doses. And reporting of preparation errors, that is, while reconstitution was low and did not impact the vaccine's benefit-risk ratio. And most of the side effects on the right side, we all know about those, are pretty low in incidence. And this forest graph shows the risk of generalized reaction was increased by 3 times in wholesale vaccine as compared to the cellular vaccine. Injection site tenderness were increased by 4 times. And the first dose wholesale vaccine versus the first dose cellular vaccine, the risk of fever was pretty high. It was almost 9-fold for the wholesale vaccine. We are aware of this. And when we talk about a kind of severe side effects, again, the incidences are very low. It's low for wholesale, but it's lower, slightly lower than wholesale as compared to in cases of a cellular vaccine. Adverse events, if we look at it, there's a 4 times less fever using the cellular vaccine as compared to the wholesale. 5 times less redness or less swelling or even less pain. A systematic literature review was done and meta-analysis of the solicited local and systemic adverse events of the 2 acellular hexavalent vaccine. That is comparison between the Infanrix hexa and the Hexaxim actually. It's not the wholesale vaccine, but 2 acellular vaccine. One is Infanrix hexa and the Hexaxim. And what did this study show? Overall, Infanrix hexa has a more favorable tolerability profile than the 2-component one from Sanofi. In the local reactions, it favors Infanrix hexa. The systemic reactions, again, favors Infanrix hexa. So how relevant is that information to your clinical practice? The fewer children will actually experience adverse reactions with Infanrix hexa compared with Hexaxim. For every 100 children that you vaccinate, use of Infanrix hexa over Hexaxim would avert, on an average, 10 cases of fever, 7 cases of redness, 6 cases of pain, and 4 cases of grade 3 systemic side reactions, if you compare both the vaccines. Interestingly, France has used both the vaccines in the immunization program, either the 3-component or the 2-component. And there was a mathematical projections to safety from Mukherjee et al. With a meta-analysis. They did that in that country. What did they achieve? So with a single dose of these 2 vaccines, adverse reactions avoided goes into thousands because this is a national immunization program. And over 5 years, this could be avoided over 1.4 million adverse reactions in France when using 1 dose of either this or the other vaccine, where it favors the Infanrix hexa. So on an average, on a global experience, Infanrix hexa is the only hexavalent vaccine with more than 20 years of use in clinical practice. It has been used in over 100 clinical trials. It is registered in over 94 countries, and more than 6 crore kids have been vaccinated with this. And in summary, combination vaccines provides better convenience. The 3-component acellular hexavalent vaccine from GSK Infanrix hexa has shown high seroprotection against all antigens and led to better efficacy against available Indian vaccines. This vaccine has the longest follow-up of immune response for all the antigens, including pertussis. And this vaccine demonstrated sustained protection in real-world settings. In terms of safety, not only in comparison to wholesale, but in comparison to the other acellular vaccine, this has a demonstrated superior safety outcome at clinic and at population level as well. Thank you so much. Thanks.
Thank you, Dr. Sarkar, for your very lucid deliberation, always very interesting. And the usage of hexavalent vaccines are increasing by the day, and I'm sure the audience has benefited immensely from your talk. Thank you.
Thank you, ma'am. Thanks.
I would request Dr. Abhijit Sarkar sir to kindly felicitate our chairpersons and hand over the mementos. I would request Dr. Keka Datta ma'am and Dr. Noni Gopal Chakraborty sir to kindly hand over the memento to sir. Thank you, sir. Thank you, ma'am. Thank you, sir.
Just one announcement by Dr. Pavitro.
Thanks for the organizers for the wonderful conference we are having here. So I'm Dr. Pavitra Chakraborty. I'm from coming from Newtown. So I'm at the present the organizing secretary of the Society of Pediatric Gastroenterology, Hepatology and Nutrition. As you know, we are associated with Dr. Neelam Mohan with the ISWAGAN. But right now, we are organizing the annual West Bengal Pediatric Gastrocon, which is on next Sunday. I know this Sunday you're busy, and it's going to be just next Sunday. It will be at National Medical College, Ophthalmology Department, 3rd floor. So you can please make your subscriptions. I think it's normal is only 500 rupees, but today we are giving an offer of only 400 rupees. Now the main thing, when I spoke to my colleagues and dear old friends, they were saying that, oh, khane jabo, the topics will be very difficult to understand, what is it for to do with us. But I can assure you, I am basically a general pediatrician. I am not a specialist gastroenterologist. I don't do endoscopy. When I am the organizing secretary, means it will be something which I can understand, means you can understand. I am very much a general pediatrician, okay? And you take it from me, all the top bosses, right from Dr. Neelam Mohan to Dr. Thapar, who is not here today, right? When we did our annual ISWAGAN, the program should be highlighted 90% towards the PGTs and the general pediatrician, who are the heart and soul of the practice, okay? So it's our guarantee. So apni ashun, the topics I am giving very briefly, I won't take much time. So one is like something like how to interpret abnormal LFT. মাঝে মাঝে আপনার কাছে পেশেন্ট আসবে যে LFT করেছি abnormal. তারপর ধরে নিন lower GI bleeding, আমি just 2 minutes হয়ে গেছে. So these are very common topics. So please come, you can register today, next Sunday. Okay. Thank you so much.
Thank you. So now I would request all the delegates who was just roaming about in the garden and enjoying the tea, snacks and everything, please come in the hall. We are going to start our most prestigious oration, Dr. Manoj Mukherjee Memorial Oration. It will be given by none other than Dr. S.G. Kasi. So pura sir, S.G. Kasi bol raha hai sir. So please come on the dais, and this session will be chaired by our President of Howrah Academy of Pediatrics, Dr. Abhijit Sarkar, and Secretary, Dr. Torun Samanto. So Doctor, please felicitate Dr. Kasi with the Medal of Oration. Tejashwini and Choitali, please come. Sir, I'll request you to garland our beloved Professor Manoj Mukherjee, sir. So I'll request Dr. Abhijit Sarkar to introduce Dr. S.G. Kasi, sir.
Do I really need to do this, actually? Dr. Kasi is a guru, we have already said that, and he's a very respectable person. This is a protocol why I should be doing, so that's why I'm doing. Dr. Kasi hails from Bangalore. He has been the past president of IIP Bangalore. He has been the past vice president of IIP National Respiratory Chapter. As for the ACVIP, he has been the member of that organization since 2011-2013. He has been the convener of ACVIP 2020 to 2021. He has been the advisor of ACVIP from 2022 to 2023. He is the editor of our Vaccine Bible, the Purple Book, and he has been the editor of IIP Question and Answer in Vaccinology. Is a very favorite book for us. He has contributed chapters on vaccinology in various IIP textbooks, and he has delivered 6 orations, 4 endowment lectures. Welcome, Dr. Kasi. Thank you so much for being here. Thank you. We're eager to
So
hear
I'll
you.
request Dr. Kasi to take the stage. Sir, please.
Thank you, chairpersons. At the outset, my sincere thanks to the organizing committee of Howrah Pedicon 2025 and Dr. Swapan in particular for inviting me to deliver this prestigious Dr. Manas Mukherjee oration. It's been a wonderful day so far. Good academics, lots of love and affection. Excellent venue. On one side you have history, on the other side the serene river. A very inspiring oration by Dr. Neelam Mohan. And I wish this day continues forever. So, today I'm going to talk on something practically everyone in this audience is guilty of at some time or the other. Everyone has made some mistakes, either vaccine or non-vaccine related in the course of our clinical practice. We are ashamed to talk of it, but we do not want that to happen again. We must understand that to make mistakes is human behavior. You just cannot avoid it. But what we must do is learn from our mistakes so that we don't commit that again. So, what is a vaccination error? It is any preventable event or events arising from the inappropriate use of vaccine. Please mark every word. This can occur at any step, right from the time you prescribe it, from the time it is dispensed, in case you're in a hospital setting, during preparation, during administration, post-vaccination, when you have to monitor, or even where the storage is done. At any stage it can occur. It may result either in an inadequate immune response. It may increase adverse effects, like if you give a live attenuated vaccine to a child who is immunocompromised. All these leads to a reduction in confidence and potential injuries to the healthcare system. Basically, this will promote vaccine hesitancy, which should not occur at any cost. Before we go further, let's understand the difference between an error and a fault. Okay? Error results from a discrepancy between action and intent in a given context. You want to do the best for the child. Somewhere an error creeps in, and you realize that that error has occurred only after the event has been completed. Get the point? On the other hand, fault is a violation of a known rule. It is voluntary, it is deliberate, it is negligency. So there's a world of difference between error and a fault. Okay? But both involves some amount of legal issues and also may involve moral sanctity. So we should avoid both. Now, please remember, an error does not become a mistake until you refuse to correct it. So if an error occurs, recognize it, accept it, correct it, and take measures to see that it never recurs again. Is it common? I mean, you may sit back and say, I've never had an error. What does the literature say? Basically, errors occur more in a public health program. At an individual level, it may be less common. Now, this first is a meta-analysis done by Brazilian authors, where they found that the prevalence was about 0.044 per 10,000 doses. Doesn't look too great. But if you come down to children below 5 years who receive the maximum number of vaccine, it goes up to 5 per 10,000 doses, which is quite high. So a corollary of this is that vaccine errors are more common in the youngest age group, specifically below the age of 1 year, where there is a crowding of the immunization schedule and many vaccines have to be given either together or in a serial sequential order. This is a study done by US authors from 5 well-developed countries. Their overall rate was 1.15 per 10,000, much higher than what was reported by the Brazilian study. But look at the range, 0.05, which is almost non-existent, to as high as 17.6 per 10,000. So depending upon the situation, depending where it is done, who is giving the vaccine errors will vary. Europe, they have a very robust surveillance system. 3% of all medication errors were vaccine errors. And if you notice, I think I'll just put the pointer on. Yeah. So if you see, the number of errors from almost a negligible in the beginning of this century has gone up to very high levels, more than 1,000 errors in the year 2016. And quite a few of them also cause adverse effects. Or look at the US VAERS system, which is a passive reporting system, not very accurate, not very robust, but still look at the numbers. Almost 7% of all reported errors were vaccination errors. 75% there was no health issues, 25% there were health issues, and of these 25%, 92% were non-serious, only 8% were serious. This gives a very graphic picture of what is happening in the world today. Now this is same VARS data from USA, gradually increasing over a period of time, and as more and more reports occur, the number of vaccine errors go on increasing. But what happened during COVID times? An explosion of vaccine errors. New vaccines, new populations, we didn't know what to do, we didn't know much about the indications, contraindication. So the vaccine errors as far as COVID has gone up to as high as 17%. Phenomenally high figures. But that's of course not what we are going to observe in our routine practice. Now what are the types of errors that we see? Okay. One, you can either give it the wrong age, you may give the wrong vaccine, there may be an error in doses, there may be an error in timing, interval between two vaccines which were discussed today. Very importantly, expired vaccines, which is not uncommon in our practice. You may give it by the wrong route. Sometimes you may give only the vaccine, or you may give only the diluent. Many such mistakes occur. Now, what is it from the public health point of view? Is it a major burden? This is again data from USA, which looked at over 1.6 million vaccination records. And what they found was, especially where 2 live vaccines have to be given, where at least you have to keep a 4-week interval, they looked at what is the financial burden of invalid doses when it is given too early. Remember, the incidence was almost 0.5%, and look at the cost, close to $800,000 for our public health system. In the subsequent years, when they took some remedial measures, again you had a 0.1% and almost $200,000. So vaccine errors are also costly in addition to being probably harmful. Now, do we have any data from India? Only one record published in 2018 from the AEFI reporting system in the National Immunization Program. Concentrate on these blue bars, which indication immunization error related AEFI. What I said earlier is the maximum errors occur below 1 year, where the maximum number of vaccines are given. But somehow in our own country, the maximum incidence is between 2 and 5 years for inexplicable reasons. Again, as I said, this was a passive surveillance, not an active surveillance, so not very, very robust data. So we don't have much data from the public health system in our own country. We don't have any publications coming from the private sector because we are very disorganized as far as reporting, and we don't want to report errors, but errors do happen. What we must remember is we can commit errors, and the greatest error is believing that I can never do anything wrong. When you do that, you are making a mistake. So recognize your errors. So today's discussion, as I said in an earlier slide, You have to recognize and see that, learn lessons from it. And there are two ways to learn the lessons. You either learn lessons from your own mistakes, or you learn lessons from the mistakes committed by others. So today, the audience is going to listen to mistakes committed by me and many other people who I have interacted with for preparing this particular lectures. There are volumes of it, but this is only volume 1. Okay, so when you detect a vaccination error, what are you going to do? First, is it going to cause any problem? First point. How do I solve the problem if it occurs? And the third is, how can I prevent? So these are the 3 points to be considered whenever a vaccination error occurs. So look at some cases. These are all real cases from either what I have experienced or what people have interacted with me reporting their errors and how we went about solving it. A 9-month healthy infant was inadvertently administered 1 vial of BCG instead of the measles vaccine. And why did it occur? Look at the similarity of the vials. If you're in a hurry, the only difference is the color of the cap and maybe the color of the label. Mistakes can occur, and it has happened innumerable times. Okay? So what do you do in this case? Remember, the dose that you have administered is almost 10 times. 1 BCG vial contains 10 doses. So you're given 10 times the dose. So what is going to happen? And what have you done? You have not given it intradermal, you have given it subcutaneous. So you are going to get an abscess. So how are you going to deal it? First, I think, honesty. Inform the parents that an error has occurred. Counsel them regarding what may happen. And convince them that whatever happens is correctable. Follow up the child. Watch for any complication. Of course, as you all know, if an abscess has formed, like this child developed a nice abscess on the left thigh, it needs to be aspirated if it is big enough. If it's not increasing, one can just leave it alone and wait. It may just subside on its own, because please remember, Mycobacterium bovis does not extensively multiply in the human body. So after some time, the human immune system sort of compartmentalizes it and it disappears. You may find a small calcified nodule in the subcutaneous tissue after a few years. Okay. Now the problem comes 10 times the dose. So should I give antituberculous treatment? The answer is a clear no. In an immunocompetent child, there is no need for preemptive antituberculous treatment. How will you prevent this situation? Check the vial 3 times. See, there's something very interesting about this 3 times, you know. If you do it twice, you can make mistakes. But if you do it 4 or 5 or 6 times, there is no additional advantage over checking over 3 times. CDC says check 3 times. I did a lot of reading about why this 3 times. It has that figure 3 has certain primordial or even cultural significance. See, it is the first continuous number. Okay? 2 is a little more complicated figure compared to 3. If you see, there are so much religious significance. You call the Holy Trinity. So there's something specific about this number 3. Psychologists also say that 3 is a very important figure in memory generation, because it has certain parts of the brain are more receptive to this number 3 rather than any other numerals. So check 3 times, and it's very likely that you will never make any mistake. So remember, check 3 times. And look at this. On your left side, you have a green colored top. On your right side, you have a blue covered top. Both are BCGs. This is onco-BCG, which is used for installation into the bladder. That is our regular BCG. Regular BCG contains, as I told you, about 4 million, or 2 to 8, 10 raised to 6. 10 raised to 6 is 6 zeros after 1, so it comes to about 1 lakh. But look at onco-BCG, 10 raised to 8, 100 to 500 times more quantity of the tuberculous antigen. And in a nursing home, 2 cases which we have handled in Bangalore, and I think Mumbai also had this once this has happened. In a nursing home where vaccines were kept with everything else in the fridge, where a patient with bladder cancer was admitted for installation of onco-BCG. The nurse hurriedly picked it up, drew 0.1 ml and gave it to the newborn child. Immediately the fault was detected. What now? Panic. Okay? In fact, when this question came to me, I was not prepared at all. So I thought, what are the options? Such a massive dose, should I give antituberculous treatment? Or sometimes you see, you can aspirate out the site of the injection and remove as much vaccine as has been deposited. We do that many times. You know, the old practice following snake envenomation was to aspirate out, something like that. Or should I just observe, nothing will happen? Only literature I got was a study from Pakistan. I mean, Pakistanis always do things worse than what we do. Prince Aga Khan Hospital, premier teaching institute, 28 newborns were given onco-BCG in the course of just one day. They didn't have any precedent. So in the published paper, they gave antituberculous therapy. One after the 28 children died, but he died of an intracerebral hemorrhage, which was unrelated to BCG. That gave me confidence that nothing is going to happen. But should I give ATT? No literature, nothing. They have mentioned about 2 times, 5 times, 10 times, but nothing about 200 or 500 times the dose. What I did is, I went to our guru, Dr. Jacob John. His explanation was very simple. Every pathogen is most adapted to one particular host. And this is called host range restriction. So, Mycobacterium bovis, natural host, is the cow, not the humans. So if it is injected into humans, it cannot multiply efficiently. And if that newborn's immune system is competent, it cannot disseminate. Believe me, just on the basis of his opinion, I kept quiet. I followed up the child, and look what happened. This occurred within 24 hours. This is within 24 hours a pustule formed. By day 5, already a scab had formed, and you had a lovely scar by 10 weeks. So we got an accelerated BCG reaction. When the second child came, this happened a few months after the first, of course from a different place. I was more confident. We just waited and it just passed off. But you can very well imagine the amount of anxiety to the treating pediatrician, to someone like me, to the parents, that this mistake. Yes, it is harmless, but your heart will miss a beat when you know that you have given such a massive dose of the vaccine, right? So they look so similar. BCG, measles, and onco-BCG. So first mistake is interchanging vaccines because they look very similar. Vaccines can sound very similar, okay? Look at this, Hexaxim, Hexacil, Pentavac, Pentaxim, EZ4 pole. Of course, nothing great may happen if you interchange, but these errors can occur. So, error number 1, administering the wrong vaccine due to similarities in vaccine vial size, labels, and names. So, let's go to the next type of mistake. Pardon? Yes. So, few examples that I have given. Now, a mother brings her 10-year son and 18 months daughter. She had the second child after a long gap to your clinic for vaccination. The 10 years child has to receive Tdap. The 18-month child has to receive the DTP, IPV, Hib vaccines. They come in, your assistant prepares the vaccine. Just when it's time to give the vaccine, you just attend a phone call, you go to the table, a vial is given into your hand, Tdap is given to the 18-month child, and the pentavalent vaccine is given to the 10-year-old child. Not impossible, it can happen many, many times. So, the first question is, are these doses valid? Second question is, are these doses harmful? And the third is, how do I correct it? 3 things every time an error occurs. So, is Tdap vaccine valid in an 18-month-old child? Okay. First, inform an error has occurred. The CDC recommendation states that if Tdap is given as any one of the 3 primary schedules, that is of 6, 10, 14, it is invalid. But if it is given at 18 months or as a 5 years booster, it's a valid dose. Recommendation. Okay? Fine. But what about hip and IPV? We don't have monovalent hip. We don't have monovalent IPV. And you can't leave the child unprotected. So in essence, you have got to repeat the dose again. And when will you repeat the dose? You can repeat as soon as the error occurs. Okay? Now the next question comes, is the DPT, hip and IPV vaccine valid in the 10 years child? The answer is yes. Here you are giving much higher antigen load than what is necessary. It is definitely effective, but it is going to be highly reactive. You're going to get a lot of reaction locally when you give the full component of P and D in a 10-year-old child. So, how will you prevent such a situation? First child comes in, vaccinates, he goes out. Second child comes in, prepare his vaccines, go out. If you want to prevent, have separate trays for each vaccine and put a small label with the child's name in that tray stating that this is for Sanjay or this is for someone else. So this mistake should not happen. So this is the cause for the second mistake, where you prepare vaccines for administration for all children together when more than one child is in the room for vaccination. Let's come to the third mistake now. You know, a child was due for the 9 months vaccine, TCV and MMR. So your assistant takes out the TCV vial, the MMR and the diluent. In a hurry, she uses TCV as a diluent for MMR, and she loads only the diluent in a separate syringe, and she hands it over to you because you trust her a lot, and you inject the vaccine. Okay? Now the question is it a vaccine error? Will the combined vaccine TCV and MMR work? Should we repeat the dose? When should we repeat the dose? First point, diluents are not interchangeable. Let us be very, very clear about it. No compromise in this aspect. If the wrong diluent is used, the vaccination should always be repeated. So TCV and MMR both are invalid doses. The TCV, you can repeat immediately the moment you realize the error. But as far as MMR is concerned, you give it on the same day or at least 4 weeks after this invalid dose. Okay? Now this spacing is done because there is going to be some response by that vaccine, which you have given. Maybe a suboptimal response, but that may interfere with subsequent take of the vaccine. So either give it on the same day or give it 4 weeks apart. So error number 3, using the wrong diluent or administering only the diluent. This is not fiction, these are facts. Okay? A nice chubby child weighing almost 5 kgs is brought to you for you make some mistake in reading the date of birth. You feel is already 1.5 months old, and you give him the hexavalent, PCV and rotavirus vaccine, 35-day-old child. Or, a 10 weeks child had received the hexavalent vaccine on the 10th of June. The parents had to travel, so they wanted the vaccine earlier, and you said, it's all right, what is there? You administered on the 3rd of July. I think Dr. Kripa Sindhu dealt with it earlier. Just to recapitulate, vaccine doses administered 4 days or more before the minimum age of interval, 4 days or less are considered as invalid. Anything administered 5 or more days later is invalid. And how do you count this? 28 days is valid. When you count the 4 days, don't count day 28. 27, 26, 25, 24. So any vaccine given 23 days or earlier is an invalid dose. So obviously this 35-day-old infant is invalid dose. Even the second case, it's an invalid dose. Okay? Now in this invalid dose, you can repeat the vaccine on the same day or whenever you detect. But the 35-week, what will you do? You have to repeat all the doses when he reaches the proper chronological age. That is, when he reaches the age of 42 days, at that time, though it is only 7 days later, you have got to repeat all the doses. These are the standard recommendations. Okay? So, Error number 4, giving a vaccine earlier than the recommended age of interval. Or you look at this 22-year-old guy going for his MS in US. He received the first dose of varicella vaccine on the 24th of June. Because he was traveling on 21st of July, the second dose was given on 19th of July. Remember, this is a live attenuated vaccine. Is the second dose valid? Is the question that comes to your mind because it is less than 4 weeks. Please remember, for the same antigen live attenuated vaccine, grace period is applicable. So here if you apply the grace period, this is a valid dose. But if it was chickenpox and MMR, 4 weeks is a must. Even 1 day before renders the dose invalid. Okay? So, same earlier. Now, a 19-year individual whom we have seen for quite some time comes to you for the hepatitis vaccine because he is going to a hostel. He has no record of his vaccine. He has never had jaundice in the past. You tell your assistant, hepatitis A vaccine. She never knows that there is an adult formulation because you never store it because we give pediatric till 18 and we don't see anyone above 18. So she takes up one pediatric dose and gives it to the 19-year-old boy. Is it a valid dose? No. Suboptimal doses are invalid. How will you rectify it? Two situations can occur. If you notice it immediately, then your option is to give one more pediatric dose and complete it. Okay? But if you recognize it later, 7 days, 10 days later, the first dose is a suboptimal dose, it becomes invalid. So you got to repeat one more adult dose rather than giving one more pediatric dose. That is the difference in approach if it's recognized immediately versus recognized some days. Now some days, 2 days, 3 days, if it is recognized beyond that particular immunization session, you have to repeat the full dose again. Of course, the question may come, I don't have 1440, give 2 doses of 720. Remember, it is a wrong practice to draw out both in one syringe. You have to give it at 2 separate places, or of course, hepatitis A live. But remember, live hepatitis A is not a CDC recognized vaccine. So for someone who is going to USA, don't give the live attenuated hepatitis A vaccine. Right. So giving the wrong dosage amount for the patient's age. This is something that is extreme. I'm sure all of us, sometime or the other, have experienced this. Okay? And just look at the shock. You have administered the hepatitis A vaccine. You have, ceremoniously put the sticker on his immunization card. Okay? The parents say thank you. They go out. 10 minutes, 15 minutes, mandatory waiting time. 10 minutes later, he barges in. Expired vaccine 3 months ago. Okay, what happens? Your heart misses not one, a few beats. Okay, not one. Important thing, admit your errors before someone else exaggerates it. He goes to your neighborhood doctor who is not on good terms because you have a better practice than him. He's going to exploit that situation. So recognize your own mistake and try to correct it. So, first principle, any vaccine administered after the expiry date is an invalid dose. How do you recognize it? 4A approach. Accept, apologize, assure, and administer. Accept that a mistake has occurred and apologize. First point. Assure that no harm will come. Show him literature which is available that expired dose does not harm of any vaccine. Offer to administer the dose at your own cost. At your own cost. If he says, no, it's all right, quietly take the fees. Otherwise, please try to give it free of cost. Now, when will you administer it? Inactivated vaccine, you can give it immediately, but probably at a different site. If it's a parenteral vaccine, you will not repeat on the same day. You will repeat it 4 weeks later. Why this difference? Please remember, there are studies which show that this expiry date is a legal necessity. I remember I had been to Ahmedabad in the Zydus factory and I met their scientists. They have got stability till 6 months beyond the expiry date. So your expired vaccine, live vaccine, may initiate an immune response, and because you do not want to increase the adverse effect and the antigen load of a live vaccine, you always give it 4 weeks later. Expired vaccine, give 4 weeks later. Don't give it on the same day if it's a live attenuated vaccine. Okay? Now you should be sure of what is an expiry date. See, if the expiry date they says 21st July 2023, means that vaccine is valid till the midnight of 21/7/23. This information is very important when you go on legal issues for this. If the date of expiry is stamped as 21/07/23 means it is valid till the midnight of 21/7/23. If the expiry date has only months, that is 07/23 means it is valid till the last midnight of the last day of that month. So midnight of 31/7/2023. So this is the definition of expiry dates. Keep it in your mind. When you're in a tight corner, this may pull you out. Okay. So avoid such errors. Again, check the expiry date 3 times. I told you why 3, why not 2, why not 4. FIFO, you all are aware, first in, first out. So that you never have expired vaccines lying in your fridge. Now Tdap is being administered to a young adolescent. That guy suddenly pulls his arm, the needle comes out, and you have given less than half the vaccine. So the doctor very nicely changes the needle, cleans the site again, and puts it back. The remaining half of the vaccine. Is this a vaccine error? I know in Oration I'm not supposed to ask questions, but is this a vaccine error? Yes, this is a vaccine error. What is the recommendation? The needle should be considered to be contaminated, so you change the needle. You should also change the contents of the syringe, because once the needle is in the body, in the skin or the muscle, tissue pressure is greater than the pressure in the syringe. Tissue fluid enters the syringe, and that can alter the composition of the vaccine. So the recommendation is you have to start all over, new vaccine, new syringe, new needle, re-swab and give it at a different site. Okay? So, errors during the injection process. Now, Dr. X has taken the typhoid conjugate vaccine pack out of the fridge. He's removed the rubber stopper and affixed the needle. On rechecking, he finds that this kid needs the influenza vaccine. So he puts it back into the box, keeps it back in the fridge. Next morning, next afternoon, another child comes for the typhoid conjugate vaccine. He gives it off. Is it a vaccination error? Yes, it is a vaccination error. So what are the recommendations? A manufacturer-filled syringe is prepared and sealed under sterile conditions by the manufacturer. Most of these do not contain preservatives, so they cannot be stored. Once the sterile seal is opened, it has to be used immediately or within that same immunization session of 4 or 6 hours. Your next question is, will this vaccine work? Yes, definitely it will work because it is within the expiry date. So this vaccine will work, but it is a wrong practice. Error has not occurred, but a mistake has occurred over here. Okay, so not following standard recommendations. Or look at this case, something that happened to one of my colleagues. 5-year-old boy was bought with a category 3 exposure on the left knee and thigh, dog bite. Perfect wound hygiene, immunoglobulin, rabies vaccine as per standard recommendation. Day 29 after the bite, he developed symptoms of rabies and died 2 days later. Everything was done properly. Was this a vaccine error? Why does post-exposure prophylaxis fail? There are many reasons: improper wound care, delayed treatment, incorrect RAG, low potency of vaccine, comorbidities. None of these things was there in the child. Post-mortem was done on this child, and what did they find? 2 small bites in the gluteal region, which was covered by his underwear. Immunoglobulin was not given, and from there the rabies virus entered. So, every child with exposure at stray animals should be stripped and examined for any exposure in hidden areas. So this was a vaccine error because standard protocols were not followed. Okay. Now, a pediatrician, high-heeled pediatrician, elite clientele, mothers never want to lose sleep at night. He advises his parents to give paracetamol half an hour before the vaccine and repeat it 6 hourly for the next 48 hours. Is this practice correct? Yes, I think it's very clear. It's an incorrect practice because when you give a vaccine, these vaccine antigens are taken up by the antigen presenting cells, cytokines are released. When you give an anti-inflammatory, even paracetamol is an anti-inflammatory drug, it suppresses this cytokine response and will affect the immune response to the vaccine. And this has been very clearly demonstrated with PCV10, Synflorix, and PPSV23. But as a generic rule, it applies to all vaccines. So generally, this is not a correct, even if a child is prone to febrile convulsions, it's not a correct thing to do. Probably the only place where you may give it is in a child with Dravet syndrome where you are going to give a vaccine. That's the only place where you may give prophylactic. So errors in the post-vaccination process. You are in a busy OPD. You have just administered the varicella and MMR vaccine to a 16-month toddler. Everything is fine. On the way out, the mom says, casual, oh doctor, I forgot to tell you, this child had MISC about 2 months back and he was treated with IVIG and steroids. So what happens? Your heart misses 1, 2, 3, 4. How many dots have I put? 5 dots, 5 beats. Okay. Now, what are the thoughts? Should I expect any adverse effects? Generally, no, because though he was on high-dose steroids, it has been stopped 2 months back. So that 1 month gap is there. So this child is not immunosuppressed. So there is going to be no adverse effect in spite of giving live attenuated vaccines. The next is, will the vaccine's immunogenicity be affected negatively? That's the next thought. And I think for this, the answer is yes, because your intravenous immunoglobulins will have high titers of varicella and MMR antibodies. That is going to interfere with the take of the vaccine because antibody titers are quite high because you're using that for prophylaxis also. So definitely it is going to suppress the immune response. You have to repeat it. And when will you repeat it? There are set criteria. In this particular case, you will repeat 11 months after the stoppage of the 11 months after that particular IV immunoglobulin was given. That's a standard recommendation which has been discussed innumerable times. So not using a screening checklist to identify patients, contraindications and precautions to vaccination. Can vaccination errors be fatal? Yes. In 2008, you'll all remember 4 infants died in the Tiruvallur district in Tamil Nadu because reconstituted measles vaccine was kept in an earthen pot dipped in water, where the septum was already perforated. Staphylococcus, enterotoxin, and all 4 developed toxic shock syndrome. 15 children in Syria died because MMR vaccine was reconstituted with a muscle relaxant instead of the diluent. I have had this experience. When I was a student in Mumbai, there's a government GT hospital where, if you remember in the old time when we used to give only DPT and Glaxos was the only brand, their DPT and Scolin ampules look very, very familiar. I don't know, some of the seniors must be knowing about it. They look so similar and 3 children were given Scolin and they all died. So this is not unheard of. This is very true. It can happen to anyone. 2017, South Sudan, contaminated measles reconstituted vaccine. Again, 2018 in Samoa. Okay, same thing, expired muscle relaxant. Fortunately expired, but still the children died. Okay, so can be fatal. Now something that from my own experience, 3 newborns in a hospital in Bangalore were given insulin instead of hepatitis B in the newborn period. All 3 died. Unexplained death, they said, but when they did an audit, AFI committee came and looked into it, insulin was given. Or, a doctor postpones the 3rd dose of the hexavalent vaccine by 3 weeks because he was going abroad and he didn't want to miss this vaccination for this child. Vaccine is very important for pediatricians. Okay, we survive on it. But what happened? 6 weeks after the third dose, that is 2 weeks after the due date, the child developed pneumococcal meningitis and died. Lesson, never postpone vaccines for frivolous reasons. This child should have been referred to your neighboring doctor or anyone. Vaccines should be taken on time, never postpone it. What happens if you give varicella vaccine to someone who is immunocompromised? Or you give BCG to someone who potentially has a family history of SCID. So vaccination risk can be fatal. It's not just your problem, it can be something fatal for the child also. So now I come to the last part. How do we prevent vaccination errors? You have to prevent it at every step, before, during, and after. Before vaccination, does this child have to receive the vaccine? Is it the right date for the vaccine? Then you take out the vaccine, expiry date 3 times, storage condition, see that the fridge is working 2 to 8 degrees. Next, pre-vaccination checklist, any contraindications, precautions. You can in fact show the package and the expiry date to the parents. Right vaccine, right dose. Check all these things before vaccination. During the vaccine, am I focused, calm, mobile not disturbing you? Important things. Are all the equipments necessary, including your adrenaline, if necessary, ambos bag and oxygen? Is everything ready? Preparation of the vaccine syringe, has it been reconstituted properly? Have you chosen the right type, size of the needle? What about the route? Have you decided that whether it should be a subcutaneous or intramuscular? Pain management, is the child relaxed? Of all the pain management protocols with Dr. Kripa Sindhu side, especially little older children, local circular massage at the injection site is something that really relaxes that muscle at that site and makes it less painful. I think that is something everyone should follow. After vaccination, disposal of biomedical waste. Is the child, especially an adolescent, seated or lying down following the vaccination? Have you documented the vaccination? Put the sticker, not if it's an expired vaccine, that discard the sticker then. Have you informed them about the next vaccine? Have you informed them about the anticipated adverse effects? Have you informed them what is to be done if an adverse effect occurs, either to contact you or some emergency number or some emergency hospital where they should go immediately? So all this has to be done after vaccination. Before you administer any vaccine to any child, ask 5 questions. That's all, nothing more complicated than that. How is your child today? So you rule out any acute illness. Has your child received any vaccine in the past 4 weeks? So 2 live vaccines interactions you can avoid. Has your child been hospitalized any time in the past 6 months to 1 year? That means, is he suffering from any illness which may affect the immunogenicity of the vaccine? Maybe CRF, maybe chronic liver disease, okay? Is your child on any regular medications apart from vitamins? So steroids, immunosuppressives, you don't miss out. Last, has your child had any reactions after any previous vaccine, or does he have any known allergies? 5 questions, and this is a very efficient checklist for vaccination. So friends, immunization errors are a reality to be faced by all healthcare professionals, but they are amenable to prevention through interventions such as adoption of protocols, which I just told you, checklists, and continuing education and assessment. Please keep attending all my sessions. You will never make mistakes. Thank you. Thank you.
Thank you, sir, for your nice presentation. And all the pediatrician in this room was listening just like a student. And we are really learning many things from practical point of view, from medical legal point of view. Thank you, sir, once again.
Please be seated. Now I'll request our President and the Secretary to felicitate sir with the plaque and the shawl. Dr. Manoj Mukherjee was the founder president of Howrah Academy of Pediatrics, and Sir remained president till he was with us. And Sir was also president of West Bengal Academy of Pediatrics, and Madam Dr. Manoj Mukherjee, she couldn't come for the ill health, so we'll just send this picture to her because we'll be continuing this oration years after year, and this time Dr. S.G. Kasi sir has given this oration, so we, the people of Howrah and West Bengal Academy of Pediatrics, are really indebted to you, sir. So it's our great honor that you have come. So I'll request Kasi sir to give memento to our secretary, Dr. Torun Shamanto, and to Dr. Abhijit Sarkar. Thank you, sir.
Panel on the nephrology. The moderator of the session is Dr. Sumantra Kumar Raut, and panelists are Dr. Mihish Sarkar, Dr. Dibyendu Roy Chaudhuri, Dr. Nilanjan Ghosh, and Dr. Sharadindu Sarkar. And chairpersons Dr. Sukanto sir and Dr. Onup sir. All are requested to please come on the dais and take the chairs. Dr. Onup sir. Dr. Onup sir. Dr. Chatterjee is requested to introduce the moderator, and the moderator will introduce the panelist and other chairperson.
Well, it's a privilege today to introduce Sumantra Raut, whom I should always call my student, because student always remains student. So, but he is a renowned nephrologist, pediatric nephrologist now. I'm proud of you. And whatever I will say is, it will be less. The West Bengal Academy of Pediatrics and also Indian Academy of Pediatrics is giving you importance and inviting you as speaker everywhere. So it's really a privilege, and that I am introducing you. Thank you.
Thank you, sir, for the nice introduction. A very good afternoon to all. And at the outset, I would like to thank our academic team for giving us the opportunity. And we are parallelly sorry also to make a break within the sweet lunch. So enjoy your lunch, also enjoy the show. So we'll be happy to introduce our eminent panelists because they are doing the most of the job now. So our first panelist is Professor Mihish Sarkar. So zero introduction needed because rare pieces are there who doesn't know, sir. Still, sir is in charge of PICU and professor in Medical College, Calcutta, and teachers of many students, definitely. Next, our next panelist is Dr. Nilanjan, sir. Sir is, congrats, sir, for getting the recent promotion to assistant professor. And sir is now in Diamond Harbour Medical College. And our last panelist is Dr. Sharadindu, and he's the managing master of the whole Uriya Hospital. So welcome all. And once more, among the most of the panelists are also a good cricket player, so do those know, because last time only our Bengal went to quarter-final of the IPPL match in Hyderabad, Pedicon. So now we, jokes apart, we jump to our main show. So obviously we will not disturb your lunch, carry on your lunch parallelly. So we will basically jump into our only case-based discussion, which cases we usually see regularly in day in and day out. So this is first girl, Misty, 6 years girl. The names are changed obviously for legal reasons. So dysuria for 6 days, febrile for 2 days, and no such prior urinary history. This is the first time history. So our pertinent questions will be, what is the provisional diagnosis? Is it a UTI or not? How to make the diagnosis confirm? What are the investigations needed for this particular child? This question goes to Dr. Nilanjan, and then will come how to collect your samples for investigations. To Dr. Nilanjan, your turn. So what is the diagnosis for this child?
Thank you, everybody, for inviting me. I thank Howrah Academy of Pediatrics. Anyway, very simple thing, a febrile patient with urinary symptoms, the first episode. So it is case of first episode, urinary tract infection.
Correct, correct.
So the approach, what we will first do, if these patients come, we have to do first a screening test.
Right.
The first line of screening is the sticks test.
Right.
And if which goes for leukocyte, esterase and nitrite.
Right.
And if that is not available, then we have to do microscopy
Correct.
and see for pus cells or bacteria is present or not.
Correct.
And for diagnosis, the gold standard is the urine culture.
Correct.
And for it to be positive, 4 things we must remember: that the culture must be positive for a single uropathogen, single.
Rightly
and
said.
that must be of a significant number, second.
Right.
And the number depends upon the way the urine was collected.
Correct.
These are the points that should be done.
So thank you, Nilanjana, for pointing out 2 important changes in our recent guideline, the ISPN 2023 guidelines. So the first thing is dipstick. So there are multi-sticks available. So previously we are sending urine RE, urine culture. Many a times patient comes out clinic to Saturday night. So difficult to get a urine RE. So how can you start antibiotics? So the easy thing is just do a dipstick in your own clinic. You will get instant results. If your leukocyte esterase gets positive or nitrite gets positive, you may start your antibiotic. Just keep a sample of urine culture in a fridge, send it to the next sample to the lab. And second changes was the colony count. So for clean catch, it was initially 10 to the power 5, the colony count was initially there. But currently, if the child is symptomatic, so please consider little bit lower count also as valid for UTI. So 10 to the power 4 is also okay for clean catch if your symptom matches. So these 2 changes Nilanjana has rightly opted out. So we need a simple test, just urine RE and urine culture. No blood test, nothing. But if the child is toxic parallelly, then might need some blood culture and other test. Agreed? So after Nilanjana has cleared that, and these all things are from our recent guidelines from ISPN 2023. And those who have less time to go through the whole guidelines of 20 pages, there is a shortcut for in the 2024 paper, a 5 pages summary. So you can have a look on that. So now, how to collect the samples. So this job, difficult jobs goes to Sarunandi because this job is easily said by a doctor, but very difficult to practice by the mother, how to collect the samples. So Sarunandi, what is it?
It is very important to collect the sample first because the contamination is to not occur. And most common is clean catch urine.
Right.
And really it is a cumbersome in case of the female patient because we have to instruct the parents also before the collecting the clean catch urine. We have to wash the labial part with the water, normal water. Then in and out catheter, that is the institution based. We will introduce the catheter and we will collect the sample, then we will out the catheter. We will not keep the catheter in situ.
Right.
Next is suprapubic puncture. This is gold standard because those are in the ICU or those are not collecting, those are not well trained. We
Right.
can use the guided suprapubic puncture by the help of 21 gauge needle, just above the 1 to 2 centimeter symphysis pubis. And bag sample is not recommended and it is not done. These are the protocols.
Well explained. So before jumping to the next slide, just I want to know how the colleagues are working. So how many of us are doing this gold standard suprapubic sampling? Any of us are doing it? Ever done it or routinely doing it? Right. So in India or at least in West Bengal, मतलब एतगुलो centurions रा बसे आचे जरा daily century मारे तादे क्षेत्रों किन्तु जिता things is actually rare. So whatever is gold standard is difficult to practice. So we need something which is easy to practice. So most of the time we are doing a clean catch, but problem is that huge rate of contamination. So coming to clean catch, the contamination rates may touch up to 50%, how good you are doing the cleaning. So the standard practice is clean with a soap and then do the thing. Difficult for a girl, particularly a chubby girl whose labials are opposed, and also difficult for a male child who has a preputial adhesion also. So for that reason, we need to decrease the contamination rate. And that too for infant, they are not verbal child, so they are not toilet trained. So how can I wait with an open sterile container? So among that, to increase your success rate, we can have a chance for quick V method. We have at least a cold compression or a warm compression over the bladder, and the child will give you a success within 15 minutes. But the contamination rate is similar because this is coming through the urethra itself. So to decrease it, the simple test is in and out catheter. So this is also doable for an inpatient or a hospital patient. For OPD clinic, it's again difficult. So finally, it boils down to this clean catch sample only. What not to do is bag sample, and I know because many of the hospitals are routinely doing these Eurobag samples. These are absolutely not done for urine RE or urine culture. Maybe done for urine biochemistry, calcium, creatinine, protein, etc., but not for UTI. So not for bag sample, it's a strict no. So For the time being, practicality is clean catch. For infant, better to do for a in and out catheter, but many of the centers refuse to do in and out catheter. Actually, the laboratory, which is like Dr. Lal or Metropolis, they don't do it. So you have to be collected in from any hospital and then can be done. So easy to say, but difficult to perform. I agree. So just a reminder, if you have no symptoms, please don't call it a UTI. Don't send a sample. If your colleague has sent a sample, just ignore the sample, because no symptoms is no UTI by definition of ISPN. And proper urine collection method has to be asked to the mother. Just don't read the report. First ask how the sample was collected. Many a time we have faced that it was collected from a potty seat. So it's a common mistake to get the sample from a potty seat sample. And obviously, just request the mother every time you send a self sample, please don't start antibiotic and then send a sample. At least if you are in a hurry on Saturday night, keep the sample in a fridge, then start your antibiotics, send the sample to next to the lab.
I just would like to one thing. We often advise urine REME, but this we never say midstream urine, and also the labs are not also advising it. So always what we are getting is contaminated, and we are finding organs. So we as physicians should tell the mother to catch the midstream urine, clean catch.
For older children, at least it's feasible. For infant who are passing the urine for 5-6 seconds, there is no early stream, there is no midstream. So difficulty in that only. So the contamination rate varies from 10% to up to 60%. We have to accept that. So we have to try to minimize that also. So Misty now, she was having a 2 days fever, but later on day 5, she became toxic. So now how to treat, Dr. Nilanjan, for this type of children? And do we have any other option? No, not all the baby will be toxic. For them, what are our easier options to treat?
So this is a diagnosed case. That means this culture has already been done, and we know the sensitivity report. And being toxic, I will be.
We have sent the culture report is awaited. Urine RE is there.
So as the patient is toxic, I will be inclined to admit this patient immediately. After admission, I will also try to get the blood samples for CBC and also blood culture, because it may have systemic bacteremia. Then after admission, I will start an empirical antibiotic, and that choice of antibiotic will depend upon the local sensitivity. But that is not always available with us. So our option will be to start with 3rd or 4th generation cephalosporin IV, and we will use it for round about 48 to 72 hours until the patient is able to take by mouth, and hopefully by then we'll get our culture report. When that is available, we'll shift to oral. And we'll continue as this was a toxic patient for 10 to 14 days.
So Dr. Nilanjan, are you admitting all patients with UTI to hospital and giving IV?
No. The particular
what are the indications for
indications are the children below 3 months of age,
infants,
the patient infants, and because those not accepting oral feeds, those are immunocompromised, whom we cannot follow up, and also who failed on OPD therapy basically. We have given medicine, but they have not responded.
Or just like this Misty, who is toxic since day 1, so they have to admit. And one of the symptoms of UTI is vomiting in children. So if a child is vomiting repeatedly, how can he take oral drugs? So that time we need to admit the child. Okay. And also for hydration, if the child is not taking enough water, that is the number one treatment for UTI, then you have to admit for only IV fluid also. So what are the...
Just one point, I want to highlight that the patient you have mentioned that they have some symptom. So the patient less than 2 years of age who have this, maybe the only fever or this vomiting is the only symptom. Just because they have not a urinary symptom, they will not be able to convey. So it is very important, just a 48 hours unexplained fever to consider this as a UTI. You must have a dipsticks immediately available, because if you delay the treatment, there is chance of scarring, even though taking the sample to the outside. So that is very important change that I think according to this ISPN guideline we have to take in our practice.
Correctly explained. So the symptoms may be age related. So all the bigger child will said dysuria, cry during urine, dirty urine, red urine, etc. For infants, as Professor Mihisakar told, there should be just a fever without focus. And the difference is for other fever where we says at least 2 days, 3 days, just wait there. That can be a viral one. For the child who has already a past history of UTI, we said don't wait more than 24 hours, because as Dr. Mihisakar told, if you delay the treatment, there is a fair chance of scar. If you start the treatment for UTI early, the chance for future scar is much lesser.
And so in whenever this guideline, nothing is said, you must start treatment within 48 to 72 hours to prevent scarring as per this guideline.
So 48 hours of fever, without any viral or any other focus, just send a sample and start antibiotic. If your samples come negative, you can always de-escalate your treatment. There is the option. So rightly pointed out. So oral antibiotics for most of the patients, unless they are sick. And for the antibiotic choices, we always need our local antibiotic profile. Many times there is no such profile. For Howrah, we don't have a local profile. So we can follow our nearby neighbor profile, maybe from medical college, maybe from AIIMS Delhi, whatever protocol is nearby to the similar matching cohort, we can follow that. So then starting straight with the other treatment options. So what are the other symptoms? So this is again a common scenario. Child was started on antibiotic on day 1 itself, started on cefixime. On day 3, the child become well already. She is fine. We just want to complete the day 5 or day 7 of antibiotics. But the culture report came which was resistant to cefixime, but jolly well sensitive to meropenem. So what is our option? Can we admit the child, give meropenem? Mother many a times are not agreed for admitting. Can we choose oral ferropenem that we mostly do? Or can we continue the taximo itself, whatever is our to take? Same, all. Any other different in opinion? So don't go the culture if the child is well. So even if the child is well, whatever may be the in vitro sensitivity, just continue the same antibiotics for your total duration what you have planned. Either it is a day 3 to 5 for uncomplicated UTI or a day 5 to day 7 for complicated UTI. Agreed with all the audience. So fine, so no switch to meropenem. So coming to the history proper, Nilanjan sir, whatever other history we need to ask the mother repeatedly, because only single question many a time mother will refuse the history. So what are the particular history for this type of
For this recent fever, we should ask about the nature of the fever, any urinary symptoms present or not,
right.
And also if the patient has received any antibiotics, because that will give us an idea of any antibiotic resistance.
Correct.
Then we should also go into the past, if you had any past history of UTI, any family history of renal diseases,
right,
and all that. And chronic urinary symptoms, that is very important, like incontinence, post-stream, or frequency, urgency.
Right.
One thing that we must not forget is chronic constipation.
Absolutely,
This is very
absolutely
important to prevent recurrence, and we should
Right.
give importance on asking on this very point. So
Correct.
we should have a good idea about the patient is having constipation or not.
Right. So always, if you ask constipation, most of the our colleagues are doing that, but many of the time mothers are telling no, there is no constipation. Passing stool well once or twice, or maybe alternate day. So always don't believe on the mother only, because other than history there should be some evidence. So always better to ask, have a potty picture, how is the potty pattern, how is the sitting pattern. For this type of patient with UTI or repeated UTI, we at least need a good bowel clearance at least 2 to 3 times, and that too as per the Bristol stool chart. So just like a gravy-like stool, these are some common example we give, and that we have to stick about. And this type of prior symptom, what is the symptoms now? Among them also important, what is the symptom when the child is well? Is the stream is irregular for a boy child? Then we need to have some stream video, because mother may not be knowing what is a interrupted stream, what is a good stream. So better to have a urine video for the boy child. And for the girl child, does the child while looking for the mobiles or studying, while the child wants to hold the urine like this is a classical position. And what this position is known as? This is a classical position for a girl child with holding behavior. The child is trying to hold her urine while watching mobile. It will lead to some post-fire residue and further UTI. So this is called classical Vincent crisis, and this has to be asked for. Many a times we can show the pictures from our Google mobile and then ask if your girls does like this. So not to miss the history of constipation, as Dr. Nilanjan told, and many a time we want to check the urine stream by ourselves or by checking the video at least of the urine stream. So supportive treatment. So if there is some constipation or other thing, what supportive treatment to be done and what not to be done, Dr. Nilanjan? Anything we do it more commonly, maybe right or wrong?
Hydration here we have to maintain.
Correct.
Treat the
So
constipation, and urilizer and dexamethasone, no, we do not, we should not.
Correct.
Give.
So a commonly done things is urilizer. We don't have much scientific basis. I still can remember Sapon sir has asked me in one of our webinar that can urilizer or steroid can be given. So a big no for urilizer, that can only give a placebo effect, not more than that. And steroid, though few of the study has shown it can decrease scar, but for the time being, no trial for pediatrics has proven. So that's why it is not a common practice for us, not at least a educated practice for us. Don't miss clinical exam. The pertinent for UTI is checking the backs and the spine and the genitals, which we commonly missed in a busy OPD, particularly for a government OPD where there is no privacy. For a bigger girl child, it is difficult to examine though, but always look for spina bifida, occulta or ovata, like this type of thing. And also check your genitals. For boys, for the prephysial tightness, and for girls, the labial adhesion. If you don't clear that, your UTI symptoms may be repeatedly happening. And obviously, blood pressure, a oftenly missed common 6 vitals that we don't do for time reason, maybe for cough reason or anything, but for at least patient of UTI, it is recommended for every visit, they need a blood pressure done, correct? So then now next, this is baby of Mitali. Meeza might be quite well knowing of this child, having repeated history of UTI earlier. So the first episode happened in January 24. There was some fever, some dysuria, treated as UTI, child was well. So second episode, July 24, there was same fever and frequency. This time urine culture was not sent. First time urine culture was sent, there was E. coli. Second time no sample sent, just given antibiotic, the child became well. Third episode, September 24, no symptoms. Mom, by virtue, because mom was a nursing staff, did the urine culture. It showed again E. coli of 10 to the 5. And the fourth episode on November 24. So fever, no focus this time. Urine shows plenty of pus cells and culture shows E. coli of 10 to the 4. So total 4 episodes. So my question to audience, how many UTIs were there? 1, 2, 3, 4 or 0? How many UTIs were there? As per definition, first is a UTI, culture was, first was not mentioned, culture was E. coli for first. So second, no sampling, so don't consider as UTI. Don't take any drastic step as considering. You can treat the child with antibiotic, but don't consider as UTI. Third step, no symptoms. So again, this is not UTI, this is asymptomatic bacteriuria. Fourth is an UTI. So first and fourth, total 2 episodes of febrile UTI, and this is called repeated UTI. Repeated UTI is in any lifetime 2 episodes, in pediatric lifetime definitely. So this is a case of pediatric, this is a case of repeated UTI. So Mihir sir, how to investigate for further imaging scans? And
Yes.
what are the timing of such scans? This is a common confusion every time we
Yes.
do
So
wrongly.
that is very important because if you are referring to the ISPN guideline, initially it was that we have to do for the scanning of the every patient less than 1 year of age or 1 to 5 years, we must the ultrasound scan.
So all
And
three.
yes, and then MCU and the DMSS scan, because we do not want to miss any urinary tract abnormality or any VUR.
Right.
But now the approach has changed.
Correct.
So now the every UTI patient you have first episode ultrasound scan is must.
Right.
That should be done within the 10 to 14 days.
Accepted.
Now depending upon the clinical features, now whether to go to the patient with the MCU or the DMSS scan. So now if the patient have abnormal ultrasound or the patient is less than 2 years of age with the non-E. coli UTI or recurrent UTI. So 3 criteria, abnormal USG, recurrent UTI or the non-E. coli growth in less than 2 years, then you have to go for MCU for this patient. And if the patient DMSS scan when the patient has recurrent UTI or your MCU showing the VUR of grade 3 to 5. So these are the indications for DMSS scan.
Correct.
So there is a change in the practice from the previous guideline to this guideline.
So thanks Meeta for pointing out another changes in recent guidelines. We are going away from radiation investigations where DMSA was done routinely for all child, and also DMSA is not available in most of the centers. So wherever it is more judgmental, wherever treatment will vary, then only we are going to do the DMSA. So for this girl, 6 years Misty, who is having E. coli UTI, what is our take for this girl? What test to be done? Ultrasound or all 3 or all 2? Whatever is our plan for this child? Any opinion? Ultrasound only. This child is having repeated UTI, 2 episodes. So repeated UTI, everything. So means what are the timings? They are asking what is the timing. Ultrasound when? When is the MCU and when is the
Ultrasound
DMSA?
as the during the 10 to within the 10 to 14 days.
Correct.
MCU is after you treating the UTI, so
Yes,
after the
right.
14 days, and
Right.
DMSS scan later on. That is the after recovery. It is 3 to 4 months after.
Always, yes sir. Yes. For repeated UTI, yes sir.
Yes.
The guideline says if it is a repeated UTI, then all
Recurrent
3.
UTI.
Ultrasound. Sir, ultrasound ideally says during a UTI episode there
During
can
the
be
UTI.
some false adhesion, false hydronephrosis. So whenever your UTI subsides after 5 to 7 days, you can do a ultrasound. 2 fallacies. The child may lost to follow up, never come back again. And second, if your child is not improving on day 2 of antibiotics, there can be some pyonephrosis or a abscess. For that, you need a early ultrasound. Otherwise, 5 to 7 days, as Mihir told, is good for ultrasound. For MCU, whenever your UTI has been subsided, we don't try to ascend some more infection. So after 10 to 14 days is fair enough for MCU. For DMSA, never early for Indian protocol at least. We do after 4 months at least. Previously, it was some 2 to 3 months was written. Currently, it is obviously after 4 months DMSA. It's always a late DMSA. So thanks Mirza for pointing out all the points appropriately. So when to refer to pediatric nephrologist for such cases, most of the UTI by choice and by rule to be treated by primary pediatrician only because patients are more comfortable with them. So when to refer?
It is very important to find out that patient is having any association with like UTI with bladder bowel disorder dysfunction. That is very much important because we from the history, that is training, constipation history, and urgency and frequency, we can find out the patient is having the BBD. So it is very much important we have to refer the pediatric nephrologist UTI with BBD. And next is UTI with VUR, that is early intervention is required. So from the history,
child is already known VUR and this is the second episode, you need to refer.
We have to refer.
Correct. Next.
Because 3 to 4 stage is required. And non-responder is very much important. Pyelonephrosis is one of the cause, and renal abscess, because the high-grade fever and chill and that are not responding to proper antibiotic therapy after yielding it, we have to refer to because surgical intervention we have to take also. And another thing, associated urologic or renal anomaly, structural anomaly like diverticulum or meatal stenosis or urethral stricture, whatever it may be. And deranged renal function, that is raised serum creatinine and GFR if deranged. So we have to think about another is not simple UTI. It may be associated another syndrome or nephritic in origin.
So
also.
seeing a UTI in a chamber on first go, don't refer. Treat it simply. Unless it is a complicated one or there is some background defect, then only you need a referral on first go. On follow-up, when to refer?
And in due course, we have to measure the hypertension. The 24 hours ambulatory blood pressure measurement is required.
Correct.
If there is hypertension, that is not a case of simple UTI. It is association. I already told that is association with the nephritis.
Right.
So we have to refer. And renal scarring evaluation, we have to must refer to.
So for follow-up patient of UTI, try to measure the blood pressure, and even if the blood pressure is repeatedly normal, don't believe on single office blood pressure. This type of children have a normal blood pressure in your office and a very high blood pressure at night during sleep time. They have a nighttime stroke, though the number is less. So to diagnose this, we need a 24-hour ABPM because this condition is called as masked hypertension. They are normal in an office and high at home. So for that only the only armamentarium is doing a 24 hours ABPM, nothing else. So now coming to the next case, Srishti, 9-year-old girl coming with a red color urine. We can also may tell hematuria with some puffy eyes for 2 days and no such prior urinary history. Crash landed at ER at medical college with general tonic-clonic seizures. There was some history of boiled heels ulcer in the leg. So Dr. Saranandu, what is your provisional diagnosis and what are the other DDs for this one? So classical case seems to be a
straightforward classical case, 9-year-old and urine 6 days, puffy eyes. So there's edema and there's a hypertension because GTC is there. So it is a case of acute glomerulonephritis.
So AGN, right?
AGN is a relatively abrupt onset and having the variable degree of hematuria, oliguria, edema, and hypertension, etc. and the decreased GFR.
And what's the etiology for this AGN? For this girl, it seems?
This is a post-infection is most common streptococcal group A beta hemolytic streptococcus.
So PIGN you means?
PIGN, and that's a 12 strain is more common.
Right.
And other thing is that streptococcal, staphylococcal, pneumococcal, meningococcal, whatever it may be, and plasmodium and P. falciparum toxoplasma.
And what could be your close DD if not a PIGN then?
It's not because it's a Henox corneal purpura or BMB.
So vasculitis can be there, right?
There. And other things, some syndrome is there, syndromic Alport syndrome, whatever.
Right, or other type of GN like IgA nephropathy.
IgA nephropathy is much more common.
Correctly told. So coming that provisionally diagnosed as PIGN might be it can turn up to something else. So what investigation, Dr. Nilanjan, we need to prove that?
So we'll do a routine urine examination and look for, what we look for is basically is there proteinuria present or not, red blast cell hematuria present or not, and RBC cast or dysmorphic RBCs because they denote the glomerular pathology.
Right.
Also in blood, not specific, but there may be some anemia due to dilution, due to water retention. And also look for the renal function tests we will have to do, and the hypoalbuminemia we have to see. And most important in case of
what is the key test here? What is the main
test is post-infectious. It is the low C3. Okay, because it is the alternate pathway is activated, these gets consumed and the level falls. And also if there is clinical features and if not or not present, streptococcal evidence of any streptococcal infection present.
Rightly said. So whenever a mom comes with a red urine, don't call it hematuria directly. That can be hematuria, can be hemoglobinuria, that can be a red dye itself. So just send a urine RE, check some RBC. If RBC is there, then okay, now it's coming to a hematuria. And whenever considering just simple PIGN, we don't need long-term treatment, don't need investigations much, at least confirm by a low C3. If C3 is not low at the start, then challenge your own diagnosis. Correctly said Dr. Nilanjan. So C3 is the key test here and we need to do it from a good lab, maybe 2 or 3 times, not on a single times. So does we need renal biopsy for every child with PIGN? PIGN
No,
is
not
very
at
common.
all. They are, unless complicated or other features, systemic features are found, we'll never go for renal biopsy in case of post-infectious glomerulonephritis.
Classical PIGN don't need renal biopsy, don't need long-term immunization, correct? So what are the other history that not to be missed, Dr. Sarasindu? What are
its onset is very much important, acute versus chronic. In case of it's a AGN always acute onset. There is a something is abrupt onset, and age is much more important. 5 to 12 years, 5 to 15 years after. And in case of nephrotic syndrome is less than 3 years. And
so if this child should be having a 2 years age, we can consider FSGS or other nephrotic with hematuria rather than AGN.
Right, nephrotic proteinuria.
Next.
And the family history that the patient is having the IgA nephropathy or MPGN is not. And
any importance for the latency period, sore throat versus PIGN?
Versus the pyoderma in whatever in the lower extremities, that in case of the sore throat 1 to 3 weeks, and in case of pyoderma 2 to 3 weeks latent period.
So the gap is important. Synpharyngitic or non-synpharyngitic, right? So if it is non-synpharyngitic, there is only just a weak gap, then what is the diagnosis?
Just a weak gap, that's an...
So then not a PIGN anymore. So maybe a IgA nephropathy or a Bardet disease.
Or Alport syndrome.
Right. And what other history should be mentioned here for other diagnosis, other type of GM?
The hypertension, the rashes and joint pain,
So
because we have to look for there is any arthritis or not. And
so other type of vasculitis may be possible.
For vasculitis and henoxcholine purpura or maybe ACLE may be there.
And one of the examination not to be missed is blood pressure.
Blood pressure is very
it's important. The
because
child crash landed with Mihir at medical college. So, yes, please, sir. This is a cartoon picture, sir. This is actually 2 cups are given there in the arm and forearm. So this cup is not at all a proper size. The position might be normal, but the child is not that calm. It was over 8 T-shirts and 2-3 shirts. So these are some common errors which are done in routinely. Particularly in winter, it's difficult to undress the child. So these are all mistakes, and not all mistakes, many of the mistakes on the same pictures. So blood pressure is important, and as per some of the members of Howrah Pediatrician, just 1 week back I was telling how to look for this blood pressure high or not. This is a complicated chart. Girls, boys have separate chart. Put the age, put the height, and you will lost in your busy OPD where you are going to target 100 patients. So there is a shortcut chart also there. So please go to the shortcut chart, keep it in your OPD, and just finish your work. If the child is high, then go to that complicated chart. Most of the child will have a normal BP. So agreed? So, and all these are from that 3 articles only. So Srishti now came to medical college with this crash landing. Blood pressure was 170 upon 98 millimeter mercury. No gallop. So what next, Dr. Mihir? How to manage this child? What is the first step? We will believe this single blood pressure reading or what?
Yes, the single blood pressure reading will not, that should be repeated, but as the patient have convulsion, during the active convulsion, there may be falsely high.
Correct.
So whenever you have controlled the convulsion, you have to repeat the blood pressure.
Still high. Still
high. Yeah. So this patient has hypertensive emergency, as this hypertension with end organ damage. As you can see, the patient have a convulsion and encephalopathy.
Right.
So now then you have to check the basic things of checking the blood pressure of all the 4 limbs.
Similarly high. Suppose similarly high for all 4 limbs. Then?
Yes. So now you have to go for, now you have to reduce the blood pressure for the patient.
Correct.
Now we have confirmed.
So now oral drugs?
Yes, no, but how we'll go for it? Definitely in this patient, we'll go for the IV, preferably the infusion anti-hypertensive, and you have to choose a drug which you can titrate very frequently and which don't have a very long half-life, because you have to have a target, reduce the blood pressure not less than 90th centile of this patient. So the and total reduction target should be done over a period of 24 to 48 hours.
So how rapidly? At least 2 to 3 days over the time we need to reduce it, not on a single day, just like decay management. And what is your choice of drug, as per you told?
My choice will be drug for the, mostly in our unit we use the nitroprusside or the labetalol, but the nitroprusside is the first option definitely, because it has a very short half-life. So if you are going down very fast in the blood pressure, you can stop or titrate the dose and you can monitor. One thing I will urge is that the invasive blood pressure monitoring is very important here for management of hypertensive emergency, because if you are doing a rapidly decreasing, there will be again the decreased perfusion to the organs, and there may be the secondary brain
So immediate
injury.
blood pressure and this thing, can we do it in ward? Or the child
So
needs
that
special
should
care.
be
Where to
patient-
care?
Yeah, so H2 or PICU setting is most important.
Ideally preferable,
Yeah.
right, right.
But that is, one thing I want to ask them, for management, this invasive blood pressure will have a very crucial role during
Right.
management.
So less chance of inadequacy for this reason. So hypertensive emergency without heart failure, NTP nitroprusside will be the first choice if available. If not, try Labeta. If it is with heart failure, then nitroglycerin can be the first choice. And nowadays also hydrolazine IVs are available in Kolkata. So whatever is in your choice, whatever you are prudent with, you are comfortable with, try that. But NTP has obviously 1 to 2 minutes of onset and 5 minutes of duration of action. So Mirza rightly told it should be NTP by choice. So what is your treatment plan to decrease the blood pressure? Mirza? Just a rough sketch, not the
Yes.
details. Just a
So
rough sketch.
basically, as you can see that the guideline is that the 25 to 30% in the first 8 hours, the next over the 48 hours. So you can divide this next one as the first within the 16 hours, the
Right.
next 25%. But as you know, the human body does not follow mathematics, so
Right.
that will be variation.
Obviously.
So, but you have to, as a clinician, you have to look at this continuous blood pressure monitoring of this patient. If that is the severe fluctuation, you have to titrate the dose and you have to take the measurement.
So every
that is
drug
the
has a good range. We will target 1/3 reduction on day first 8 hours, next reduction over next 24 hours, and next reduction over 48 hours. We'll draw a line and we'll plot our blood pressure. If it is going high, we will decrease our medication. Right, Mirza?
Yes.
Okay, fine. So, and parallelly we'll start oral drug because after 2 or 3 days we are trying to win out our IV and we'll put our oral or NG drug for that same reason. So now this is Dystry, another girl with same blood pressure but no hypertensive emergency, Dr. Saranjan this time. No gallop, no seizure,
okay,
nothing.
this
So what is your drug of choice? Again admit an IV?
Okay, these 9-year girls admitted with CMC, no GT, without GTCS.
No emergency, no
and
emergency.
No S3 because.
So what is the choice?
But no congestive cardiac failure, so drug of choice should be oral.
Oral, so no IV here,
no
right?
IV that, because no GTCS there, and drug of choice should be furosemide like that.
Right.
And that's the loop
Right.
diuretics. Or then we can go for the amlodipine or enalapril if the potassium and creatine is okay to go for the enalapril also.
Correctly told. So, no emergency, no urgency, even if there is severe high pressure, you may need to admit the child for monitoring, but not necessarily IV drug can be managed with 1 or 2 drugs for oral. For AGN background, Lasix diuretics is the first choice, enam versus amlodipine is the second choice. For nephrotic background, enam and amlodipine become the first choice and diuretics become the second choice. And always check your target organ, right? So now,
target organ. No. And we have to.
So now coming to the same patient of as Dr. Mihir has faced, 60 who is admitted with GTC with high blood pressure in a background of AGN. Now we sent for C3 also. All the reports came on day 1 in medical college. C3 came 3 days after it. It was 98, more or less normal. So Dr. Nilanjan, you already told classical PAGN does not need renal biopsy. Do you differ in this case? Yes or no?
Yes, the next, we have to do renal biopsy for further management.
Why?
Because this is not PI, in a classical PIGN, the C3 level would have been lowered.
Lower, right.
But
So-
here it is normal.
So we are challenging our own diagnosis here, correct? So what is the take now? What are the indications of biopsy for AGN? What
So when we find the indication, we generally don't do biopsy, but the cases we'll do, it should have fever, rash, joint pain or heart disease, or we do not find any cellular, ASO titer is not very much raised, and there is a mixture nephrotic, nephritic picture, or there is severe anemia, very high levels of blood, urea, like renal function tests are very much altered.
RPGN insert, right.
Yeah.
Next.
And in delayed cases, when the hypertension is persisting more than 7 to 10 days, it's not being controlled, or there is gross hematuria even after 3 to 4 weeks, which naturally it should come down, but it's not coming down. And nephrotic range proteinuria persisting.
So nephrotic mixed picture.
Mixed picture for more than 2 weeks.
Right.
More than 2 weeks. And the indication over here, low C3 levels.
Correct.
It should that this low C3 level should normalize.
Right.
But if it stays below for 12 weeks, then we should also go for renal biopsy also.
So for easy option, for every PIGN classical patient, we need to send C3 2 times. At the onset, that should be low. At after 2.5 months, that should be normal. If something goes beyond that, we need a biopsy. Otherwise not. Right? You said to me, Dr. Nilanjan. So That's up to that thing. And as per, as Dr. Mangal told, that for classical PIGN, most prevalent, for uncomplicated case, we don't need admission, don't need investigations further, and don't need biopsy. Wherever there is some atypical features that Nilanjan told, for rashes, for arthritis, secondary nephrotic, or with a complication of high pressure, high edema, heart failure, for complicated cases, we need to admit and further investigation and might be biopsy for that same reason.
In every acute nephritis, there is some hypertension.
Right, sir.
So how quickly you ask them to check for the blood pressure or come to the office?
So in our, if the child is coming to an OPD and have a mild elevation of BP only, the BP is between stage 1, suppose, that time oral antihypertensive control is fine. So we start our day 1 of diuretics and we manage it, but that time BP has to be monitored regularly. This child can have a shoot up, can crash land in your ear. So if you are doing that on a OPD basis with that much of BP, tell them to have a good BP measurement in their nearby or come to the same OPD to have their BP check on next day itself. Many a time we don't rely on other BP materials because cuff size may vary. Better to come to their own OPD follow-up. If they are not possible to come to the OPD daily, just get admitted for monitoring reason. So for that, we have already crossed time, so we conclude our session. Thanks to my panelists and again our chairperson on our HypeCon. Any questions from chairperson with the permission of them can be tackled later. And I will also like to, on the same gathering, I would like to invite you people for this Nadia Academy of Pediatrics having a UTI and VUR meet on this 8th of March. You all are invited. So please have a look on that. Dr. Pankaj Hari sir is coming from AIIMS New Delhi. So thank you.
Excellent moderation.
Thank you.
And very good informations, recent informations regarding these picture, regarding these cases, and our very good deliberation from our learned panelists. So we have to conclude now the session.
Thank you, sir. Thank you, my
everybody.
Thank you, Sugant sir.
Thank you. Now I'm requesting the moderators to come on the dais and facilitate. I am requesting Mihida, please, to felicitate Dr. Shukantu sir and Dr. sir. Thank you. Our next session is on the typhoid conjugate vaccine. It is scientific grant session, and in requesting Dr. Asim Kumar Ghosh to take the chair on the dais for this session.
Very good afternoon to all the esteemed delegates. First of all, thank you to the Howrah Pedicon for giving me the time to represent a vaccine from Bharat Biotech. This is a sponsored session on the typhoid vaccine. It's a very big slide deck, around 60 slides. Choitali, I would request you, if there are 5 minutes or 2 minutes remaining just, and maybe I'll be taking 5 minutes extra for that. So what we will be dwelling on is, why are we talking on type bar TCV? There are other typhoid vaccines also. So what is unique about this vaccine, which is lacking in the other vaccines? And if time permits, we will go to that very hot topic of whether we need 2 doses, a booster dose for typhoid vaccine or not. So let's get started. So I would ask the House, where does typhoid occur maximally? Does it occur in one continent or in more than one continent? What would be your answer be? More than one continent. Which would those 2 continents be, or the continents be? South Asia and the other? And the other? No, I'm talking about continents. Africans. So let's see whether we were right in saying typhoid fever, salmonella occurs in one continent or in more than one continents. So this is annual stats. I won't go into details. And as you see, India is scoring somewhere between 350 to 400 cases per 100,000. It's the only place which is showing except for this African state and a part of New Zealand. নড়ছে না কেন? স্লাইড মুভ করছে না? So when does a global disease peak occur? It's very important. The global disease, the peak occurs between 5 to 14. If you see the 5 to 9 maximal and also from 10 to 14. And then as we cross and get into late adolescence and into adulthood, it decreases. This is the annual stats. 345 incidence rate, prevalence of 21, deaths 3.65. Again, this Indian stats shows 2 to 4 years age group, the number of cases were 2,900, 5 to 15, it was 5250. So basically, it is the story between 2 to 15 years. Now, if you look at this, typhoid, the deaths and dailies due to typhoid, which is the continent? As you all said, it was South Asia. But if you see the diarrheal non-typhoidal salmonella and the invasive non-typhoidal salmonella, then the sub-Saharan Africa comes into picture. So basically, if we talk about the normal enteric typhoid fever, it is South Asia and South Asia and South Asia. What about then the non-typhoidal salmonella? The WHO is looking into it as we go into the subsequent slides. কাজ করছে না কেন? প্রবলেম হচ্ছে? হ্যাঁ, জড়িত প্রেস করছে, হচ্ছে না। Yeah, it's coming. We are coming then. So the WHO has described the, sorry, back koro to, এটা কি next slide ছিল? আগের slide কোনটা? হ্যাঁ, back. Right, come back again. হচ্ছে না তোমার এটা ভালো করে. Let's go on with this. Yeah. So the typhoid occurs due to a variety of reasons. As we go to the extreme right, it is the 11 to 35 degrees latitude, preceding rainfall, associated with higher temperatures. All these would lead to increased risk of food and water contamination through flooding, through droughts, and through famine. There would be a sudden upswing of typhoid cases with a transmission, a situation ideally suited for typhoid vaccination. Two important unaddressed gaps in typhoid management. If you look at the first one, it's the carriers. The major source in low incidence and non-endemic settings, and they go through multiple outbreaks. This needs to be addressed to prevent typhoid, especially in low incidence settings. The chronic carriers, they exhibit a gallbladder pathology which includes cholelithiasis and bladder carcinoma. There is no practical way of detecting nor managing the carrier stage. If we come to the reinfection immunity, if we say if it is reinfected, the antibody levels get up, the individual is protected. Let's see what happens here. The volunteers in the controlled human infection study of typhoid, when they were rechallenged with S. typhi compared to the naive, they showed a modest reduced risk of developing typhoid when they were homologously challenged. It was only 36% modest reduction, not a great reduction. For the heterologous cross challenge, there was no protection. No difference in symptoms in those who developed enteric fever. Baseline protective antibodies were practically same, and there was no obvious boost in the protective antibodies from prior exposure. There was reduced shedding of the bacteria, but that was similar to the vaccinated VI containing or the TCV vaccines. Now AMR, it's a global, it's a health emergency. It's not a problem now, it's a health emergency. And by 2050, WHO says 1 person could be dying every 3 seconds if AMR is not tackled now. And this is a big problem in the management of typhoid. The typhoid superbug, which is resistant to 5 types of antibiotics, have infected globally. 60% of these were drug resistant. And as you all know, MDR, if it is resistant to 2 types of antibiotics, and XDR, if it is resistant to 5 types of antibiotics. MDR plasmids still circulate among other Salmonella in Asia. So returning to the previous drugs is not favored, as it might prompt a re-emergence of MDR and subsequently to the dangerous XDR typhoid. Adoption of TCV vaccination has not shown any change in antibiotic prescription as brought out in the recent Zimbabwe trial. The development of effective vaccines is needed to counter the emerging AMR situation in typhoid, according to the immunization agenda of 2030. And therefore, there have been many developing programs for typhoid vaccines. For example, newer vaccine platforms like the mRNA vaccine platforms are being used if we can get a more efficient oral typhoid vaccine. They are trying out for tri, tetra, and hexavalent typhoid vaccines, but these are in the nascent stage. So, the AMR problem, if you see, according to the WHO bacterial priority pathogen list, it was 18. And within a period of 7 years, it climbed to the 7th position. A huge jump. So what does this high group mean for Salmonella typhi? Significantly difficult to treat, causes a substantial disease burden, increasing trends in resistance. It is uniquely difficult to prevent this disease, highly transmissible. As we all know, the humans are the only host and reservoir of typhoid. Only a few potential treatments in the development and critical for some populations, especially the lower age group, as I showed. As you see, a very disturbing statistics. In India, 98.28% are ciprofloxacin non-susceptible. For our country, an alarming picture. So the practical prevention of typhoid can be something very intangible, which needs to be repeated and which is unreliable, like washing hands, drinking boiled water, washing fruits and vegetables before use, and of course getting vaccinated. But the more tangible and reliable would be getting a typhoid vaccine, which would prevent around 1,80,000 of AMR related deaths per year. So what should an effective typhoid conjugate vaccine do? There should be a primary use, a secondary, and a typhoid use. The primary use would be to reduce the disease incidence, reduce the severity of the infection, decrease the transmission of disease, and counter the development of AMR and subsequently AMU, that is decreased antimicrobial use. And lastly, for the tertiary stage, it would be to prevent the carrier stage development, limit the damage to the individual, and complement the infection-induced or derived immunity. So as you all know, a polysaccharide and a polysaccharide conjugate. Why do you conjugate it? It increases the efficacy of the vaccine, increases the potency of the vaccine. So the classical features of the polysaccharide vaccine, as you all know, a short-lived memory, no immune response in infants less than 2 years. But for the polysaccharide conjugate, you would have an affinity maturation, induction of the memory B cells, a long-lived antibody protection, and improved immune response in infants so that you can use it below 2 years. In India, at present, there are 4 typhoid vaccines. Out of them, 3 are WHO pre-qualified. First to get it in 2018 was Type-BAR. In 2020, it was the B vaccine Typhi-Bev. And recently, last year, Zydus got the pre-qualification for their Zyvac TCV. So it is the world's first pre-qualified typhoid conjugate vaccine. And it is now being used as a comparator vaccine. So any new typhoid vaccine that comes in subsequent days, they will only have to do a non-inferiority study, keeping the Type-BAR TCV as the model. It is comparator for other TCVs, as I said. The only TCV with proven efficacy across the 4 continents with proven booster dose effect. And they've got multiple studies. I don't know how many studies I can go through. They are claiming, Bharat Biotech is claiming this is supposed to be a perfect typhoid conjugate vaccine because of their innovative saccharides, which they have got from NIH USA, the linker, which is the adipic acid hydroside, and the carrier protein, the tetanus toxoid protein, which is a high purity vaccine obtained from the WHO pre-qualified vaccine manufacturer with proven high IgG titers in children than others. It is an ideal carrier protein as preferred in the newer conjugate vaccines. A process of glycoconjugation, I won't go into details. They've got a patented technology for this glycoconjugation process. Through random or selective, then they activate and get a vaccine which is highly immunogenic with high avidity index and a lasting immunity. The polysaccharide protein ratio is 1:1, extended thermostability required in a tropical country like ours. The immunogenicity responses elicited by the TT glycoconjugates were significantly higher than the CRM 197. And some pharma houses are thinking or contemplating of shifting to this TT carrier proteins. Why does it score over others? So wild type natural strain, I won't go into details here, otherwise I can't. And the main thing is, they've got the tests, clinical studies for the avidity, class switching, boosting, efficacy, effectiveness. Multiple studies across multiple countries. As I said, they've got the animal studies, followed by the efficacy studies and the effectiveness studies. So these are some of the studies. The first one is something very unique. The only human challenge study done by Bharat Biotech in UK. Age group was 18 to 60. Then they had the seroefficacy modeling studies, followed by the vaccine efficacy and effectiveness studies. I won't go into details of these. Just a glimpse of the studies that they have done. These were the phase 2 and phase 3 studies. Important to show this phase 3 study, 6 months to 45 years. They gave a booster after 2 years, followed it up with 3 years, 5 years, and 7 years. So they've got a 7-year follow-up study, a booster dose which was administered 2 years post prime dose. Here they gave the booster, followed it up at 3 years, 5 years, and 7 years. And what did they see? The single dose and the booster, if you see, this, if you look at these two, this pink is below 2 years, and 59.3, this one, the blue is above 2 years. So this was a single dose, and when you gave the booster, the 48 jumped up to 71 and the 59 to 83 after the booster which was given 2 years later. This was a study done during the corona times in Navi Mumbai, a huge cohort of 1,13,000, 83.7% was the efficacy. These are the multiple studies, as I said, done across India, Nepal, Bangladesh, Pakistan in Asia, and Malawi, Ghana, Congo, Burkina Faso, and Zimbabwe, and in the Oceania, Fiji Islands. This is, as I said, the first and only human challenge trial for typhoid. And what were the results? The people were challenged with a dose of Salmonella typhi. 5 minutes, I'll complete. And the results were reduced signs and symptoms in typhoid cases. They prevented the mucal invasion in the gut. There was long-term immunity with memory. This was a study done in Pakistan, as Sir said, in the Aga Khan University. And what did they see? 60% of the typhoid cases were drug resistant, 45% were confirmed blood culture as XDR. And what were the results? 95% effective against culture confirmed as typhi and 97% effective against XDR. A very encouraging results indeed. And now this was a Bangladesh effective study which showed around 84% vaccine protection. Then they did, I won't go into details of this. This is a Bangladesh study. They show the decline in the anti-VI, IgG and IgA gradually over time. This was a Nepal study, practically same, 78 to 80% efficacy. The Malawi efficacy study, there also they show the vaccine efficacy is reducing by 1.3% per year up to over 4 years. This was a Zimbabwe study. They did it in hospital settings and they did it in community settings. Around 94% between 6 months to 15 years and 77% between 6 months to 45 years. This was extensive safety data they have done. Non-interference, if they co-administer with MMR vaccines, MCV or MCVA, they had a post-marketal study and also the phase 4 adult study, where they're looking into the middle-aged and aged group, the effectiveness of the TCV. It's a very safe vaccine. The pink shows no AEs. Most common local AE was pain at injection site and systemic AE is fever, which is very common for any vaccine. No interference if you give it with MCV or measles, rubella and mumps, so it can be safely given. This is also can be co-administered with MCVA, proven safe and immunogenic in middle-aged as well. If you see the 45 to 65, the response, the VI-IgG is practically same if not more. And now the study is going on, additional study on more than 65 years, that is in the elderly. They've proved till middle-aged. So the 77th World Health Assembly on typhoid vaccine gave some important directions. It prevents millions of antibiotic-treated episodes of deaths, particularly under 5 in low middle income countries, decrease AMR and AMU, and the IVI, the International Vaccine Institute, is now working on 4 priority pathogens. One is, as we know, the Salmonella typhi. The other is a non-typhoidal Salmonella, which is creating havoc in the African continent, and Shigella and Group A Streptococcus. I don't think I have time for the single or double dose. I leave that. I leave that. One thing is the results that have shown there is waning immunity in the first 3 or 4 years. After that, the immunity gets up. So you might need a booster after the first dose which you are giving at 6 months. Bharat Biotech had given all the relevant studies to ACVIP. ACVIP stand till today is we haven't got sufficient epidemiological data to say that we need a second vaccine now. But it has been proved beyond doubt till 3 or 4 years it rapidly decreases, especially after 4 to 5 years. That is up to ACVIP to decide when the second dose should be. But there is no point in giving it after 5 or 6 years, because then the maturation of the bone marrow system occurs and then it picks up through repeated infections. So if you have to give it, it has to be below 4 or 5 years. So across all continents and countries. So I conclude my talk here with first pre-qualified vaccine, only TCV with established long-term safety and immunogenicity data, used as a comparator for other TCVs, proven efficacy across all the 4 continents, proven booster dose effect, proven to reduce AMR, non-interference with MMR and MCV vaccines, proven safe and effective in all age groups and also in the middle-aged. And we should be proud that we have got a vaccine, the Indian vaccine, which is being used globally as a comparator vaccine. For any other vaccine which was manufactured by the Indian manufacturer, The comparator vaccine was a vaccine which was manufactured outside. Now the globe, across the globe, any typhoid vaccine which comes will be compared with our made in India type bar vaccine. Thank you.
Thank you, sir. Now I am requesting Dr. Indu Surana, please give the memento.
আমাকে নামিয়ে দেবে, আমি আসছি।
Sir, to come on the dais for our memento. Indudi will hand over our mementos to our speaker, Dr. Asim Ghosh. Now we coming on the next panel, Beyond HPV Disease and Immunization. Moderator Dr. Amita Sinha Mondol and panelist Dr. Choitali Ghosh, Dr. Shilpi Siddhant, Dr. Shanta Chattopadhyay and Dr. Tejaswini Mitro. All are requested to kindly come on the dais, and chairperson of this session is Dr. Moushumi Mukherjee. Requesting Moushumi madam, please come on the dais and take the chair.
Dr. Moushumi Mukherjee from Howrah and Dr. Moushumi Mukherjee ICH. Both are requested to please come on the stage.
Both madam are requested to come on the dais and take the chairs. Please take the chair. Ma'am, edike. Edike chair.
So very good afternoon. For this, I thank Howrah Academy of Pediatrics for giving me this opportunity to moderate this topic, and it's post-lunch siesta time, so I will try to be as crisp and clear as possible to keep you awake in the next 30 minutes. My esteemed chairpersons are Dr. Moushumi Mukherjee from Howrah. She is a consultant pediatrician from Howrah and also does a lot of social activities, and Dr. Moushumi Mukherjee of ICH, Institute of Child Health, who is also into developmental pediatrics. And you can see my panelists, esteemed panelists, Dr. Choitali Ghosh, Dr. Shilpi Siddhanta, Dr. Tejaswini and Dr. Shanta Chattopadhyay. So moving on to the topic. So my topic is on HPV. So cervical cancer, so that is one of the burning problems that the world and India is facing. Around 77,000 women are dying every year in India from cervical cancer. And you can see the global burden. India unfortunately is in a very high risk age standardized mortality rate group, almost very red, almost similar to the African nations. So we have a lot of work to do in this case. So the global burden is around about 6 lakh cases or new cases every year, and out of which 90% are from the low and middle income countries, and also around 3,42,000 deaths from cervical cancer are happening every year, and again unfortunately 90% of these deaths are from the low and middle income countries, and more women are now dying of this cervical cancer than during childbirth. So if we do not act fast, the cases will keep on increasing at a very high rate of around 54% till the time of 2040. So your action today can change the picture of this grim scenario. So do you recognize this gentleman? So he is Harald Ziu Hassan, and he was the one who actually established the link between HPV and cervical cancer. So that for this he was actually given the Nobel Prize in medicine for his discovery of human papilloma viruses, which caused cervical cancer. So he is the first one who actually established the link between the two. So what is HPV? Coming to HPV, there are around 150 types, serotypes of the human papilloma virus, but most notorious of these are around 14 types, which can cause around 6 types of cancer in men and women. Cancer of the cervix, vulva, vagina, penis, anus and oropharynx. So we'll come to our panelists. Dr. Choitali, what are the serotypes of HPV which actually are the causatives for causing cancer?
Good evening, everybody. There are actually more than 150 serotypes are there, but mostly the approximately 70% of the cancers are caused by serotype 16, associated with 13.5% by serotype 18. And there are 5 additional, all this 16 and 18 together contribute to 83.2%. And another 5 additional serotypes are there which contribute another 15.2%.
Right. So the 4-valent cervical cancer vaccines are actually covering 16, 18, 6 and 11, which are more important for the cervical cancer and the warts. And the 5 additional types of cancer are covered by the 9-valent vaccine, but they only contribute to around 15% of the cervical cancer cases. So Tejashwini, what are the risk factors for HPV infection?
Good afternoon, everyone. So there are several risk factors, as we all know, like if there are multiple sexual partners, unprotected sexual intercourse, any history of sexual abuse or any drug abuse like tobacco or marijuana use, then uncircumscribed male partner, inconsistent condom use during sexual intercourse. So these are the known risk factors for HPV infection.
Okay, and Dr. Shilpi, would you give us the timeline of this progression from the infection to the disease? How does HPV infection actually cause infection, and after how long does this become a disease?
Good afternoon to all. So this progression of the infection starts with the exposure, which is more related to the multiple sex partners, early sexual debut, high parity and no circumcision, as already described by Dr. Tejashwini. And then this infection depends upon the susceptibility of the host, that is the high risk HPV infection if it is there. If there are weak immune responses, other STDs and genetic factors are there. In that case, the HPV infection, the person gets HPV infected. However, the 90% of the HPV infections clear or become undetectable within 1 or 2 years. Now this infection that remains, it progresses to dysplasia or precancerous stage, which depends upon the microenvironment, which includes multiple HPV infections, smoking, long-term use of oral contraceptives, and which progresses to the precancerous stage. And here also there are chances of regression. Now, first the infection is the highest prevalence of is found in the late teens and early 20s. And this dysplasia and the precancerous stage is highest prevalence is found in 20s and 30s. The detection depends on age of screening. It depends on absolutely the screening. And this stage progresses to cancer in around a decade, and most diagnosed by 50 years in USA. It depends upon different genetic and epigenetic factors like HPV integration, tumor suppressor gene inactivation, etc.
Okay, so very nicely explained. So it takes a long time to progress from dysplasia to cancer, and just remember that a very few percent, around 80% of the women may actually get infected, women or men, but out of which a very small percentage will have the virus in the body, and of which also a very smaller percentage will actually progress to the disease. So this is again saying the same thing. The HPV persistence can happen up to 1 year, between 0 to 5 years. This progresses to the dysplasias, and in the next decade or so, it can, in a few percentage of women, can progress to cervical cancer. So this is how again it is depicted. So normal cells, then the precancerous cells, and then cancerous cells in the next 15 to 20 years. So just to let you know that estimated 50 to 80% of the population will get at least one type of HPV infection in their lifetime, and most of them will be asymptomatic. And the body will fortunately fight off most of the HPV infections in 2 years, but not all. And if it doesn't go away on its own, it can cause changes in the healthy cells. So how is this transmitted? Again, Tejashwini, I think it is almost the same kind of question, but just in brief.
So 2 arms, that is sexual contact and non-sexual contact, sexual intercourse, and for the virgin girls, they also may be infected with HPV, but it's a rare kind of transmission through non-penetrative sex, and proper condom use may help to prevent this infection. Those studies are still ongoing to prove this. And mother to child transmission, that is the non-sexual route, and fomites, again this is hypothesized but not yet proven that it may be transmitted via fomites.
Okay. So we will now come to the vaccines. So these are the vaccines which are the recombinant L1 capsid proteins made from the virus-like particles, and these virus-like particles produce higher levels of the neutralizing antibody than the natural infection. So in brief, to let you know, we don't have the bivalent vaccine at present. We have 2 quadrivalent vaccines in our market, and they will cover 6, 11, 16 and 18. 6 and 11 are mostly causing the genital warts, and 16, 18, about 84% of the cervical cancers are caused by these 2, and the rest 5 serotypes are responsible for around 15% of the cervical cancers. So these are the vaccines: bivalent not available, quadrivalent from serum, and quadrivalent from MSD, and the 9-valent which comes at a higher cost, covering the rest 5 serotypes. So Shanta, why doesn't natural infection provide immunity? As I told you, 50 to 80% women or men are getting infected. Then why don't we just depend on everybody to get a natural infection and then herd immunity?
So thank you for the question, and this might need an elaborate discussion, but to keep it short and simple, we know that natural HPV infection is essentially and exclusively intraepithelial. The virus infects the basal epithelial cells of the skin and the mucous membrane, and it restricts its life cycle within the epithelia. So there is minimal or no viremia. The virus does not access the lymphatics and the draining lymph nodes where the adaptive immune responses are usually initiated. So the antibody response is limited. If we look at the natural course of HPV infection, as already shown, most of the infections will be cleared by the host's innate immune responses. And of the remaining, those which progress to cause benign lesions, those also mostly will be resolved by the cell-mediated immunity mounted by the host against the early non-structural proteins of the virus, like E2, E6, etc. However, the activation of the cell-mediated immunity is it is associated with, or it's followed by, some seroconversion, where neutralizing antibodies will be formed against the viral L1 capsid protein. However, this antibody response is slow and it's delayed. It can take months to develop. The titer is low, and it also varies with the type of the virus as well. Like HPV-18 has a poorer seroconversion compared to HPV-16. Like studies have suggested that boys have less seroconversion rates than girls, and the women, only 50 to 70% of the women will seroconvert, and amongst them only 20 to 25% will have persistent antibodies for 10 years or so. So the long-term protection is also limited with natural infection. But on the contrary, when we vaccinate, so either with a quadrivalent or a nonavalent vaccine, so because we are administering it IM, so after the intramuscular administration, the vaccine VLPs, they immediately gain access into the vascular and the lymphatic compartment and the draining lymph nodes, and the entire cascade of this, the humoral response is initiated. And because these vaccine VLPs are highly immunogenic, this antibody response is rapid and robust, and also the serological and the reactive B cell memory, those are also substantial. So vaccine can confer a very effective long-term protection to the individuals who are vaccinated. However, we have to remember that we have to vaccinate early in the adolescent age, because as we know that because this HPV is ubiquitous in nature, the infection is contracted fairly sooner with the initiation of sexual life. So ideally, we should be vaccinating early to get the optimum efficacy from the vaccine between 9 to 14 years of age of the girls prior to the sexual debut. And yes, in our context, if more and more girls we can vaccinate, that can confer some herd immunity to the boys as well.
Okay, so now I think Dr. Indu will now be after us for time. So we have to be short. So Tejashwini, is there any evidence? So recently in 2022, the WHO SAGE committee actually said that for countries who have low resources and have to vaccinate a larger population, so there were studies which proved that one dose of the HPV vaccine was as effective as a two-dose regimen. So can you enumerate some other studies also?
So from 2004 till 2018, the 4 important studies which have taken place in Costa Rica or the International Agency for Research on Cancer in our very own country, and also in Tanzania or in Kenya, all 4 of them have suggested the same thing. The conclusion was that one dose of the vaccine is efficacious if given on time, and it provides an immunity for next 10 years post-vaccination. So specifically in this Costa Rica vaccine trial, they measured the antibody levels, which was 10 times the antibody levels as compared to a natural immunity, which would have taken place, as Dr. Shanta ma'am mentioned. So yes, one dose of HPV vaccine is as effective.
So thank you for being very short and clear. So this was the IARC trial. This actually was started as a randomized control trial, but due to some unknown reasons, the government of India, they stopped vaccination. And later what they did was they converted this to a retrospective study, where they saw that girls who were given a single dose, girls who were given 2 doses, and girls who were given 3 doses, they actually mounted the same kind of response. The vaccine efficacy was almost similar, 95, 93, 93. So that is how a single dose efficacy was also proven. So why is the young adolescent vaccination crucial? Why are we more and more stressing on that you should get vaccinated early? You should give them the vaccines early. So Shanta? No, Shilpi. You can say, okay.
So different studies have been done. International collaboration of epidemiological studies of cervical cancer from the International Journal of Cancer collected 21 national epidemiological studies. The data showed that there was increasing risk with the age of first intercourse, with the earlier the age of the first intercourse, with a relative risk of 3.5 for those with AFI less than 14 years versus those with AFI more than 25 years. Hence, the cervical cancer incidence rate increases approximately as a square of time from first intercourse up to 45 years, and then flattens as the age increases. Secondly, there is a cumulative risk of the cervical HPV in females from 15 to 19 years with one sexual partner. It showed that the median time from the first intercourse to the first detection of HPV was only 3 months. Hence, the importance of vaccinating early. It's shown in different studies like Udaya survey, which are conducted in 2016. And
it was shown that around 64% of these girls were actually sexually active. So in India also we cannot ignore this. Baba. We cannot ignore this. So again this
yeah. And there was a higher immune response in adolescents versus young adults, as shown in this graph. The serum anti-HPV-6 response 1 month after completion of the vaccination regimen versus the par protocol immunogenicity population, it showed definitely that the age at as you can see, from the 9 to 23 years, it's given the x-axis. With the age of enrollment, the serum's GMT, that is the geometric mean titer, it is more in the earlier ages than the later ages.
So the young adults, they mount a very good, robust immune response. Hence, we can utilize this age group to give them the vaccine earlier, before their first sexual debut. And also because we can only do away with 2 doses here. After 15 years, remember, we have to give more number of doses. So we have to target this population, because then they will have a good response. They will be not earlier infected, because remember, if a person is infected with one HPV serotype, he will not get protection by the vaccine also from that serotype ever after. So we have to actually vaccinate them before their sexual debut. And how effective is this vaccine in older women? Then suppose a mother also comes to take the vaccine, would you discourage, or would you tell her the facts that okay, you can take the vaccine but the effectivity would be lesser than what your girl would get the protection? So who will take this? Yes, Chaitali.
Yes, definitely we will encourage the mother to take the vaccines, but we should know the facts that people, mothers, females actually, who are not infected with any of the vaccine serotypes are usually benefited maximum. And also those infected with the vaccine serotypes, those will get the protection from the other serotypes only. And there is a study known as Future 3 study where quadrivalent vaccines showed higher efficacy even in 24 to 45 years of women, regardless of previous exposure to HPV vaccine type. But this is very important. Vaccine will not have any effect on existing HPV infection, pap smear or warts.
Okay. So you'll take
yes, and this is a study which shows that impact of quadrivalent HPV vaccination on women who have undergone cervical surgery. There were 2 groups of women. One has given vaccine peri-surgical time period, and another group were given placebo. And there is definite overall reduction rate in 46.2% in the group who have taken the quadrivalent vaccine only.
So yes, so definitely there's an utility of giving this vaccine even though that person has been infected and is undergoing treatment. So Shanta, do you think the vaccine has proven its efficacy over the years?
So I think we all now know the answer. Definitely HPV vaccination is effective and it's getting successfully rolled out globally as also in our country. I can refer to this study. It's a study done in Sweden 2020. It was a huge study using a quadrivalent HPV vaccine where 1.7 million females between the ages 10 and 30 years, they were followed and evaluated. I'm not going into the details of the study because of time constraint. I want to highlight only that in this study, only amongst the 4,39,000 participants aged 10 to 16 years, they had the least number of cases of invasive cervical carcinoma, only 2 cases. So this study showed that it is 88% protection against the invasive cervical cancer when vaccinated, the individuals got vaccinated before age 17. So the vaccine was effective, and that effective also when given early. Similar results also came out of this 14-year long-term follow-up study amongst women from the 4 Nordic countries, which also showed a vaccine effectiveness close to 100%. So next, so males also should be considered for HPV vaccination because of the high association of the HPV infection with some of the notorious carcinomas that contribute to high morbidity and mortality in males, like anal cancer 90%, 63% penile cancers, 30 to 70% the oropharyngeal cancers. And also in this systematic review and meta-analysis on the global and regional estimates of genital HPV prevalence among males, also they showed a high prevalence among the young males between 25 and 29 years. And in India, the prevalence was high as 26.7%. And in a very interesting study where the spouses of the women who were suffering from cervical cancer, they were studied, and the HPV prevalence among those males were found to be as high as 66.7%. So definitely, I think all these studies underline the importance and the relevance of considering HPV vaccination in males too.
Okay, Shilpi, just in very short, the 9-valent vaccine, 2 or 3 maybe sentences about this.
Yeah, the 9-valent vaccine, it showed that there was non-inferiority to 4 quadrivalent vaccine, that is to the 6, 11, 16 and 18. And there was also efficacy against clinical endpoints, that is 31, 33, 45, strain number 53 and 58. It was shown. And in this study also it was shown that there was not much difference in the geometric mean titers between the quadrivalent and the 9-valent vaccines among the different serotypes, that is the 6, 11, and 16 and 18. And in this study, it was shown that in case of high-grade cervical, vulvar, and vaginal disease related to 31, 33, 45, 52, or 58, as well as persistent infection more than 6 months duration related to the same above strains, the risk reduction was significant. It was around 96.7% in the 9-valent vaccine.
Shanta, now the most important thing, because we have different schedules for different age group and there is often a confusion if the child is coming to you before 15 years, after 15 years, a boy is coming to you, a girl is coming to you. Just enumerate in short and clearly the schedule for HPV vaccination.
So as per the latest recommendation, the ideal age of vaccination is 9 to 14 years. All the girls should be completing their vaccination by their 15th birthday ideally, and in this age group it is a 2-dose regimen, 0 and 6 months, and any vaccination that we initiate after 15 years is a 3-dose regimen, 0, 2 and 6 months. And the vaccines available are the quadrivalent vaccines from two like Serum Institute, if I have to name, the Sarvavac, and from MSD it's a Gardasil 4, and one nonavalent vaccine we have, that's Gardasil 9. So in this age group, for the girls, we can pick up any of the vaccines, it's recommended. And for boys, either Sarvavac or Gardasil, these two are recommended. And Gardasil 4, we are not recommended for boys of any age. And beyond 15 years, so 15 to 26 years for girls, again, any of these 3 vaccines can be chosen. And for the males, only Sarvavac is recommended. And 26 to 45 years, only females have the recommendation for vaccination, and that is too with Gardasil 4. And regarding the minimal interval between doses, so in a 2-dose schedule, we know it's ideally should be 6 months. So the minimum interval should be at least not less than 5 months. Similarly, in a 3-dose schedule, the minimal interval between the first and second, which ideally should be 8 weeks, it should not be at least less than 4 weeks. The dose 2 and dose 3 interval, ideally it is 16 weeks, should not be at least less than 12 weeks. And the minimum interval between dose and dose 3, which is ideally 6 months, should not be at least less than 5 months. So any dose that is given before these minimal intervals will be considered an invalid dose, and we have to give the due dose in the proper time. However, for all immunocompromised individuals, it's always a 3-dose schedule, irrespective of the age group.
So thank you very much, and already I told you that the WHO SAGE Committee 2022 recommendation, they have reduced the number of doses if you are in short of resources, 1 or 2 dose schedule either ways for girls between 9 to 14 years, 1 or 2 dose schedule for women and girls between 15 to 20 years, and 2 doses with a 6-month interval for women older than 21 years. So this was based on the fact that single dose schedule can provide equal efficacy or comparable efficacy and duration of protection as of a 2-dose regimen. So suppose a person gets inadvertently administered a vaccine, HPV vaccine during pregnancy, what would you do?
There is no risk of miscarriage, abortion, stillbirth, or congenital abnormalities till date recorded.
Yeah, so we have to reassure them that okay, you have taken the vaccine, but no further vaccination of that schedule can be completed before the end of the pregnancy. So once the woman delivers, then you complete the remaining doses. You do not have to repeat a schedule. At any point of time, there is no need, even if the girl or the woman comes to you after 1 year of taking the 2nd dose of a vaccine, HPV vaccine, you do not need to repeat the whole schedule because the memory cells which will have the immunogenicity still. So you can only give the remaining dose. You need not repeat the whole schedule. So just coming to the last slide of this session, now should people be screened before giving the vaccine? Anybody?
No, there is no need to screen before giving the vaccine.
So do we need boosters for the HPV vaccine?
No, as it gives long-term protection, so no need of boosters also.
Okay, so how many doses needed for a girl who got 1 dose at 14 years, 8 months, and now is 15 years, 3 months?
2 doses.
Now Kripada has got up from his sleep, so again he can answer.
We have to take the age at which the first vaccine
So
was given.
Basudevda, what is your answer? Okay, so you have to only consider the age at which the vaccination was started. So irrespective of how much later she comes to you, you have to only give 2 doses because you started before 15 years of age. So is revaccination advised with 9-valent for people who have earlier received a series of 2-valent or 4-valent? So is it recommended? So it is not recommended. As of now, there is no recommendation. It's not recommended. So next question, a 14-year-old was started on a 3-dose schedule. She received, মানে কেউ ওকে একটা 3-dose schedule ভুল করে start করেছে in another center. She received first 2 doses 2 months apart. As now she is less than 15 years, is her HPV vaccination complete or does she need a 3rd dose? মানে কৃপাদাত আপনি আনসার করলে চলবে না? She needs a 3rd dose. Why? Because at 14 years you have to give it at 0 and 6 months. So if it is given earlier than 5 months, you do not consider it as a valid dose. You have to now again repeat the dose, right? What if a female becomes pregnant? I think I have just told this answer. So you complete the vaccine. Yeah, so you stall the vaccination now. After she delivers, you then complete the vaccination. Can HPV vaccination be given to a lactating mother?
Yes, it can be given to a lactating mother.
Yes, so it is safe in lactation. A girl receives 1 dose of HPV at 11 years and she did not follow up. Now she comes to you at 14 years. Should you restart the schedule?
No, there is no such recommendation to restart because it was initiated 11 years, that is between 9 to 14. So it was a 2-dose regimen that was intended. So I'll give the due dose now, only the single remaining dose.
Very good. So if the series is started with a 4-valent vaccine, now can it be completed with a 9-valent vaccine?
So yes, we can complete the series with the nonavalent vaccine doses. However, it is not necessary to restart. Schedule should not be restarted with the nonavalent. The remaining doses can be replaced.
Thank you very much. I think this was the last slide. What male children? হ্যাঁ বলুন স্যার এটা হচ্ছে
না না জনতার পারমিশন থাকতো না
दिया तो आपको बताया तो मेल चिल्ड्रेन ने अपनी तখন ঘুমিয়ে পড়েছিলেন তাহলে কি গার্ডাসিল 9 accepted
Sarvavac sir 9 to 26 years
9 to 26 males
both
Sarvavac
both male and female
both
you
boys
have
and
your
girls.
own made in India vaccine you can give it to 9 to 26 years
Sarvavac
Male and female.
9 to 26 both girls
both
and
male
boys.
and female
And Gardasil 9 only boys sir 9 to 14 girls 9 to 26
because studies tab tak
studies.
hua hai because that studies have been done till
Thank you
26
so
years
much. Thank you, Amita Di. Now I'm requesting our chairpersons to hand over the mementos to the panelists and the moderators. Dr.
already
Moushumi
introduced-
Mukherjee, both are from ICH and from Howrah.
So I'll request them to just say a few words. Yeah. So can you sum up or you want to say anything?
So it was very eye-opening. Thank you, Dr. Amita and the panelists for giving us small snippets of very important information. And I was just reading, I know that in the West there is the screening program.
Yeah.
We don't have the cervical cancer screening program, so it is all the more important that the vaccination should go ahead. And I think UNICEF is going ahead with it. Hopefully it will materialize soon. So, Dr. Moshe.
Thank Howrah Academy of Pediatrics. I think if price get lesser, then the opportunity of giving vaccination will be more.
Thank you. Please come on.
Have you noticed? This is the power of Nari. So, right from the chairperson to the panelist and the moderator, all are Nari. So this is my plan. We have intended
Thank you.
Doing this, and Torun has supported me. Shobanda do like this session. So thank you.
Amitadi, Amitadi, Shantadi, Tejoshini, Choitalidi, Shilpi. Now requesting Amitadi to hand over the mementos to our chairpersons. A group photo. Come on the next session, how lecture on the Beyond the Guard, how drugs-induced dysbiosis affects overall health in children by Dr. Indu Surana. Chairperson of these sessions are Dr. Shantanu Ghosh and Dr. Shyama Prasad Das. They are requested to come on the dais. I am handing over the mic to the Dr. Indu Surana.
Slide change. So after this, two talks on vaccines. Now we are moving ahead to the gut.
So we have the chairperson of the session, Dr. Shantanu Ghosh, very senior pediatricians of rural India, and Dr. S.P. Das of Andul. So you please introduce Dr. Indu Surana.
Good afternoon, everybody. It is my privilege to introduce to you a dynamic member of Howrah IIP, who is not only known to us, but also outside West Bengal, for her relentless efforts to raise the fame of Howrah IIP in association with other able and eminent members, not only in academic fields, but also in various social welfare activities. She is none other than Dr. Indu Surana, the past president of Howrah IIP and present vice president of WBAP. She is associated with DBI Foundation and Research Center, Howrah. She has special interest in infant nutrition and neurodevelopment in early childhood. She is administrative coordinator of fellowship program of IIP neurodevelopmental chapter and also its state coordinator. Today's topic is on dysbiosis induced by drug, which not only interferes with gut metabolism, but also has its effect on overall metabolism and neurodevelopment of children in their later life. Now I welcome Dr. Indu Surana for to enlighten us on this subject.
Thank you so much, sir, for that kind introduction. And I was in a hurry. I'm late came and started the talk. So beg your pardon for that. So beyond the gut. So now how drugs can induce dysbiosis and it will affect the health of the children. So we are using drugs in our day-to-day practice, and this is the human microbiome. We are all very much well versed with what it is. So it is the set of organisms which we all have in our body, and from childbirth there is a interaction between the body and the microbiota which begins right from the time the baby is born, and it is not only from that time, even in the intrauterine period there is a interaction which begins. So they maintain the general health and well-being. So this eugenesis is very much important, and whenever this eugenesis is disturbed and it goes into a dysgenesis, then there is the beginning of all the illnesses which we see. And see, this is the gut microbiome, and it is closely connected to the individual's health and the diseases which they experience. So as per the current consensus, the microbiome has individualized composition. So just like one size does not fit all. So each one of we are harboring very individualized microbiota, and the environmental factors, they play a very important role in shaping these microbiomes, and with that the diet and drugs in particular, they are the major driving forces for the composition and the functional diversity of these microbiota. So what are the functions of this gut microbiota? Not only the metabolic functions like vitamin B12 and K synthesis, but the most important is the defense. So they are the policemen of our body, and they are having some tropic functions also. They maintain the intestinal integrity of the epithelium of the intestine. So regulation of the immune system and so on and so forth. And we all know that there is a gut-brain axis, there is a gut-liver axis. So this gut is in fact related to most of the organs of our body. And if something goes wrong in this gut, the whole system is affected. And this is what we call gut dysbiosis. So when the pathogenic flora, they overcome, they are more in number than the normal good microbiota, then we call it dysbiosis. And there are intrinsic factors, there are extrinsic factors which influence the gut microbiome, like a healthy diet, some which favors good microbiota, medicines, the day-to-day antibiotics which we are prescribed, and this is the talk which we are going to discuss about this only. Smoking, different diseases, the genetics of the host, there is some role because genes play a role, and in fact a lifestyle. So the intrinsic factors are also very important apart from the extrinsic ones. And there is a complex bidirectional interaction between the gut and the drugs. It's not only that if we are having antibiotics, too much of antibiotics, the microbiota is disturbed. On the other hand, it's the gut microbiota which also decide the metabolism of these antibiotics, the metabolism of these drugs, and that is why everyone is not having the same reactions to the drugs. Someone is having amoxiclav and is having a diarrhea, but the other person is okay. So why does that happen? Because the gut microbiota is like that. So we are going to discuss mainly upon this we can say, yeah, this is not the environmental factors, but the man-made factors, that is antibiotics which are associated. And the recent, if you see the recent trends of antibiotic use in India, I would rather say it is a misuse nowadays, because India has found to be the world's largest consumer of antibiotics for human health in 2010. So you can just see these alarming numbers. And between 2000 and 2010, 76% of the increase in global antibiotics was attributable to these BRICS countries, that is Brazil, Russia, India, China and South Africa. And out of these, 23% of the increase was contributed by our country. So this is the association, as you can see, with some of the commonly used antibiotics which we are using. like meropenem, gentamicin, vancomycin. So we are having so many intensivists here who are using these day in and day out. But obviously we have to pay a price when we are using these antibiotics, because they are increasing the gut susceptibility to colonization with other pathogenic bacteria, and then we are getting all the hospital acquired infections, the nosocomial infections and all those things. So the antibiotics disrupt the gut ecosystem, they increase in the antibiotic resistance genes, there is a change in the bacterial metabolites, there is a disrupted bacterial signaling and antimicrobial peptide secretion. So these are the different ways in which the gut microbiota and the host immunity is negatively influenced by these antibiotics. And here you can see the different antibiotics, these beta-lactams. There are some microbiota which are suppressed by this, some which are increasing. So basically most of them, what they do, they are suppressing the good microbiota, and because of that the harmful ones are having a overgrowth, and then there is a dysbiosis. So we are using many antibiotics like cefotaxime. So there is an increase in the relative abundance of bifidobacteriaceae when we are using cefotaxime. Again vancomycin, it decreases the microbial diversity and the absolute number of gram-positive bacteria, especially the Firmicutes phylum. Again metronidazole, it is exerting no effect on the microbiota, likely because it is mainly absorbed in the small intestine. So these are some of the examples of how these drugs are working. This is again the beta-lactamase, the glycopeptides. So there is a decrease in the number of the beneficial bacteria, and again the same thing, that vancomycin, imipenem administration, it resulted in increased susceptibility to Clostridium difficile infection, potentially by serving as a growth substrate for these. So there is a decrease in the relative abundance of some of these good bacteria which convert this arabinitol to pentose sugars. So there is an increased susceptibility to Clostridium difficile when we are using these antibiotics. And it is not that if we are using these antibiotics for a long time, even if it is used for a short time, it can have a long term damage, like it can be seen in the long term. So this study was done assessing the effect of ciprofloxacin used in a dose of 500 milligram twice daily for only 10 days, and clindamycin also, and the results were alarming because the change in the microbial composition was observed within the 12th month, with the most pronounced microbial shift even starting from 1 month. So it is not a very short story which begins at 1 month, the thing will continue for a long time also. And these are some of the long term complications of the dysbiosis or the antibiotic usage. Like I am not going into the too much, like allergy, increase, what do you say, incidence of allergic conditions, autoimmune diseases, infections, inflammations, metabolic and other neoplastic conditions. So they are on the rise, and we see nowadays that some of these non-communicable diseases, they are more on the rise. The lifestyle changes, and these all are giving rise to the different diseases. And the effects on microbiota and associated health problems, as you see. So I am not going into the details of this because we all know what it is. This is the study on macrolide use on early life, which is associated with increased risk of asthma and predisposition to antibiotic associated weight gain also. So these are some of the alarming studies which we can come across. And allergic diseases are on the rise. We see most of the children nowadays, they are on inhalers taking anti-allergics. So milk allergy and other allergies also. So as I said, it is not only just after the birth of the baby, whether it is a vaginal delivery or a cesarean section, we usually correlate that babies who are born vaginally, they have a good microbiota, but those who are born with a cesarean section, they don't have that advantage of getting the good microbiota. But it is starting even before that. So कहानी बहुत पहले से शुरू हो जाती है. It's prenatal and even the peripartum times. So exposure to antibiotics. So this is like a scene which we come across in our day-to-day practice. The mothers are being given high dose of antibiotics before the delivery. Even if there is a rupture of membranes for say 2 or 3 hours also, the mothers are given parenteral antibiotics. And when the baby is born, the baby is given cefotaxime for the first 3 days. I see this as a regular practice in some of the hospitals. And when we question the obstetricians that why they are doing it, just to prevent infection in the newborn. So as we all know, there is no preventive strategy for preventing infections in the newborn. But this thing is continuing and we should discourage this. So if we use antibiotics injudiciously, we will land up in antibiotic resistance in later life. We all know that. And prenatal exposure to antibiotics in the 2nd or the 3rd trimester were associated with the higher offspring risk of even childhood obesity, increased risk of asthma, increased risk of hospitalizations with various kind of infections. And how do these impact in the fetal life? So until now we knew that the fetus and the intrauterine environment were sterile, kichu jete parbe na. But no, there are some antibiotics which can cross this placenta barrier, which can enter the gut of the fetus and change the microbiota. Again, PPIs, which is used very rampantly. So even these PPIs are associated with a lot of dysbiosis, and this is the effect of PPI treatment on the composition of gut microbiota. So please be aware when you are taking PPIs. Some people, they take it on a regular basis, like you see months and months. আমি তো রোজ সকালে একটা প্যান 40 খেয়ে যাই. So please be aware because you are almost wiping out your microbiota. And what are probiotics? We know they are the live microorganisms which when administered in adequate amounts, they will confer a health benefit on the host. And this is the role of probiotics in antibiotic associated dysbiosis. So in children, usually in day-to-day practice, we don't get so much, but those who are hospitalized, those who are undergoing a lot of parenteral antibiotics for a long duration, this problem definitely comes up. And there comes the role of probiotics in helping to prevent the gut dysbiosis. And this functionality is mainly based on the bacterial interaction with the host gut microbiota. And for gut dysbiosis, we can give a consideration for Bacillus clausi. There are many probiotics now flooded in the market, and we are sometimes spoiled at a choice that which one to use and which one not to use. So we can use this associated diarrhea, and there are studies we see that the stool consistency improves from day 2 or 3. It starts repairing gut from day 1. Even in IBS, it has some role in rotavirus infections, in acute diarrheas. It reduces the duration of vomiting in acute diarrhea also. Consistency was seen that it was almost the same with most of the probiotics which were used within the first 24 hours. So that does not make much difference. So the key messages are broad spectrum antibiotics, they affect 30% of the gut bacteria leading to antibiotic induced dysbiosis of the gut. And so we have to be very careful when we use antibiotics, not only in the child but in the mother and after the child is coming to us with the day-to-day common coughs, colds, the loose motions, the viral diarrheas. We should refrain from using antibiotics. We just celebrated the antibiotic awareness month, in fact in November I think, and in Howrah we did a lot of programs with this, and this is just a picture from that flip book which IAP Ki Baat community ke saath had made. It was a very interesting flip book. The war against antibiotic resistance is far from over, but with knowledge and responsibility we can still win. Use antibiotics judiciously, prevent antimicrobial resistance. And we need to learn more from IAP. We are having so many nice workshops, and I would encourage all of you to please participate in these workshops and go ahead and be with us, with IAP, with WBAP, with Howrah Academy of Pediatrics. Thank you so much. Hoping to see you all. Register for the Pedicon we are hosting next year, and the early bird registration is continuing till Shapunda 31st March. So those who have not registered, please register as soon as possible, because we are hosting it and we want 100% attendance from our state. Thank you so much.
Thank you, Indu, for your lucid and elaborate deliberation. Thank you.
Requesting Dr. Indu Shurana madam to give the memento to the chairpersons, and this is not the gold coin. And requesting Dr. H.P. Das and Dr. Shantanu Ghosh to give the memento to Indu madam. Thank you. Now come to the next session. This is the session on the pediatric surgical cases by Dr. Nitin Vyas, and Dr. Joydipto Chatterjee is requested to come on the dais and take as the chair of the chairperson, please. Slide.
Good afternoon, everybody. Thank you, Howrah IP, for giving me the opportunity to sit as a chairperson in this pediatric surgery session. And Nitin is a very junior surgeon, very recently introduced to me by Bhagirathi Neotia in a short RTM, which was held in North Howrah. And I have a very brief conversation with Nitin, and he's a very energetic surgeon in Bhagirathi Neotia. And I hope he'll highlight on the basic surgical problems that we face in our day-to-day practice. So without wasting time, I welcome Nitin to this session, and please start your sessions.
Thank you so much, sir, for the introduction. I'll start with the common pediatric surgical conditions. So first of all, including starting from the head and neck, the most commonly seen midline neck swelling is the thyroglossal cyst, which is the diagnostic criteria is the movement of the swelling with the protrusion of tongue, and it may present as a cyst or a sinus. So complete removal up to the base of tongue is necessary and is completely curative. The next is the branchial cleft cyst. It may arise from first to fourth any arch or cleft, but the most common is the second pouch cyst, and it usually opens near the lower end of the sternocleidomastoid up to the foramen cecum. Next is torticollis. Torticollis is usually diagnosed even at birth with a slight deviation of the face, but it appears as a mass in the muscle of the sternocleidomastoid. Usually during the infancy, no surgery is required up till the age of 12 months, when there is a stiffness of the sternocleidomastoid with the chin deviated to opposite side and hemifacial hypoplasia. This is the indication for surgery. Sometimes the children may present late by the age of 2 to 3 years when the hypoplasia is quite severe. Even after the surgery, the hypoplasia does not resolve. Neck exercises after the surgery are not so curative, but the definitive cure is surgery when the both the insertions of sternocleidomastoids are cut and the deep cervical fascia is also cut, resulting in the unrestricted neck movements. Then the cleft lip and palate. The age of surgery for cleft lip is usually by 6 months, and cleft palate is usually after the 12 months. Both can be either unilateral or bilateral. Then coming to pediatric thoracic surgical conditions. First is empyema chest. So in most of the cases, when the complicated pneumonia proceeds by the day 7 of pneumonia duration, It may lead to consolidation, leading to either pleural effusion, leading to empyema chest, lung abscess, or even necrotizing pneumonia. Most commonly seen in the lower socioeconomic status, but nowadays with the thoracoscopic approach, the results are very excellent. And if there is delay in diagnosis or delay in the presentation by the post pneumonia day 12 or day 13, mostly the open surgery is required and is curative with good results. In necrotizing pneumonia, nowadays necrosectomy is performed, which involves removal of part of lung only and not the complete lobe, and which gives good results. Congenital diaphragmatic hernia. So, newborn presenting with a triad of respiratory distress, apparent dextrocardia, and a scaphoid abdomen is a clear-cut clinical diagnosis of diaphragmatic hernia at birth. If at birth the oxygen saturation is around 60 or 70%, it is an indicator of bad prognosis, and is immediately shifted to high-frequency oscillatory ventilation, where the settings are kept to high until the weaning off of ventilator settings and oxygen saturation around 90% is achieved, when the delayed surgery is performed. So nowadays, immediate surgery with the poor oxygen saturation is out of date, and initial stabilization necessary for good results. Exit procedure may be required in selected cases at birth for securing the airway. Esophageal atresia with or without fistula. So the most classical type is the type C, in which the distal fistula is there with the trachea with a blind upper pouch, which can also be seen in the antenatal period with a dilated esophageal pouch in the upper cervical region. The primary repair is possible in the type C, and in type A, usually primary repair is impossible. We do a cervical esophagostomy and the feeding gastrostomy with a delayed repair at the age of 1 year at least. Coming to pediatric GI surgical conditions. So first is intussusception. So invagination of the one part of bowel into another is the definition of intussusception. The most common age group is between 3 months to 3 years. In this age group, the only cause is idiopathic most of the times, when there is transcircumferential involvement of the Peyer's patches of the terminal ileum during the period of weaning, you can say, and when the most common type is ileocolic type. The most common age group of idiopathic intussusception is 3 months to 3 years. Now, below 3 months and after 3 years, most of the time we have found some or the other pathological lead point. There are seasonal variations in intussusception, and most of these will correlate with the monsoon season of May, June and July, and it also correlates with the viral respiratory as well as GI infections. So these are the, we can say, initial lead points for the even idiopathic types. Initially there is engorgement of the mesenteric vessels and the intussusceptum, which leads to the pouring of blood and mucus into the lumen, which leads to classic red currant jelly stools. Most common cause as a idiopathic cause is Peyer's patches, but most common focal cause is inverted Meckel's diverticulum, which leads to the pathological lead point leading into the ileum and then colon. So there are 2 classic signs and 2 classic symptoms in intussusception. The 2 classic symptoms are crampy abdominal pain. Baby will come with extreme abdominal pain, and within a few minutes he will be completely calm. So these presence and absence of symptoms is classic for intussusception. Otherwise, vomiting. Initially it will be non-bilious, followed by bilious vomiting. 2 classic signs are abdominal mass. It is palpable usually in the right hypochondrium or right iliac fossa, which is the classic site of the ileocolic type. And the other is the perrectal bleeding. Perrectal bleeding, when it is present, it is a grave prognosis sign, and it is indicator of some vascular compromise. So pain is severe, colicky, intermittent, and lasting only few minutes. In between the 2 episodes, patient is calm and pale, and mass is more palpable better when in between the 2 episodes when the baby is quiet. Ultrasound is very diagnostic with the target sign, and in management, even in any type of intussusception, first management is nowadays non-operative when the pneumatic or hydrostatic reduction is done either fluoroscopy guided or USG guided, and usually gives good results. If it fails or if it recurs, we can give a trial of at least 3 trials for non-operative management. But if it recurs or if there is any grave sign like rectal bleeding, we have to go for surgery. Even nowadays, laparoscopic reduction is possible. But if there is signs of gangrene or shock, we have to open and do sometimes resection anastomosis of the involved part. Next is Meckel's diverticulum. So most of the Meckel's diverticula are clinically silent, and it usually is the diagnosis of exclusion when there is usually presentation within the first 2 years of life, and it is one of the part of the patent VID variants, and the only sign is the painless PR bleeding, and this is one of the 50% lower GI bleeding cause, and sometimes due to additions may lead to intestinal obstruction or due to perforation of Meckel's diverticulum. So the color of the stool is not indicative of Meckel's. It can be bright red, it can be dark red, it can be tarry, anything. So the only way to detect the Meckel's diverticulum is Meckel's scan, and only because of the ectopic gastric mucosa which is present in almost 80% of the cases, and the resection is either laparoscopic or open repair. Then umbilical abnormalities. So broadly there are 3 abnormalities: umbilical granuloma, remnants of VID, patent VID, or remnants of urachus. So remnants of VID include patent duct, completely patent VID, umbilical polyp, Meckel's diverticulum, a duct cyst, or just a fibrous cord which causes a volvulus around it. So any polypoid mass which is appearing at the umbilicus after the stump has fallen at its usual time warrants a further investigation, and an ultrasound is necessary to rule out any underlying vascularity, underlying communication with the GI tract or a bladder, considering it as a part of VID or a urachus, and surgical removal of any partial or complete tract is necessary. So management of a umbilical granuloma is just application of common salt. You just apply common salt for 30 minutes and cover it. Then after 30 minutes, you should wash it off. And you do this for 7 days, it will be completely removed. It will be gone. But if it is not a granuloma, it will never fall off. Or if it has some good vascularity inside. Common salt. Best thing, no reaction at all, and it is very comfortable for the child also. Yeah. Just sufficient enough to cover the granuloma, and the essential thing is that we should wash it off completely after 30 minutes. 30 minutes. Sir? Next day. Once a day only.
7 days.
7 days. And we ask them to put for 7 days, but by second or third day we can see the result, and it is started to getting necrosed actually. But if it is not falling, then we should do an ultrasound. And again, if it is not falling, we need to do a mini laparotomy or a laparoscopy to look for the an underlying communication, because many times the ultrasound is not completely diagnostic. We may miss, like in this ultrasound image, we can see a patent urachus, but sometimes it may be missed if it is an incomplete tract. Next is inguinal hernia and hydrocele. In both the cases, the cause is patent processus vaginalis. So for timing, inguinal hernia should be operated as soon as possible after the diagnosis, even at birth, even at preterm. Also in preterm, it is more risky with the risk of obstruction. Hydrocele, we can wait till 1 year of age, even if it is a large hydrocele. Undescended testes, it can be palpable or non-palpable. Timing of surgery is usually after 6 months of age. The only exception is associated inguinal hernia, when we need to do surgery along with the hernia surgery only, even at birth. It should be differentiated from retractile testes. So how do we differentiate? Just a well-developed scrotum, and on squatting position, the testes will naturally come into the base of the scrotum. We don't need to do any manipulation also. Thus, on squatting position, this cremasteric reflex will completely inhibit and will easily slide down into the scrotum. Torsion testis is one of the few surgical emergencies in the pediatric surgery. So any acute scrotum presenting to the OPD with pain in scrotum without any history of trauma should be considered as torsion testis. Even if the ultrasound reports is saying that it is a epididyma orchitis, it may be misleading because a case of torsion and detorsion is labeled as epididyma orchitis. So immediate exploration of the scrotum is extremely essential. It can save the testes, and within 6 hours of torsion, the chances of salvage are more. Coming to malrotation of gut. So malrotation of gut has usually 3 types of presentations. First is asymptomatic. We may never diagnose the malrotation without a volvulus, and patient may go on with the whole life without any diagnosis, or may come up with an incidental diagnosis on a routine ultrasound. Second is the acute midgut volvulus at the first month of life. So the classic age is within first month of life. You can say within first 2 weeks of life actually. So sudden onset of bilious vomiting in a previously healthy child who is feeding well and with growing weight, appearing with the scaphoid abdomen and bleeding per rectum. Complete obstruction can lead to ischemia or an abdominal distension. So scaphoid abdomen is not a classic sign, but in most of the cases in initial presentation, it will present as scaphoid abdomen with bilious vomiting and sometimes bleeding PR. So in comparison with the X-ray of duodenal atresia, in duodenal atresia there are 2 big size air bubbles, so considered as the double bubble sign. So in comparison with the duodenal atresia, in X-ray erect of the malrotation, the stomach bubble will be very huge, but the duodenal bubble is relatively small with very scanty gas in the distal bowel. This is because the cecum is actually sitting over the duodenum and is not allowing the duodenum to expand as much as in duodenal atresia. Third presentation is chronic midgut volvulus. It will be presenting after the age of 2 years. So it will present with the chronic vomiting, intermittent abdominal pain, diarrhea, sometimes hematemesis. In all the cases, treatment is correction of the volvulus with the LATS procedure. This is the classic treatment. Coming to Hirschsprung disease. So delayed passage of meconium even after 48 hours of birth should raise suspicion. So in a neonate, it will be, sorry, should I continue? So neonate presenting with the abdominal distension, vomiting and infrequent passage of stool. Symptoms are more prominent after the weaning period, and in delayed presentation after 2 to 3 years, they will present with chronic constipation. Typically in comparison to the constipation, there will be semi-solid stool, not hard stool. And on per-rectal examination, there will be burst of feces and flatus. Most common is the rectosigmoid short segment type. Diagnosis is by contrast enema, in which the normal caliber is actually normal and is the abnormal part, and the dilated colon is actually the normal thing. So on the arrow is showing actually the transition zone between the aganglionic distal segment and the ganglionic proximal part. Surgery is done by usually the initial divergent colostomy followed by the definitive procedure. Anorectal malformations can be low, intermediate or high. Low type can be repaired by single stage, high type or intermediate in the 3 stage. Rectal prolapse, the most common causes in the pediatric age group is habitual constipation. Initial management is strict diet modification and followed by injection sclerotherapy if does not resolve, and in reluctant cases, angioplasty is done. Then urological cases. First is the PUG obstruction, in which the most commonly the antenatal diagnosis occurs, and 90% of the cases will resolve on their own. Indications for surgery is a palpable lump, function of less than 35% on the DTPS scan, AP diameter at least more than 18 mm at birth, and T-half on the EC scan at least more than 20 minutes.
Nitin, may I interrupt? Since we are running short of time, how many slides do you have left?
A lot of slides.
We have number of speakers awaiting.
Okay, okay, sir.
So
I'll just
if you can wind up in few minutes,
okay,
few seconds, it
so
will be good.
this is a very big topic, vesicular reflux. So
common pediatric surgeries.
A culture-proven UTI and where recurrent episodes of UTI may need diversion. Otherwise, at the age of 1 year, ureteric implantation. Posterior urethral walls, palpable bladder at birth, poor prognosis, leads to hydroureteronephrosis, may need diversion and fulguration of walls. Ureterocele at the infancy requires cystoscopic incision of the ureterocele, and at the age of 1 year, ureteric reimplantation, because every incision will lead to reflux. Hypospadias, timing of the surgery is 6 months to 1.5 years, and may require 1 or 2 stages. Varicocele presents at the time of puberty with the either asymptomatic or dragging pain. Laparoscopic ligation is definitive procedure and is 100% curative. DSD is very long topic. The most common type
let
is
us.
Okay.
It's a very good presentation. The common pediatric surgical emergencies and common problems in the day-to-day practice, well dealt by Dr. Nitin Vyas. Thank you,
Thank
Nitin.
you so much, sir.
May I request organizer to carry on with the next session.
I request our chairperson, Sir Joydeep, to kindly hand over the memento to our speaker. I request Dr. Nitin Vyas, sir, to kindly hand over the memento to our chairperson. Moving on to the most awaited session of today, that is the cardiology session. So I would request Dr. Shubhashish Sarkar sir and Dr. Ansar Ali sir to kindly come and chair this session. Dr. Shubhashish Sarkar sir, Dr. Ansar Ali sir to kindly come and chair this session. Sir, I would request you to kindly call upon the moderator for this session.
Probably this is the last session, scientific session of our Howrah Pedicon. I am requesting Dr. Shatanik Sarkar as a speaker and panelist Dr. Shubhodip Das, Dr. Amitabh Chattopadhyay and Shatarupa Mukherjee. I think this will be the most interactive session because it is on cardiology and we are facing lot of trouble in pediatric cardiology. We have with us 3 eminent pediatric cardiologists, mainly Dr. Amitabh Chattopadhyay, Dr. Shubhodip Das and Dr. Shatarupa Mukherjee. Shatarupa, sorry. Dr. Shatanik Sarkar is at present attached to SSKM Hospital, DM Pediatric Cardiology. I am requesting Dr. Sarkar to start the session.
Thank you, my respected chairpersons, and thank you, the Howrah Academy of Pediatrics, for giving me this opportunity to moderate this session on cardiology. So, first of all, I'll try to start with this topic which I have kept like for the general pediatricians, not too much cardiology, and also as 2 of my 3 panelists are intensivists, so I have kept the cases like the emergency cases or PICU cases on the basis of cardiology. So the topic is management of acute ailments in children with congenital heart disease a case-based discussion. So my first panelist is Dr. Amita Chattopadhyay, who needs no more recognition. Then Dr. Shubhadeep Das is a pediatric intensivist attached with NH Howrah. And Dr. Shatarupa Mukherjee is also, she is a pediatric intensivist attached with BM Birla Hospital. So I'll start with my first case. So this is a 3-month-old boy presented to pediatric emergency with fever and cough for 3 days and worsening respiratory distress for last 2 days. There is history of feeding difficulty, 1 hospitalization for LRTI 15 days ago. His on examination weight is 2.8 kilo, heart rate is 150 per minute, respiratory rate is 65 per minute, so his tachycardia, tachypnea, severe subcostal and intercostal retractions with saturation of 90% in room air and 100% with oxygen. On cardiac examination, there is a grade 2/6 ejection systolic murmur at upper left sternal border with S3 gallop. Liver is 4 centimeter palpable, below right costal margin, spleen is not palpable. So on further investigation, we found in chest X-ray that there is bilateral diffuse patchy opacities and ABG is showing respiratory acidosis. So child is already intubated in emergency and shifted to PICU because of worsening respiratory distress and impending respiratory failure. So this is a very common case we always found in our day-to-day practice in emergencies in PICUs. So first of all, I'll come to Dr. Shatarupa. So as a part of initial assessment, so what is your working diagnosis?
So this is a baby who is 3-month-old, and as we can see, there is a past history of hospitalization, and the baby is only 2.8 kilos at 3 months. So there is a background of failure to thrive with history of hospitalization in the past and feeding difficulty. And on admission, we can see that there is history of fever, cough, cold, and the diffuse opacities in the lung, and definitely there is a murmur. So this is a child with a probable congenital heart disease with a left to right shunt. It is usually a left to right shunt in a child with some respiratory infection and with heart failure. So definitely this child as was in failure, we need to tube the child in the ER, and then we had to shift the child to PICU. So,
I'll just put a few words that this is a large left to right shunt, large post tricuspid left to right shunt, that is large VHD, large PDA, maybe AP window, sometimes very rarely some cyanotic congenital heart disease with increased blood flow also. So next is what will be the fluid management.
So as we can see that the child is there's a big liver and there's a murmur. So this child needs some fluid restriction. We need to maintain a strict intake output of this child in the PICU. As starting from maybe we need to monitor the urine output, and we need to give fluids initially. Once we have stabilized, we need to monitor. We need to monitor multi-para monitoring, and we need to monitor the blood pressure. And depending on that, we need to start inotropes, or the child might need some aliquots of fluid boluses. So definitely, and nutrition, which is very important. So at no point of time we should restrict the patient from having enteral nutrition. Definitely, the child should be started on early feeds. There is no, as far as the patient's hemodynamics are stabilized, we should think of starting feeds early, and definitely supportive care like ventilation, sedation, fluid nutrition, and starting antibiotics, sending cultures, and getting an echo done, and so these are all part of the basic ICU care for this child.
And a part of basic heart failure management to start diuretics also.
Yes.
Next, my question to Dr. Shubhadeep. So what will be the ventilation strategy? So what will be the settings? What will be the targets, saturation, weaning challenges?
See, there are few important points to note and few important points to remember here. One is this child, as we know, is having a large left to right lesion, right? So there is a lot of blood going into that lungs. At the same time, this child is suffering from pneumonia. Now, while ventilating such a child, we have to remember that if we ventilate them hard and if we target a lot of saturation in the high 90s, what might happen is, because oxygen is a very strong pulmonary vasodilator. So what it can do is, it can reduce your pulmonary vascular resistance, And in a child with already a big left to right shunt, it can increase the shunt volume much more. So your lungs can become totally much more wet, and you may have weaning challenges, right? At the same time, this child has got pneumonia. So if the chest X-ray, it's kind of a balance. If the chest X-ray is wide and looks like a very severe pneumonia on the top of a left to right lesion, in the initial phases, you have to treat like a severe pneumonia. You don't ventilate too hard. You probably target saturation in the low 90s. You maintain a good FRC, as in you use your PEEP judiciously. And then once the pneumonia starts to resolve, you have to quickly come down on the FiO2, because that will help in your weaning strategies. When do you wean the child? It's like weaning any other children. When the child is adequately awake enough, when the child is able to generate good breaths without much sedation, and when we are down on reasonable ventilator settings, maintaining good gas exchange. So those will be kind of your standard criteria before you attempt to extubate the kid. Having said that, these children, we know that they suffer from failure to thrive. They are very skinny. So when we take the tube out, again, they might struggle. So in these children, typically I use a lot of non-invasive ventilation. It could be in the form of high flow. It could be in the form of, like pressure support, in the form of a mask. But using non-invasive ventilation is a very important strategy.
So a smooth transition is also important here, from ventilation to non-invasive and then to room air. And another point or message to give is, whenever a large left to right shunt like this patient went through a pneumonia, there is also a worsening of the heart failure. Already heart failure situation which have worsened. So most of the times we have to increase the diuretics dose also in these cases, which after the resolving the pneumonia, we can again come down. So now, so Amitabh sir, so what will be our clinical diagnosis from cardiologist point of view, and then management plan?
From the cardiological point of view, as you have already said, it looks like a large left to right shunt lesion post tricuspid. So the obvious differential diagnosis would be a large VSD, a large PDA, or maybe an AP window. Sometimes obstructive lesions might behave in this way, but they are very rare. They usually do not behave in this unless there is a superseded infection. Now, the fact is, for example, the commonest and the most dreadful combination we are afraid, especially in our unit, and or rather anyone in the eastern part are afraid, is a combination of a large VSD with an LRI. What happens is, these helpless children, once they get into this vicious cycle, that actually damages both the heart and the lungs. And what happens in some of the societies, they do as a routine, they do a nasopharyngeal aspirate before the surgery to find out where they are harboring a lesion. Anyone harboring any viruses like the adenovirus and RSV virus, parainfluenza, and the influenza viruses, they cancel the OT and they call them after about 6 weeks. But especially in the eastern part of India, with a very high relative humidity in the atmosphere, we get a lot of these infections. And suppose, as he said, that if we discharge the child and give him a gap of 4 to 6 weeks, nevertheless, the child will again come and get admitted within the span of another 2 weeks. So we are left with two choices. Either we have to bite the bullet and do something as soon as the patient is slightly better, irrespective of the fact that he might not be totally negative or from the nasopharyngeal aspirate at that time. Or what we might do is that we might go for a complete repair, that is a VSD closure, telling the parents that he runs a high risk of a ventilatory failure or in the post-operative period. Or else what you can do is you can go for a PDA ligation if it is there, or maybe we can go for a PA band to save the day, so that at least the left to right shunt is somewhat restricted to keep the lungs slightly dry. From the medical point of view, we use diuresis, as Shubhadeep mentioned, sometimes to the extent that we might use 1 or 2 diuretics acting at different zones of the tubules, and we might add some afterload reducing agent so that the flow into the lungs is somewhat minimized, so that more flow is directed towards the system.
Okay, sir, rightly said. So we have both medical management, and some kids are so fragile, so they never come out of this infection. Sometimes we have seen. Yes. So in that case, we need to sometime go for a surgery whenever there is a small window. So maybe complete closure. If surgeon didn't agree, then only PA band also may help to recover.
Yeah. one important point is it has a huge economical impact. Whatever said and done, suppose the parents have accumulated money, for example, say 2 lakh rupees for the surgery. Now, when the patient gets admitted in any hospital, obviously they accumulate some hospital bill, which goes in for the whatever money they had accumulated might go into the medical management, so that during the proper surgery, they might be devoid of money. So we had to devise some way on the economical front also, so that at least the surgery can be done with whatever money they have accumulated. The government does help, but whatever said and done, this kind of a large left-right shunt lesion with an LRI is a dreaded combination.
So I think we are done for this case. Any question from the audience about this? Then we move on to the next case. One important point for the clinicians, which I have kept this clinical diagnosis part. So in VSD or PDA, whatever you are seeing is large lesion. So there is no shunt murmur. So most of the times the PGs, residents are still confused to say that in VSD there should be a PSM. That is pansystolic murmur. There is no pansystolic murmur, shunt murmur in large VSD or PDA. So this is only flow murmur.
Actually, one point, the weight of the child. Sometimes in previous days, weight must be say 8 or 9 kilograms, hemoglobin 9 or 10 kilograms per deciliter. Is there any restriction like this?
No, ideally there is no restriction. Large VSD, large PDA should be closed as soon as possible. Maybe by 1.5 months, 2 months, ideally before 3 months.
So the idea was that they might struggle in the post-op period rather than anything else. So now with the advancement of technology, we can manage these kids in the post-op periods. And one of the points is that because of this lesion, these children cannot grow. So if we keep that criteria, chances are that this kid might just not, not just survive. Yeah.
So we are moving to the next case. So this is a 3-month-old girl with history of occasional cyanosis on crying, now presented to emergency with history of inconsolable crying and deep cyanosis for last 4 to 5 hours. And there is a history of fever with loose stools for last 2 days. This kid is weighing 5.5 kilo, but there is altered sensorium, heart rate is 145, respiratory rate 70, saturation is 50% in room air. There is no murmur on cardiac examination, liver is only 1 centimeter, spleen not palpable, there is generalized hypotonia. Blood gas is showing metabolic acidosis with hypoxia. So he is intubated and shifted to PICU again. So I'll again come to my PICU specialist. So Dr. Shatrupa, again initial assessment, working diagnosis, fluid, drugs and ventilation strategies.
So this baby presented to the emergency with following a inconsolable cry and is cyanotic, and there is a past history of cyanosis on crying. So that is a trigger point that this is something like a phallophysiology, like a tetralogy of Fallot. There is like, so this child is in cyanotic spell. So as we can see, the basic spell management, we should be, from the history we can understand this is spell, and then we should go like not doing blood gases right at that point, just basic spell management, giving oxygen, giving proper analgesia, morphine, giving fluids, correcting acidosis, and also giving beta blockers. So that comes as a part of the routine ICU or emergency management for a cyanotic spell. So this baby was very sick, so we had to tube, and then we have shifted the baby to the ICU. And now now like as far as the fluid and drugs management, we need to give fluid boluses, and we need to optimize the hemodynamics, needing some peripheral vasoconstrictors like phenylephrine or noradrenaline, giving morphine or ketamine, giving appropriate oxygen to targeting saturations around 70 to 75, and then what are the triggers, like the child had fever and loose stool, so correcting the infection. And then we need to see that what we can do with the spell, like is this child continuous spell, what is happening, like whether the child needs a shunt or a stent. So, and any clarification from emergency residents, this we specifically wanted to put forward, that we don't want to do blood gases and prick the child. It can be a clinical diagnosis only, because pricking the child, that can also continue the vicious cycle. So we need to provide analgesia and not doing blood gases right at that point.
So this is our message to do that there is, cyanotic spell is a completely clinical diagnosis. There is no need to document with a blood gas. Blood gas is unnecessary. Whenever you prick the child, that will again cry, then again the worsen the spell only. So it's a clinical diagnosis. No oxygen will not help. No blood gas will help. So you have to manage like a spell. So fluids is the mainstay. Already the child had a history of loose stool, so there must be dehydration to trigger that spell. So fluids, it may be 20 ml per kg up to 3 boluses, 60 ml per kg can be given. That will help the child. And if so much sick like this child, intubation and ventilation to calm, to sedate, to paralyze will help the child. So next I'll come to Amitabh sir for the cardiac diagnosis. Like what are the clinical pointers to reach a diagnosis, some echo assessment, and then plan for intervention or surgery.
The clinical pointers is a child with a gross cyanosis. So there can be two interpretations. Either, as she said, this can be a tetralogy of Fallot who is presenting a cyanotic spell. So basically the right ventral outflow tract has been obstructed and there is no forward flow through the pulmonary artery and the gross pulmonary blood flow is less. So this is the commonest clinical scenario. There might be another caveat. This can be a state of pulmonary atresia as well, where a duct was actually supplying the pulmonary artery from the aorta, but for some reasons the duct had not constricted during the immediate neonatal period. It has somehow drawn to this 3 month and now the duct has almost completely closed. So there are two caveats. Now we can, what she did was, we did the initial management, spell management, which will be similar in case of tetralogy of Fallot or in the case of pulmonary atresia. Now we go to the surgical thing. The whole gamut stands on two things. That is the whole pediatric cardiology thing. The anatomy of the pulmonary arteries. If we feel that it is a tetralogy of Fallot, the pulmonary artery sizes are good sized and the surgeon can do a complete repair, that is a intracardiac repair, then this child may as well go for an intracardiac repair depending on the institutional policies and the surgical lookout. Suppose the surgeon says that we won't do a complete repair but we will go for a BT shunt, then also some institutes follow that one. If that is not done, the interventional people can do an RVOT stenting, which is a new thing and which is in vogue for the last almost 5 to 10 years. We have done quite a few. Plenty of people do it nowadays. So we put a stent in the right ventral outflow tract to maintain the forward flow until the patient gains some weight and obviously gets rid of the cyanotic spells and the branch pulmonary arteries attain the size which is amenable for an intracardiac repair. Suppose this is a case of pulmonary atresia and we go for a CT scan to find out the pulmonary artery anatomy. If they are confluent and there is a duct, even if the duct is closed, we can open it through the wires and put a ductal stent to get rid of the cyanotic spells like scenario. Thereafter, when the branch pulmonary arteries grow up, we can go for the second stage of surgery. Intervention and surgical, these are the ones which I described. These are the standard ones which are followed all throughout the world nowadays.
So thank you sir for this elaboration. So there is one clinical pointer I again wanted to emphasize, that there is no murmur in this child, which may happen in pulmonary atresia, which may happen in TOF also in spells. So we all know in spell a TOF may not have a murmur. So not finding a murmur may not exclude the diagnosis of TOF. It may be a TOF, that time due to spasm, infundibular spasm, whatever it is, murmur may not be found. So ultimately this kid is diagnosed with pulmonary atresia and there was a small tiny PDA. So he had gone through a ductal stenting. So I am just showing few videos to show. So first video is that there is the angiography of aortic arch showing that PDA is flowing, a small PDA, and the second video is showing that a stent is being placed in the PDA so that the PDA remains open. So this is nothing but PDA stent or ductal stent, and this is the final result. After the stent is being placed, the PDA is well open to at least get rid of the spells for the time being, until the definitive surgery is being planned. In the PDA. To keep it open. So that the pulmonary blood flow is okay, reasonably okay to decrease the cyanosis. If there is complete pulmonary atresia, we cannot open. Sometimes there may be long segment atresia, sometimes there may be short segment, but if only membranous atresia, there is something called membranous atresia. There is only a membrane that can be punctured and dilated. Otherwise, in long or short segment atresia, we cannot just establish the connection between RV and pulmonary artery. So we have to put this PDA stent.
If some connection has already been existent but has somehow been cramped or it has closed off, then you can open it to the wire. But a connection which has not been present or has not developed, then we cannot do anything with the cath lab. Then we have to take help of conduits later on during the surgery. That is an extra connection which you have to place from the right ventricle to the junction of the pulmonary artery.
So now this child has gone through a PDA stent. So I'll come to Dr. Shubhadeep for the post-op issues and ICU care in case of a ductal stent.
Yeah, so again, there are a few important points to remember. First is regarding what are the complications which can happen, right? As an intensivist, we need to be very, very vigilant about the limb through which the cardiologists have went in and put a stent, right? So there can be limb ischemia. So that is something we need to very closely monitor in the post-interventional period. And the other thing is whether the stent is flowing well, because again, this stent are very small. It could be a 3 millimeter stent, it could be a 4 millimeter stent, but there is a total chance that this stent can thrombose off, right? So we, after we are sure that the patient is not bleeding much after a few hours of this intervention, or even if the patient had undergone a BT shunt operation, it's a similar procedure, right? But just done surgically, we usually start them on heparin. And we target, depending upon the institutional policy, in our unit what we follow is we target heparin depending on the ACT values, right? So that is another thing. The other thing is about balancing the circulation. So what do I mean by that is, now you have a duct which has been opened up. So what is the duct? It's essentially a connection between your systemic side and the pulmonary side. So basically a connection between your aorta and the pulmonary artery. Now the idea is in this physiology that I want to direct more blood into the pulmonary artery. But I cannot, can I dictate that? I cannot dictate that probably. Blood will preferentially go where? Physiologically, blood will preferentially go into a side where there is less resistance. So blood through the PDA has two ways to go. It can either go into more into the aorta or the systemic side. It can also go into the pulmonary side. Now blood will go where? It will depend upon the relative resistance, difference of resistance between the two sides. So now, many times when we, like an intensive care person who doesn't have much idea about this physiology, so what we want is, we want a good blood pressure. The idea is that we want good urine output, we want good perfusion pressure. But in doing that, what can happen is, we can through the duct, as now you have got very high systemic blood pressure, so less blood will go into the systemic circulation and more blood will go into the pulmonary circulation. Up until a certain point of time, this is okay, because the child was very cyanotic and we want the saturation to be high. But if it so happens that a lot of blood is going to the pulmonary circulation, then very less blood will go into the systemic circulation. As a result of which, you can have somebody who is probably saturating in the 90s, sometimes 95, 96, but you will see that the urine output is dropping. You will see that the pedal pulses are becoming feeble, because now you are having less blood going to systemic circulation. Okay. So at some point of time, in the initial period, these children like to be, what I say is, tight and tanked, which means that you need to target a little bit of high blood pressure for that blood to be driven into the pulmonary side. You need some fluid boluses, but once that period is over, once you are getting consistently good saturation, then you have to look after reducing the afterload, reducing the blood pressure, so that this does not so happen that your systemic perfusion is hampered. So at that point of time, we introduce some agents like milrinone or something else in order to reduce the afterload, so that now there is a balance, whereas a good amount of blood is going to the pulmonary circulation, also a good amount of blood is going to the systemic circulation.
So, okay, so what all we need to monitor during this period?
So, as I said, like the few things, one by one I would say limb perfusion. I would look at the limb, okay. Saturation, whether being picked up from the limb, where may I put a saturation probe, that's also an important sign, other than the skin changes, color changes, and the discoloration. Number 2, whether there is a lot of bleeding, because during introducing a stent, they would use heparin. So whether I'm having a lot of bleeding. Third is clinical markers of good perfusion, whether I'm having good urine output, whether my pulses are good, whether my lactate values are settling down or the lactate is going high, and my saturation. Typically, I want a saturation in the mid-80s after a ductal stent, not more than that.
So saturations targets are very important. In this case, we had a child who doesn't have like very less pulmonary blood flow. We have increased the pulmonary blood flow by stent. Now it cannot be so high that it leads to increased flow and pulmonary edema again, because the pulmonary arteries are already hypoperfused. Now we have put a stent, the pulmonary blood flow has increased, so we have to just regulate the flow. It cannot be so high that it will go into pulmonary edema again. So in that case, the saturation target should be around 80, 85, not more than that. I have kept this case because now more cases are done. These ductal stenting cases are done, and the kids are coming back to our routine NICU and PICU where a dedicated cardiac ICU is not there. So pediatricians also have to manage this scenario. In recent future, it will increase. So any questions from the audience, or I'll move into the next case. So I think I'll move on to the third case. So this is a 5-year-old boy who presented to emergency with sudden onset palpitation, which is continuing for last 3 hours. He is dyspneic and there is excessive sweating. Heart rate is 200. Saturation is 76% in room air. CVS examination is single S2 with no murmur. Now on history, he underwent cardiac surgery, some cardiac surgery 2 years ago, but there is no documents available with the parents. But as per mother, one more surgery is pending, which will also not completely cure the child. So this much information do we have. Now I will come to Dr. Subodip. So what next? For emergency management, what to look for?
So I would look at the rhythm. Okay, so this child is tachycardic. So I would want to have an idea of the rhythm, whether this is a sinus tachycardia or something else. So getting a 12-lead ECG. At the same time, how is the child's perfusion? Okay,
so these two questions are needed. One is what is the rhythm. Second is hemodynamic status of the child. Every management will depend on these two things.
Yeah. So for me, what I can say is this is of course tachycardic. The child is tachycardic. The child has got a narrow complex tachycardia. I cannot completely make out the P waves, although it might be difficult in a tachycardic child to make out the P waves. And what I can appreciate is probably the RR intervals are quite fixed. And with the given background that the child had a cardiac surgery and probably another surgery is pending, like I don't want to name a cardiac surgery, but probably if I have to name one, this could be a Glenn surgery. So we know that these children are very prone to having different forms of supraventricular tachycardia, atrial ectopic tachycardia. So as a cardiac intensivist, for me, this is an supraventricular tachycardia probably. And then depending upon the perfusion, I will decide how to approach.
So his BP is 72/50.
Yeah. So for a 5-year-old child, this is slightly on the hypotensive side. So I would say this is an SVT with poor perfusion. And so my first line of management will be, if I have the facilities of cardioversion, I will cardiovert. If I don't, then immediately cannot get a defibrillator, I would still use adenosine. Of course, there are techniques of giving adenosine. I'm not going into that. But if I have the facilities of cardioversion, I will straight away go for cardioversion.
So dose of cardioversion in this SVT?
So 0.5 to 1 joule per kilo will be my initial dose. And if I have to use again, then I will be using 2 joules per kilo.
So in a SVT with poor perfusion or hemodynamic instability, the first treatment of choice is cardioversion. If cardioversion facility is not available, we can try adenosine with a thing in mind that he may go into cardiac arrest and we may have to do CPR. So now, Amitav sir, about the cardiac part, what is your idea about the operation the underlying CHD or congenital heart disease, and what are the congenital heart diseases which are commonly associated with arrhythmia, like SVTs?
As the mother has already depicted, that the child has undergone one surgery, but one surgery is still left. So most probably this child, we are dealing with a case of a single ventricle where the heart cannot be repaired totally, but a palliative surgeries can be done. These kind of surgeries were unknown of about 50 years back, but for the past 50 years they have been done in different parts of the world, where the surgery consists of 2 or almost 3 parts, sometimes including a stent or a BT shunt in the initial part. So after a Glenn surgery, most probably the child has undergone a Glenn surgery. The single ventricle per se might have different types of anatomies, which gives rise to different types of different dilatations of the atria, and obviously they can have ventricular arrhythmias as well if the ventricle is dilated. In this particular case, we are having a supraventricular tachycardia because by virtue of the distribution of the fibers, current fibers, and as well as the different pressures they undergo, which leads to this kind of a foci, which can be found in the atrium or around the pulmonary veins, whichever may be the cause. Now, the operation itself, the Glenn shunt itself, lies on a very, very delicate balance of the lung pressures, that is the pulmonary artery pressures and the systemic pressures. If they are slightly down the way, that means the pressures are rising, then there can be certain debacles which we are not discussing at the moment. The underlying congenital heart diseases, there is a single ventricle kind of a scenario. They have a good quality of life, not totally comparable to the single ventricle, but they can have a life even up to 5th or 6th decades. The first generation of patients, they are now lying in the 5th decades, so probably we have some more attempts to see how they behave. The CHD-associated arrhythmias, they can be divided into 2 parts. One is the associated arrhythmias which they can have from birth. The other one is the post-operative arrhythmias. The ones which they can have from birth tends to be different types of supraventricular arrhythmias and even ventricular tachycardias and ventricular arrhythmias, which may be treated with medications in the first instance, and thereafter we can undergo some radiofrequency ablation wherever the merit of the case be. Post-operative arrhythmias, the most dreaded one is the junctional ectopic tachycardia, which can arise even after Glenn or even a Fontan surgery, and that takes we have to take special precautions starting from the temperature of the patient to the institution of certain decreasing temperature protocols or even some amiodarone, which can take almost about 12 to 24 hours sometimes to get totally controlled, fully controlled. But once they set in, they happen to destabilize the patient hemodynamically, and the intensive care and the cardiology and the surgical team have to act in synchrony so that the child can come out from there slowly.
So thank you. What I want to add is that there are some congenital heart diseases which are more prone to cause SVTs, like we know Epstein's anomaly, atrioventricular septal defects, some single ventricle physiology like heterotaxy. These subsets are very prone to have accessory pathways and causing SVTs. So now my last question to Dr. Shatarupa. This kid ultimately got admitted to PICU, and there are recurrent tachycardia episodes in the PICU also. So now how to manage the case? The rhythm in the PICU is like this.
So as we can see now, this is a wide complex tachycardia. So again, like back to the basics, like how is the perfusion of the child? Is it a stable VT or an unstable VT? Is it a VT with pulse or VT without pulse? So as per our ABCDE management, if the child is unstable, we need to tube and support with ventilation. And if it's as per the perfusion is concerned, if it is a VT without a pulse, definitely we need to give shock, 2 to 4 joule per kg. And if it is a VT with pulse, we can cardiovert. And if the most important thing is that what is the underlying what are the electrolytes? We need to check if the electrolytes are normal, and what is the temperature. As part of the routine post-operative care, when we have kids with arrhythmias, we need to control the temperature. Sometimes we might maintain a low normal temperature around 36 to 36.5, and correction of electrolytes, particularly magnesium, and see for the other electrolytes like potassium. And then for a VT with pulse and without pulse, we can cardiovert and we can give shock, or we can try amiodarone or even lignocaine. So all depends on, obviously we can give magnesium, that is for torsades, we need to give magnesium. Sometimes for this VT, if the kids can be very unstable, they can have a very poor cardiac function, and even we have a VT with pulse, but the child is hemodynamically very unstable. They may go into the extent of needing an extracorporeal life support. So these are things that should be kept in mind, that we have those options, and we need to opt for them at times. But also, sir, any role of EP study and radiofrequency ablation, as you have already told. Dr. Chattopadhyay can add to that. Sir?
Yeah, one important point we should remember is the spectrum which we are discussing here is the tachycardia spectrum. But the other spectrum, there might be bradycardia as well. As you told, the common AV canal defects or some other single ventricles, we might land up in bradycardia to the extent complete heart block. And in those situations, if it is a bradycardia, the complete heart block, the single ventricle physiology doesn't work well. So we might have to replace them with a pacemaker, and obviously with the pacemaker and the single ventricle, the situation becomes yet more complex and has to be handled very, very gently, so that the heart rate, that's a main determinant of the cardiac output in children, is adequately maintained. So both the spectrums need to be adhered to very, very strictly.
Sir, anything to say about there are recurrent episodes of VT in ICU. So if the VT episodes continue even after we correct the correctable things, what are our options in refractory VT?
There are several options. The simplest protocol which we follow is, as she said, we correct the electrolytes first, especially the magnesium, calcium and other electrolytes. We start a lignocaine drip before amiodarone, because as a membrane stabilizer, sometimes it does work, mostly it works, and at least gives us a ground for the other medications to act. If it doesn't go off at all, then we start amiodarone. He prefers a particular regime, that amiodarone, instead of the 5 milligram per kilo, we give in 5 different LQs of 1 milligram per kilo. The main reason being, amiodarone is a very, very dangerous drug, because it has a very long half-life and anything wrong cannot be reverted immediately. We tend to, sometimes we give a 5 milligram per kilo, instead of for the stipulated period of 15 minutes, we tend to deliver it over a long period of about 1 hour. So that whenever we see something adverse happening, we immediately stop the medications. Amiodarone has a deleterious effect on the AV node, that it can cause an irreversible block, which is unsurmountable even by pacemakers. So amiodarone, on the one hand, it is a pan antiarrhythmic, it is good, but on the other hand, it has several side effects. So we tend to use it with caution. With amiodarone, if it comes down, we tend to go into the oral version. Sometimes, very sustainably, the beta blockers, long-acting beta blockers like metoprolol can also be used in these conditions. There are controversies whether they can be used in supraventricular or ventricular things, but they can be used in this. Calcium channel blockers like verapamil or liltelcim can be used, but we are slightly cautious in using them below the age of 1 year. Flecainide is a new medication which has been used in either singularly or in combination with other medications. They stabilize different membranes and also at the class 1C agent, which has very good results in controlling all this type of arrhythmias. Sotalol has been used sparingly to all this medication. It has class beta blocker, class 2 and class 3 agents, and can be used in all these cases. Whatever said and done, if the child is on regular follow-up, we have to monitor the ECG, especially the QTC, so that they do not go out of bounds.
Okay, thank you. And the last resort, if all the medications fail, I have seen cases of VT storm then we may need to have some emergency sympathectomy also, like left sympathectomy. If that doesn't work, then bilateral sympathectomy. Sometimes this, in the extent of that, we can have to go in some cases. So any questions from the audience? So I think we are concluding the session.
So I'll request the chairperson to give the mementos to the moderator, Dr. Shatanik Sarkar, and the panelist, Dr. Amitava Chattopadhyay, Dr. Shubhodip Das, and Dr. Shatarupa Mukherjee. I'll request Dr. Shatanik Sarkar to please hand over the mementos to our chairpersons. Shatanik, please give the memento to our, and this is, here we conclude the session, but don't leave, because we have got a cultural program I think you will be enjoying, and with that there is cocktail dinner. So you cannot miss it. You can't miss it. I'll request Dr. Torun Samanto, our secretary. হ্যাঁ ফুচকা ঝালমুড়িও আছে তো I request our secretary Dr. Torun Samanto to come over the dais and just address for the valedictory.
Thank you all the delegates for coming to today's 18th Howrah Academic Pediatrics program. Now we are on the end of the program, but not the end. We are going to our second phase, that is the cultural evening. So all are requested to remain here and have some refreshment, music, songs, and followed by dinner and drinks. Thank you all for joining us today and for this memorable day of Howrah Academy of Pediatrics. Thank you.
Senior pediatrician Kekadi, we have Joydipto Da, Moshumidi, and we have Shatanik. He's a new entry to Howrah Pediatrics, and he's also a very good guitarist and a singer also. And today, to help us, we have some musicians with us. We have on the octopad Mr. Debroy, Jatati Debroy. On the keyboards, we have Shubhojit. And on the hand sonic, we have Mr. Siddhartho. So welcome all of you, and we begin with a bang.
Hello, hello.
Hello.
Hello. Hello.
প্রথমে বলে দিই এই গানটা আমরা গাইছি ফর দ্য ফার্স্ট টাইম, আমাদের কোনো রিহার্সাল নেই। এমনিতে কোরাস গ্রামে বা গ্রুপ সঙ্গে ছাড়া ধরা এগুলো সুতরাং একটু এদিক ওদিক হতে পারে। ঠিক না 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 শুনতে শুনতে শোনাটাও ব্যাপার আছে না, শুনতে কেমন লাগবে। দীপাঞ্জন দা এসে গেছে, আবৃত্তি। ওয়ান টু থ্রি বলবে। আনন্দ ধারা বহিছে ভুবনে, আনন্দ ধারা বহিছে ভুবনে, দিন রজনী কত অমৃত রস উথলি যায়, আনন্দ
জ্যোতি আনো ঘরে রবি শশী অঞ্জলি ভরিয়া সদা দীপ্ত রহে অক্ষয় জ্যোতি নন্দ ধরে জীবনে কিরণে আনন্দ ধারা বহিছে ভুবনে। বসিয়াছো কেন আপন মনে স্বার্থ নিমগ্ন কি কারণে? বসিয়াছো কেন আপন মনে স্বার্থ নিমগ্ন কি কারণে? চারিদিকে দেখো চাহি হৃদয় প্রসারী ক্ষুদ্র দুঃখ সব তুচ্ছ মানি। চারিদিকে দেখো চাহি হৃদয় প্রসারী ক্ষুদ্র দুঃখ সব তুচ্ছ মানি। প্রেম ভরিয়া দাও শূন্য জীবনে আনন্দ ধারা বহিছে ভুবনে আনন্দ ধারা বহিছে ভুবনে। দিন রজনী কত অমৃত রস উথলি যায় অনন্ত জীবনে আনন্দ ধারা বহিছে ভুবনে আনন্দ ধারা বহিছে ভুবনে।
Now we have a very different event. Performance by Tejoshini. It's a dance performance. And we were so amused by this performance when we saw it for the East Zone Pedicon that we requested her that we should have again, once again. So she has obliged her with this.
তোমার ঘরে বাস করে কারা ও মন জানো না, তোমার ঘরে বাস করে কারা ও মন জানো না, তোমার ঘরে বসত করে কয়জনা মন জানো না, তোমার ঘরে বসত করে কয়জনা। একজনে ছবি আঁকে এক মনে ওরে মন, আরেকজনে বসে বসে রং মাখে ওরে মন। একজনে ছবি আঁকে এক মনে ওরে মন, আরেকজনে বসে বসে রং মাখে। ও আবার সেই ছবিখান নষ্ট করে কঞ্জনা কঞ্জনা। তোমার ঘরে বসত করে কয়জনা মন জানো না, তোমার ঘরে বসত করে কয়জনা।
ময়না ছলাক ছলাক চলে রে পিছন পানে চায় না রে মন দুপুক দুপুক করে রে তর লাগিউ তলা রে শাল পিয়ালির বন্থিকা ওই জংলা নদীর পারে হেতে তর সঙ্গ লই ঘুর ঘুর করুম এই বাসনা প্রাণে ময়না ছলাক ছলাক ময়না ছলাক ছলাক চলে রে পিছন পানে চায় না রে মন দুপুক দুপুক করে রে তর লাগিও তলা রে শাল পিয়ালির বন্থিকা ওই জংলা নদীর পারে হেতে তর সঙ্গ লই ঘুর ঘুর করুম এই বাসনা প্রাণে ময়না ছলাক ছলাক
প্রেম রাঙা মোর কবিতা সুরের অন্তরে ঝিরঝিরি ঝরনা ধারায় নতুন রং ঝরে প্রেম রাঙা মোর কবিতা সুরের অন্তরে ঝিরঝিরি ঝরনা ধারায় নতুন রং ঝরে সবুজে সবুজে হৃদয় কেমন করে সবুজে সবুজে হৃদয় কেমন করে ও মোর দিন উড়িয়া যায় রে দিন উড়িয়া যায় কন্যে রে তোর ভাবনা গুনগুনিয়ে যায় রে গুনগুনিয়ে যায় ও মোর দিন উড়িয়া যায় রে দিন উড়িয়া যায় কন্যে রে তোর ভাবনা গুনগুনিয়ে যায় রে গুনগুনিয়ে যায় তোর স্বপনের ভ্রমরি মোর প্রেমেরও প্রহরী তোর স্বপনের ভ্রমরি মোর প্রেমেরও প্রহরী হৃদয়ের বাগিচায় নাচি নাচি ঘুরি ঘুরি উড়ি উড়ি উড়ে যায় কোন হারানোর ঠিকানায় আগুনের মোহনায় মন মাতানো মহুয়ায় রঙ্গিন বিহুর নেশা কোন আকাশে নিয়ে যায় আগুনের মোহনায় আগুনের মোহনায় মন মাতানো মহুয়ায় রঙ্গিন বিহুর নেশা কোন আকাশে নিয়ে যায় আগুনের মোহনায় আগুনের মোহনায় আগুনের মোহনায়
খুবই মুশকিল being the host also being the participant over there also আর সকাল থেকে অনেক কিছু বলে বলে গলাটা অলমোস্ট মনে হচ্ছে যাবে না so Sanjay da will be playing the electric guitar but in the meantime he is setting up his instrument we'll go ahead with the vocals so
since she is going to do the honors with the vocals, let me introduce her. Dr. Indu Surana in front of you. Madam, come here.
So the first song which I am going to sing, এটা মান্নাদের গাওয়া গান আগেও আমি গেয়েছি এটা and I think I'll dedicate this song to Howrah Academy of Pediatrics in fact because I love this society and in fact to the very person who inducted me into Howrah Academy of Pediatrics. So he's here, Shapanda is here. So and it's not only Howrah Academy of Pediatrics, Shapanda gradually brought me to West Bengal Academy of Pediatrics and gradually the journey began. And so in the same way to continue the legacy, we also try now all the youngsters who are here in Howrah, we want you to come ahead because we are already there for you and we want that there should be more active people in our society to do great things in future. জলের বোতলটা দিয়ে দেবেন এটা কি মিউজিক নেই আর আশার হাত বাড়াই তোমারই জন্য হয়েছি প্রেমে যে বন্য জানি তুমি অনন্য আশার হাত বাড়াই যদি কখনো এই প্রান্তে চেয়েছি তোমায় জানতে শুরু থেকে শেষ প্রান্তে ছুটে ছুটে গেছি তাই আমি যে নিজেই মত্ত জানি না তোমার শর্ত আমি যে নিজেই মত্ত জানি না তোমার শর্ত যদি বা ঘটে অনর্থ তবু তোমায় চাই হয়তো তোমারই জন্য হয়েছি প্রেমে যে বন্য জানি তুমি অনন্য আশার হাত বাড়াই আমি যে দুরন্ত দু চোখে অনন্ত ঝড়ের দিগন্ত জুড়ে স্বপ্ন ছড়াই তুমি তো বলনি মন্দ তবু কেন প্রতিবন্ধ তুমি তো বলনি মন্দ তবু কেন প্রতিবন্ধ দেখো না মনের দ্বন্দ্ব সব ছেড়ে চলো যাই হয়তো তোমারই জন্য হয়েছি প্রেমে যে বন্য জানি তুমি অনন্য আশার হাত বাড়াই যদি কখনো এই প্রান্তে চেয়েছি তোমায় জানতে শুরু থেকে শেষ প্রান্তে ছুটে ছুটে গেছি সঞ্জয় দা ইজ রেডি আই থিঙ্ক শেষ করার কিছু নেই লেট আস একটু আমি রেস্ট পেয়ে যাব আমি রেস্ট ইউ গো উইল বি ভেরি হ্যাঁ এটা এখানে Sanjay da, introducing you. So Sanjay da will be playing on the steel guitar. This is a modern song, I can say, not a retro one, sung by.
You all come in front of the monitors. If you don't hear yourself, you will not be able to see.
No, we are able to hear ourselves. Actually, our
Hello.
voice,
Hello.
my voice has actually gone down since the morning. Hello? 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 D আছে আলো আলো রং জমকালো চাঁদ হয়ে যায়, চেনা শোনা মুখ জানা চেনা হাত ছুঁয়ে যায়, ধীরে ধীরে ঘুম ধীরে ধীরে গান রেখে যায়, কিছু মিছু রাত পিছু পিছু টান ডেকে যায়, আজও আছে গোপন ফেরারি মন, বেজে গেছে কখন সেই টেলিফোন, চেনা শোনা মুখ জানা শোনা হাত রেখে যায়, ধীরে ধীরে ঘুম ঘিরে ঘিরে গান ডেকে যায়, আজও আছে গোপন ফেরারি মন, বেজে গেছে কখন সেই টেলিফোন। ছোট ছোট দিন আলাপে রঙিন নুরির মতন, ছোট ছোট রাত চেনা মতার পলাশের বন, আহা ওগো চলো ঘর খুঁড়ো কুটময় ছিলে কোঠা কন, আহা ছোট ছোট দিন আলাপে রঙিন নুরির মতন, ছোট ছোট রাত চেনা মতার পলাশের বন, আহা ওগো চলো ঘর খুঁড়ো কুটময় ছিলে কোঠা কন, কথা ছিল হেঁটে যাব ছায়া ফেরারি মন, বেজে গেছে কখন সেই টেলিফোন, পিছু পিছু টান পিছু পিছু টান, আলো আলো রং জমকালো চান ঝলমল, আজও আছে গোপন ফেরারি মন, বেজে গেছে কখন সেই টেলিফোন।
Whenever the feedback sound comes, raise phones.
গুঁড়ো গুঁড়ো নীল রং পেন্সিল জোছনার জল, ঝুড়ো ঝুড়ো কাছ আগুন ছোঁয়াচ ঢেকেছে আচল, আহা ফুটপাতে ভিড় জাহাজের ডাক ফিরে চলে যায়, আহা
ঘাটে ভিড় জাহাজের ডাক ফিরে চলে যায় কথা ছিল হেঁটে যাব ছায়া আজও আছে গোপন ফেরারি মন বেজে গেছে কখন সে টেলিফোন আলো আলো রং জমকালো চাঁদ ধুয়ে যায় চেনা শোনা মুখ জানা শোনা হাত ছুঁয়ে যায় আজও আছে গোপন ফেরারি মন বেজে গেছে কখন সে টেলিফোন আহা হা 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 হা
There is a Hindi song. I'll sing that Hindi song and then I will take some big break and we'll have the music. So this is a song by Lata ji. Kashi said 3 बार. So now we have our next vocalist. I'm done for now. Shatanik will join. Okay. Saurabh, in the meantime, you can adjust your instrument. And after this, you can come.
Hindi song from the movie Life in a Metro. So, hello.
चुपके से कहीं धीमे पाँव से जाने किस तरह किस घड़ी आगे बढ़ गए हमसे राह में, पर तुम तो अभी थे यहीं। कुछ भी ना सुना कब का था गिला, कैसे कह दिया अलविदा। जिनके दरमियाँ गुजरी थी अभी, कल तक ये मेरी जिंदगी, लो उन बाहों को, ठंडी छाँव को, हम भी कर चले अलविदा। अलविदा अलविदा अब कहना और क्या, जब तूने कह दिया अलविदा। अलविदा
ডাক্তার সায়কের পুরো নাম কি? শতানিক সরকার। শতানিক সরকার সবাইকে একদম মানে স্ট্যান্ডিং ওভেশন দিতে বাধ্য করিয়েছে। হ্যাঁ, মানে অলমোস্ট দ্য এন্টায়ার হল গেভ ইউ আ স্ট্যান্ডিং ওভেশন। তো ডক্টর
এত সুন্দর সুন্দর সমস্ত গান, নাচ, মিউজিকের পর রিসাইটেশন কতটা ভালো লাগবে আমি বুঝতে পারছি না। যাই হোক, বহুশ্রুত একটি কবিতা আমি বলার চেষ্টা করছি। হ্যালো, বহুশ্রুত একটি কবিতা কবিগুরুর আমি বলার চেষ্টা করছি, প্রত্যেকেই শুনেছেন। আফ্রিকা। উদ্ভ্রান্ত সেই আদিম যুগে স্রষ্টা যখন নিজের প্রতি অসন্তোষে নূতন সৃষ্টিকে বারবার করছিলেন বিধ্বস্ত, তার সেই অধৈর্যের ঘন ঘন মাথা নাড়ার দিনে রুদ্র সমুদ্রের বাহু প্রাচী ধরিত্রীর বুকের থেকে ছিনিয়ে নিয়ে গেল তোমাকে। আফ্রিকা বাঁধল তোমাকে বনস্পতির নিবিড় পাহারায়, কৃপণ আলোর অন্তঃপুরে সেখানে নিভৃত অবকাশে তুমি সংগ্রহ করছিলে দুর্গমের রহস্য। চিনেছিলে জল, স্থল, আকাশের দুর্বোধ সংকেত, প্রকৃতির দৃষ্টি অতীত জাদু মন্ত্র জাগাচ্ছিল তোমার চেতনাতীত মনে। বিদ্রুপ করেছিলে ভীষণকে বিরূপের ছদ্মবেশে, শঙ্কাকে চাচ্ছিলে হার মানাতে আপনাকে উগ্র করে বিভীষিকার প্রচণ্ড মহিমায় তাণ্ডবের দিন্দুভিনী নাদে। হায় ছায়াবৃতা কালো ঘোমটার নিচে অপরিচিত ছিল তোমার মানব রূপ, উপেক্ষার আবিল দৃষ্টিতে এলো এলো ওরা লোহার হাত কড়া নিয়ে, নখ যাদের তীক্ষ্ণ তোমার নেকড়ের চেয়ে, এলো মানুষ ধরার দল গর্বে যারা অন্ধ তোমার সভ্যহারা অরণ্যের চেয়ে। সভ্যের বর্বর লোভ নগ্ন করলো আপন নির্লজ্জ অমানুষতা, তোমার ভাষাহীন ক্রন্দনে বাষ্পাকুল অরণ্য পথে। পঙ্কিল হলো ধুলি তোমার রক্ত অশ্রুতে মিশে, দস্যু পায়ে কাঁটা মারার জুতোর তলায় বিভৎস কাদার পিণ্ড চিরচিহ্ন দিয়ে গেল তোমার অপমানিত ইতিহাসে। সমুদ্র পরপারে সেই মুহূর্তে তাদের পাড়ায় পাড়ায় মন্দিরে বাজছিল পূজার ঘণ্টা। সকালে সন্ধ্যায় দয়াময় দেবতার নামে শিশুরা খেলছিল মায়ের কোলে, কবির সঙ্গীত বেজে উঠছিল তাঁর সুন্দরের আরাধনায়। আজ যখন পশ্চিম দিগন্তে প্রদোষকাল, ঝঞ্ঝা বাতাস রুদ্ধশ্বাস, যখন গুপ্ত গহ্বর থেকে বেরিয়ে এলো পশুর দল, অশুভ ধ্বনিতে ঘোষণা করলো দিনের অন্তিম কাল। এসো এসো যুগান্তের কবি, আসন্ন সন্ধ্যার শেষ রশ্মি পাতে দাঁড়াও ওই মানহারা মানবীর দ্বারে। বলো ক্ষমা করো হিংস্র প্রলাপের মধ্যে, এই হোক তোমার সভ্যতার শেষ পুণ্যবাণী।
तेरा आंचल लहराए, हर रात यादों की बारात ले आए। मैं सांस लेता हूँ, तेरी खुशबू आती है, एक महका महका सा पैगाम लाती है। मेरे दिल की धड़कन भी तेरी गीत गाती है। पल पल दिल के पास तुम रहती हो। कल तुझको देखा था मैंने अपने आंगन में, जैसे कह रही थी तुम मुझे बांधो बंधन में। ये कैसा रिश्ता है, ये कैसे सपने हैं, बेगाने होकर भी क्यों लगते अपने हैं। मैं सोच में रहता हूँ, डर डर के कहता हूँ। पल पल दिल के पास तुम रहती हो। जीवन मीठी प्यार ये कहती हो। पल पल दिल के पास तुम रहती हो।
এবার একটা ডান্স নাম্বার আছে, ডি ডি চলা যাতা হুঁ।
चला जाता हूँ किसी भी धुन में, धड़कते दिल के तराने लिए। चला जाता हूँ किसी की धुन में, धड़कते दिल के तराने लिए। मिलन की मस्ती भरी आँखों में, हजारों सपने सुहाने लिए। ओ चला जाता हूँ किसी की धुन में, धड़कते दिल के तराने लिए। ये मस्ती के नजारे हैं, तू ऐसे में संभलना कैसे मेरी कसम। तू लहराती डगरिया हो तो फिर क्यों ना चलूं मैं बहका बहका रे। मेरे जीवन में ये शाम आई है, मोहब्बत वाले जमाने लिए। ओ चला जाता हूँ किसी की धुन में, धड़कते दिल के तराने लिए। वो आलम भी अजब होगा, वो जब मेरे करीब आएगी मेरी कसम, कभी बैया चुरा लेगी, कभी हंस के गले से लग जाएगी, हाय मेरी बाहों में मचल जाएगी, वो सच्चे झूठे बहाने लिए ओ चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए, मिलन की मस्ती भरी आंखों में हजारों सपने सुहाने लिए ओ चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए, ला 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 ला, हे 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 ओ हो हो, हे 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 हे। अरे दीवानो मुझे पहचानो, कहाँ से आया मैं हूँ कौन, अरे दीवानो मुझे पहचानो, कहाँ से आया मैं हूँ कौन, मैं हूँ कौन, मैं हूँ कौन, मैं हूँ मैं हूँ मैं हूँ कौन, डॉन 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 डॉन। अरे तुमने जो देखा है, सोचा है, समझा है, जाना है, ओ मैं नहीं, ओ मैं नहीं, लोगों की नजरों ने मुझको यहाँ जो भी माना है, ओ मैं नहीं, ओ मैं नहीं, आवारा पागल को सौदा ही पागल को दुनिया में समझा है कौन, अरे दीवानो मुझे पहचानो, जरा पहचानो मैं हूँ डॉन। अरे यारों का हो यार हूँ, यारी में वो जान लुटा दे जो, मैं हूँ वही, मैं हूँ वही, दुश्मन का दुश्मन हूँ वो, दुश्मन के चक्के छुड़ा दे जो, मैं हूँ वही, मैं हूँ वही, तुम जानो ना जानो मैंने तो जाना है, महफिल में कैसा है कौन, अरे दीवानो मुझे पहचानो, कहाँ से आया मैं हूँ कौन, मैं हूँ कौन, मैं हूँ कौन, मैं हूँ मैं हूँ मैं हूँ डॉन 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 डॉन।
আবহাওয়া তো খুবই জমে উঠেছে, নাচের মতন গান আমার আপাতত মনে পড়ছে না, আমি একটি লালন গীতি পরিবেশন করছি। ও মিলন হবে কতদিন
আমার মনের মানুষের শানে আমার মনের মানুষের শানে করে সে জানে ও যে প্রেম করে সে জানে ও আমার মনের মানুষের শানে আমার মনের মানুষের শানে মিলন হবে কত দিনে ও মিলন হবে কত দিনে আমার মনের মানুষের শানে 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 আমার মনের মানুষের
আপনারা চেনা অডিয়েন্স বলে তাই
तेरे बिना जिंदगी से कोई शिकवा तो नहीं शिकवा नहीं शिकवा नहीं शिकवा नहीं तेरे बिना जिंदगी भी लेकिन जिंदगी तो नहीं जिंदगी नहीं जिंदगी नहीं जिंदगी नहीं तेरे
did so well. Now I'll request Shatanik. He will be singing a song with his guitar. So that will be just a performance with his guitar.
হ্যালো, এটা ঠিক আছে? সো এটা আজকের মতো লাস্ট পারফরমেন্স আমার। তো এই গানটা আমি ডেডিকেট করলাম আমাদের এই যে 2-3 মাস ধরে আন্দোলন করলাম আমরা এত ওয়েস্ট বেঙ্গলে। তো দিস সং ইজ ডেডিকেটেড টু আওয়ার অভয়া। আমরা নই গেরুওয়ালা, সবুজ কিংবা সাদা নীল, জেনে বুঝে বৃষ্টি ভিজে এই মিছিলে হও শামিল। আমরা নই গেরুওয়ালা, সবুজ কিংবা সাদা নীল, জেনে বুঝে বৃষ্টি ভিজে এই মিছিলে হও শামিল। পেটে পেটে কুট বুদ্ধি এটে মিশতে এলে যাও তফাৎ, আন্দোলনের শেষ থাকে না, থাকে শুধুই শুরুয়াত। গানে গানে রাত্রি দিন, হারমোনিকা আর গিটার, ভীষণ অস্ত্র শির দ্বারা আর মারণ অস্ত্র অহংকার। অধিকার নিজেকে চেনা, বুঝতে শেখা রাইট রং, ভোটের খেলা সাঙ্গ হলে গিটারটাই শিখো বরং। কলরব 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 কলরব
তরুণদা একটা আবৃত্তি করবে, and then we'll go with the instruments by Rohit.
খুব ভালো প্রোগ্রাম হচ্ছে, তার মাঝে মানে অ্যাকচুয়ালি আমরা যে স্টেজটা এসে পৌঁছেছি একটা মিডিল এজে, তো মিডিল এজে একটা ভেতরে একটা আর্তনাদ বা ক্রাই থাকে, যার উপর থেকে একটা কবিতা তৈরি হয়। তো এখানে একটা বাবা যা তার ছোটোবেলাকে ফেলে এসেছে, এখন সে বাবা হয়েছে, কিন্তু তার বাবার সেই শূন্যতাকে এখন অনুভব করছে, এবং তার বাবাকে, যিনি এখন কোনো দূর দেশে আছেন বা গ্রামে আছেন, তাকে একটা চিঠি লিখছে কবিতার মাধ্যমে। সেই চিঠি, তো কবিতার নাম বাবা, কবি প্রদীপ ভট্টাচার্য। বাবা, তোমাকে একটা কথা বলা হয়নি, অনেক দিন ভাবছিলাম, সামনে বলার সাহস নেই, তাই চিঠির মধ্যে লিখব। আমরা ভালোবাসি বাবা, তুমি কেমন আছো? কাজের লোক আসছে? জানো তো এই শহরটায় এখন অকাল বর্ষণ, সব কিছু যেন ভাসছে। বাবা, আমাদের সামনের বাগানটা এখন আর বাচ্চারা খেলাধুলা করে, নাকি সবাই বড় হয়ে গেছে, সবাই বন্দি ঘরে? বাবা, মনে আছে তোমার আঙুল ধরে দাঁড়ানো, প্রথম শুরু করি চলা? মনে পড়ে সেই ছেলেবেলায় দিনগুলো, জড়িয়ে থাকা তোমার গলা? ছোটোবেলায় তুমি আমার বাহন ছিলে, কখনো বা ঘোড়া, কখনো বা হাতি, তোমার পিঠে চড়ে ঘুরে বেড়াতাম, তুমিই ছিলে আমার সাথী। তোমার হাতেই হাতে করে, তোমার হাত ধরেই শুরু লেখা, তুমি আমার জীবন ছিলে, তোমার চোখেই বিশ্ব দেখা। মনে আছে বাবা সেই স্কুলের আবদার, টিফিনের জন্য 5 টাকা জেনে বুঝেই তুমি বুক পকেটে রাখতে, ভালো করে জানতে কে করছে ফাঁকা। সারাদিনের কর্মক্লান্তির পর তুমি ফিরতে, তখন আমি ঘুমে। মনে পড়ে অফিস ব্যাগটা ফেলে দিয়েই গুড নাইট সারতে, আলতো একটা চুমে। আমার আবার সেই আদর খেতে ইচ্ছে করছে বাবা, ইচ্ছে করছে তোমায় জড়িয়ে কাঁদতে। এখনও কি ভোরবেলা তুমি ওঠো তোমার গলা সাধ্যে? মনে আছে বাবা ছুটির দিনে সেই আবদার, আজকে কিন্তু চকোলেট না হলে আইসক্রিম দিতেই হবে, আজ কিন্তু রবিবার। কেরানির চাকরি করেও হাসি মুখে মিটিয়েছ সব বায়না। জানো তো বাবা, তোমার নাতিও এখন অনেক খুব বড় হয়েছে, পায় অনেক মাইনা, বাড়ি গাড়ি ফ্ল্যাট অনেক কিছু পেয়েছে, নাকি ও দেশে গিয়ে ওখানেও সুখেই আছে নিজের কাজটা নিয়ে। সময় মতো ওষুধ খাও তো বাবা, তোমার সুগারটা কিন্তু বড্ড বাড়া। খোকনকে জানো চিঠি লিখেছে 2 মাস, এখনও দেয়নি কোনো সাড়া। জানো তো বাবা, সেদিন ডাক্তার দেখালাম, আমারও সুগার ধরা পড়লো। গিন্নি বললে বাবার মতোই রোগের বংশ ধরলো। অনেক দিন পরে ওর মুখে তোমার নামটা শুনে বুক কেমন কেমন করলো, তাই চিঠি লিখছি বছর 10 পরে। ভেবো অভাগা ছেলে তোমায় মনে পড়লো, তোমার হয়তো চুল পেকেছে, মাথায় পড়েছে টাক, গায়ের চামড়াও আলগা হয়েছে, কোমরে হয়েছে ধরেছে বাঁক। সত্যি কথা বলতে কি জানো, আজ আমার জীবন সার্থক বাবা। তোমার ছেলে আজ তোমার মতোই শূন্যতা ঘিরে শুধু ছেলেবেলা ভাবা। এখন বুঝি আমাদের চলে আসার সময় তোমার ওই মুচকি হাসিটার মানে, হাজার কষ্ট জড়িয়েও ওই শূন্য হাসিটা এখন এ অভাগা বাপটাও জানে। জানো তো বাবা, এখন মাঝে মধ্যেই ঘুমের মধ্যে তোমার ওই ডাকটা, খোকন গেলি কই, কানে বাজে। মনে হয় আমার খোকনও বুঝি এসে বলবে চলে এলাম, আর ভাল লাগছে না দূরের ওই কাজ। যাই হোক বাবা, তুমি ভালো থেকো, তোমার বয়স তো আসে। সত্যি কথা বলতে বাবা শব্দটার মানে বোঝার পর আমি এখন তোমায় আগের থেকে অনেক ভালোবাসি। আমার করার ভুলের কোনো ক্ষমা নেই, কোনো প্রায়শ্চিত্ত নেই জানি, কিন্তু তোমার পাওয়া কষ্ট ও শূন্যতার অর্থটা আজ আমিও জানি। যাই হোক, আর বেশি কিছু লিখছি না বাবা, সুস্থ থেকো তুমি, তোমার পথেই পথ চলা শুরু হয়েছে, তোমার পথেই আমি। আজ আমি বুঝেছি বাবা শব্দের অর্থ হলো দায়িত্ব ভরে ভালোবাসা, যার মধ্যে কোনো স্বার্থ নেই, না আছে ফিরে পাওয়ার কোনো আশা। সবশেষে এটুকুই বলি সব সন্তানেরে, আমি যে করেছি ভুল সেটা তোমরা যেন না করো কোনো দিন, তাহলে হারাবে হয়তো একুল ওকুল। ধন্যবাদ।
আজ কিন্তু শতানিক যে প্রসঙ্গটার উত্থাপন করলো, আজকে কিন্তু সেই অভয়ার জন্মদিন। তো খারাপ লাগছে ভাবতেও যে আজকে আমাদের অনুষ্ঠান করতে হচ্ছে, কিন্তু তবু আমার মনে হয় তার জন্য আমাদের স্মরণ করা উচিত। 1 মিনিট আমরা দাঁড়াতে পারি? We want justice. We demand justice.
So we can have Rohit for some instrumental music, and then we have few songs left, 2 or 3 songs, which if we have time we can sing. is a vocal, we'll just keep changing the flavors now. So now we have a ghazal singer with us. Dr. Kalam wants to sing a ghazal. So welcome Dr. Kalam. I would
গজল ইয়ে করবো সিঙ্গিং করবো খুব পপুলার গজল ওইটা অ্যাকচুয়ালি একটা গজল না এটা একটা মুভি মধ্যে একটা হয়েছিল তো জগজিৎ সিংয়ের এটা ওকে बड़ी नाजुक है ये मंजिल मोहब्बत का सफ़र है बड़ी नाजुक है ये मंजिल मोहब्बत का सफ़र है धड़क आहिस्ता से ऐ दिल मोहब्बत का सफ़र है बड़ी नाजुक है ये मंजिल मोहब्बत का सफ़र है कोई सुन लेना ये किस्सा बहुत डर लगता है कोई सुन लेना ये किस्सा बहुत डर लगता है मगर डरने से क्या हासिल मगर डरने से क्या हासिल मोहब्बत का सफ़र है बड़ी नाजुक है ये मंजिल मोहब्बत का सफ़र है बताना भी नहीं आसान छुपाना भी कठिन है बताना भी नहीं आसान छुपाना भी कठिन है खुदाया इस कदर मुश्किल खुदाया इस कदर मुश्किल मोहब्बत का सफ़र है बड़ी नाजुक है ये मंजिल मोहब्बत का सफ़र है बड़ी नाजुक है ये मंजिल मोहब्बत का सफ़र है थैंक यू
So in continuum with this flavor of ghazal, I'm going to sing a song. Eta niche chole gache. By Rahat Fateh Ali Khan. I don't know I'll be able to do justice to this song or not. It's very ये আছে মিউজিক আছে তারপরে জি
Thank you. So after this, we are just on the verge of leaving, and the Raat is going away. So we have some Raat ke songs. So Raat ke liye. B. Raat baki to duet ache. So this is a Asha ji ka number. रात अकेली है बुझ गए दिए आके मेरे पास कानों में मेरे जो भी चाहे कहिए जो भी चाहे कहिए रात अकेली है बुझ गए दिए
জয়দীপ্ত দা তুমি করবে রাত বাকি আর নাহলে দেবজিৎ তুমি চলে এসো আগে তুমি দাঁড়িয়ে থাকো কাম
হ্যালো হ্যালো চেক রিভাবটা দিয়ে রেখো হ্যাঁ
So this is a song by Ashaji and Bapida. Yes. रात बाकी बात बाकी होना है जो हो जाने दो
दिलरुबा खुल के जरा दिल हार के रात बाकी बात बाकी ना है जो हो जाने दो सोचो ना देखो हाँ जाने जा मुझे प्यार से रात बाकी बात बाकी रात बाकी
Thank you. कब तक रहोगे बोलो? Because I see all of you going away. बैंड तो चलते रहेगा रात में. What sort of songs do you want to hear? Okay, yeah. A round of applause for them. He is Siddharth on the Hansonic. He is Jajati Debroy. He's on the Octopad. And he's Shubhojit. He's playing the keyboards. So what sort of songs do you want to hear? Some oldies? Melody? A little bit of Najagan and what? Melody. Okay. हाँ ठीक है हिंदी.
हसीना से